My case, my title I have kept as the cause of hepatitis searching high and low. So here is story of 52-year-old female homemaker who was resident of Pune. She had history of retroviral disease for last 10 years and she was on treatment for that from ART center. She presented to us in November 2022 with complaints of jaundice for 2 weeks and pedal edema and abdominal distension for 5 days. Going through her previous record, she was on treatment from 2010 to 2020. She was on ZLN regimen, and with that, her viral load was suppressed and CD4 was pretty good. Even in 2020, her medications were changed to TLD regimen. Until presentation, she was on that regimen. With that also, she was adherent to medication and her disease was well controlled. CD4 was 1300 and viral loads was suppressed. So this patient presenting to us, so we had done few investigations to for finding for the hepatitis. So her LFT shows the raised bilirubin with raised liver enzymes. That OTPTs were in the range of thousands. ALP was not. ALP was 118. INR was also elevated. USG abdomen showed coarse ecotexture of liver, and there was ascites also. At this point, also, as she was on medication and she was adherent, her viral load was still suppressed, and CD4 was 590. So her CD4 was controlled and CD4 was good and viral load was suppressed. So I'd like to discuss here what can be the cause of hepatitis in a patient who is on treatment, retroviral disease, who is on treatment for a long time. Her disease is well controlled and she has presented with acute hepatitis. Obviously, the first will be acute hepatitis, secondary to hepatitis A, B, C, and E. So we had worked for that, and all that workup was negative. Then rarely other viruses like EBV, HSV, and adenovirus, they can also cause this hepatitis, but it is rare. We did not evaluate further. Another common causes include like alcohol. So there was no history of alcohol also. Then if there is any history to rule out, as other causes were not there, we also tried to rule out autoimmune hepatitis. So workup for autoimmune hepatitis was also done, and that was also negative. So again, going through what things we are having. So patient was on ART, which was containing TLD regimen. So out of that, dolutegravir, can it cause hepatitis? That was the one question came to mind. So there was one drug, dolutegravir. So can dolutegravir cause this kind of hepatitis? Rarely in the studies, it has been mentioned that dolutegravir is associated with mild elevation of liver enzymes, that is less than 3 times. But in the trials, they observed that even with the comparator arm also, it was in the similar incidence was found. So it was little difficult to find that is that dolutegravir is causing this, and the mechanism of liver injury due to dolutegravir, that is also not, they have not, it is not given. So we tried to go through literature if this can be cause of it. Interestingly, there are few case reports in which we find few case report in which there is dolutegravir induced liver injury is mentioned. So out of this, there are four. I have kept here four reports. Out of these, three patients had fulminant hepatitis, two expired, and one required liver transplantation. So how did they do the diagnosis for it? Obviously, they ruled out all the possible causes, and afterwards, for one patient, they could do the biopsy, but otherwise, just with the temporal association and all that, it was done. And the duration, if we see after starting dolutegravir, when this patient have developed hepatitis, it was ranging from 1 to 8 months. So when the case which I highlighted here, after 8 months of starting dolutegravir, patient had developed a fulminant hepatitis, and for that she required liver transplantation. Uh, so if we see in our case, this patient from 2020 and she presented to us in November 2022. So nearly 2 years she was on that drug. So whether at this point can this cause it? But still we are having few reports of it. There is only drug which we could find at this point. So we had to consider that also as a cause for hepatitis. So she was treated symptomatic for her acute liver failure, and ART was withheld temporarily. Even though there are reports which are showing this kind of liver injury secondary to dolutegravir, but it is not such a common cause. We do not find in a practice that dolutegravir causing such kind of liver injury. So we tried again to rule out if there is any other there is any other cause that we are missing or any history we are missing. So we tried to find, when we trying to find the history, that time one of our relative came to us and she gave very interesting history. She told that this patient was started on one new tablet at her ARC center in October 2022, which she took for 2 to 3 weeks. And after that, she developed some abdominal discomfort and vomiting. She thought this tablet is causing her this problem. So she did not consult anyone and she stopped the medication on her own. And after that, she had this vomiting, jaundice, and or over last 2 to 3 weeks. And they thought that this might not be a significant history. So we asked them to bring the previous record where this tablet was started. If you see, this is the paper, if it is visible. So she was started on isoniazid preventive treatment. That was INH was started, INH 300. This was the tablet. So now, as we know, INH is a very common cause to common drug to cause such kind of fulminant hepatitis, rather than the dolutegravir. So considering here INH only as a culprit for this hepatitis, ART was restarted. Unfortunately, our patient later developed fulminant hepatitis. The relatives wanted to limit the treatment, and she succumbed to illness. So this case, unfortunately, there was bad outcome, but this case raised so many doubts in my mind and taught us so many things. First is INH-induced hepatitis. INH can cause this severe hepatitis due to multiple metabolites and this toxic free radicals. INH-induced hepatitis, it can be insidious. It can range from 2 weeks to 6 months, but it can be as early as 1 week and as late as 1 year also. Pattern, it is hepatocellular pattern with elevated liver ALT elevations and minimal ALP elevation. And as we know, there are no specific treatment for this. So what is this tuberculosis preventive treatment in this patient? Why we are giving this for all? So risk of TB infection, it is increases 16 to 21 types in patients with HIV co-infection with or without ART. So what are the guidelines for treating this for starting the TBT? So all individuals, irrespective of their degree of immunosuppression, whether they are on ART or not, if they have taken previously TB treatment or not, pregnancy, but all this after ruling out active tuberculosis. And contraindications like active TB disease, then any active hepatitis, peripheral neuropathy, and patient with a heavy alcohol consumption. Treatment options at present are 6 months of isoniazid, or recently what is added is 3 months of weekly regimen of isoniazid with rifampicin. So what benefits this TPT is giving us? This TPT, it increase the risk of developing this TB disease after initiation of TPT. It decreases 60% in normal, and it can be up to 90% people living with HIV. So even if patients were previously treated for tuberculosis, post-treatment TPT also has shown to be beneficial in reducing the recurrence in this patient. And obviously, treatment with this TB infection, it reduces the TB transmission in the community. But these are the benefits, but can we apply all this in our practice, and what are the challenges we face in our settings? So first and most important, like what we saw in this patient, was adverse drug reaction. Hepatotoxicity is such a serious adverse drug reaction, and these patients need to be counseled properly. The healthcare workers, patients, everyone, they should be aware of this problem, and this patient should be monitored regularly for this to avoid such adverse effect. Then there is development of resistance. If we see again we are telling to start the TPT for the in HIV population, it is after excluding the tuberculosis. So excluding active tuberculosis disease is a very important step in ruling for the initiation, before initiation of TPT. And how we are doing it? By screening for the 4S symptom, that is cough, fever, weight loss, and night sweats, and chest X-ray. Interestingly, it is given that although if chest X-ray is not available due to resource limited setting or something, that time chest X-ray is not mandatory, and lack of chest X-ray should not be a barrier for giving before starting the TPT. So if we see this thing in the settings where we find that even with the X-ray and with this screening also, many times there is extrapulmonary tuberculosis, subclinical tuberculosis. Many times we are not able to find this disease. So starting tuberculosis preventive treatment only with isoniazid in these patients is a difficult thing. So in some settings, it is very difficult to rule out active tuberculosis, and giving TPT can lead to the acquired resistance in this patient. Next is adherence to treatment. So even if you are starting the patient on tuberculosis preventive treatment, there is very poor adherence and early cessation of TPT. So so because of this, in these individuals where TPT is started, it can lead to development of drug resistance tuberculosis later. So this is very interesting study which was done in Karnataka. So they've tried to find out how many patients they tried to find out when if the patients who are started eligible for starting TPT, how many of them continued, or what was the endpoint for that. So out of nearly 3,900 patients were eligible to start TPT, but only 40% of them were started on TPT due to some problems which I will be mentioning. And the patients whom the TPT was started, out of them, when they did the observation, only 28% were on medication. So nearly 72% of patients have already stopped the isoniazid preventive treatment, and later the completion was around 80% of patients. So what are the problems and challenges in this setting? So most common was So for most, this is first is before non-initiation of hepatic. Why they were not able to start was drug stock out or non-availability, then training related challenges, proxy attendance and all. But for non-completion of TPT, which is an important point for us. So that was treatment interruption due to stock out. So what they had done in this study was they had interviewed all the staff anonymously and what was their opinion regarding what was the problem they faced that they had mentioned. So regarding drug stock out, one of the staff in that interview, she had mentioned that when we get the isoniazid stock, that time we start the patients on isoniazid preventive treatment from A to Z, and after a few months the stock gets over and we had to stop the treatment. Then adverse drug reaction, many patients, there is a lack of awareness also, and even among the patients also, due to some they feel some vomiting and some mild symptoms, they stop the treatment on their own, and obviously there is loss to follow up and death during the IPT. So these are real problems which we are facing in the if we start this for everyone, and if these are problems which need to be addressed, though there are so many benefits. And last but not important, which is drug interactions. So this thing also, patients who are on multiple on other comorbidities, they are on treatment of with some other medication. Drug interaction is also another thing which should be kept in mind. So what this case teaches us that is cause of hepatitis in HIV infected patients are numerous, and we really need to have a detailed evaluation for before getting to the diagnosis. We should remain aware to the possibility of drug induced liver injury with the drugs with excellent safety profile like dolutegravir. Then isoniazid, obviously, it can cause a fulminant hepatitis, and there is need of high index of suspicion before and early recognition, as it can be a life saving. And very important point, what I learned from this history is reviewing history is critically important for determining the etiology, especially when the patient is being treated at multiple centers and by multiple physicians. Thank you. Yes.
Check 1, 2. Was ultrasound abdomen done in this patient?
Yes,
And
sir. Yes, sir. Ultrasound abdomen was, yeah, ultrasound abdomen was done.
it should have been reflected over here because
Yes.
we are overlooking very important, two important signs. All hepatitis are not associated with ascites and pedal edema.
Yes, sir.
And if I'm not correct, I mean, if I'm not wrong, the platelet count was 5,30,000. Pardon me?
Yes.
Platelet counts.
Slides are not visible.
The plain and simple drug-induced hepatitis is not going to cause ascites and pedal edema, which we have overlooked in this case.
Yeah, sir, I would like to mention
if ultrasound was done, was there any portal vein thrombosis or something? Because platelet, there is a thrombocytosis in this patient. So we have just restricted it, discussion and presentation to that drug-induced only. What was the reason for those ascites and pedal edema?
There's already cirrhosis problem. Had the they just had the ART center done a sonography prior?
I'm just trying to take that point. So this is one USG which is done elsewhere, which was showing the core secotexture of liver. But what USG was repeated in our center again, it was showing just hepatomegaly and core secotexture. There was ascites, sir, but except that, no other findings. And this patient had all those symptoms for last nearly 1 or 2 weeks, starting with jaundice.
So another question is, this patient has been on antiretroviral therapy for a long time.
Yes, sir.
Since 10, 12 years. One day suddenly we decide that she needs isoniazid preventive therapy.
Yes.
So how prudent is it to give isoniazid preventive therapy in the decade after? So would we give it, sir?
That's what, that is the.
So the real point is, what is the timing of the isoniazid preventive therapy? When is it most beneficial? Is it beneficial to all people?
Tuberculin test.
So what guidelines have been said that did this come from the trial? It's called Terran trial and START trial, where they give IRS prophylaxis and they see there's much, the 60% of populations don't have seen incidence of tuberculosis. So, but the tuberculin test has been in Western they do interferon gamma, and in India they advise the tuberculin test.
But tuberculin tests are in our side to interpret it and all,
Positive,
which
that's
is
what-
difficult.
It's positive, then somebody is to be think of giving any prophylaxis.
Hello. Hello.
Test
Hello.
there are many reasons, including age, immune status, even for that matter, diabetes, and general immunity being low. We know for certain that you may have really and disseminated TB and you'll find a negative test. So there are umpteen number of examples where the sensitivity of picking up that is also not there. You can have false negative tests certain times. So that is why in our country it is very difficult to use that whether you want to start based on that and all. If you have reviewed that uh, guidance from whatever NACO or something else, they have never even mentioned that it is to be given only in those who have a positive test. That is far more applicable in Western countries where overall the prevalence is very low of TB past exposure. But there it makes sense. For us, it doesn't really make sense. Like, for example, this question crops up in the setting of transplant or rheumatological patients where they want to embark on, say, infliximab or something like that. And there the question is whether you do a test to decide which manage prophylaxis. So this question is very difficult. It is unanswerable. In fact, I am a part of who have reviewed the South Asian guidelines and made those South Asian guidelines for solid organ transplant. It was not possible to come to any consensus on this. And if you see nephrology, they are also not having a consensus like whether all of them would like to start on INH, whether giving ATG or something else for a mismatched for ABO incompatible solid organ or anything like that. Is such a patient going to merit? Are you going to do IGRA and only restrict yourself to that? There are so many questions which we don't know, and we don't even know whether you are calling it as a treatment for LTBI or is it a primary or secondary prophylaxis. Okay, so if you are thinking it is prophylaxis, then probably the person means that prophylaxis really is on immunosuppression. If you are treating it as LTBI, calling it conceptually as LTBI, then it is only for a finite duration. So you need only 6 months of treatment. So, I mean, I'm still not clear in my mind what are we doing exactly. And at the same time, having said all this, the route, if we ever want to eradicate people, the route will go through treating people. That is a must. Without that, we can never hope to conquer it.
So the risk of reactivation of TB is inversely proportional to that immunosuppression. The immunological status of the host. So a patient who is in the first year of his treatment has not started antiretroviral therapy or has started antiretroviral therapy and the CD4 counts are still building up. Maybe it will take a couple of years for them to build up. I can understand starting isoniazid preventive therapy in that situation. Once a patient is virologically suppressed, and what is the need to intervene in those? I see that the studies are showing that there is a benefit. Yeah, but what degree of benefit are we expecting? How do we select patients for that?
Sir. No, sir, fatwas are never implemented by the people in the ART center. Fatwas come from top. So basically, what I feel is this: we have to differentiate between the public sector and the private sector. Public sector TRGs should go into it, like whether it should be once for all. Fatwa comes like that. Now you change from TLA to TLD. So everyone goes on that. You start IPTU because there is a new study, but a TRG should have given some thought about whether patient have been adherent, whether they are suppressed, whether their CD4 counts are more than 500. Now they have stopped CD4s also, so they don't know about it. So all these criteria should be applied in that. Even for, as you said, the new cases, if they have CD4 count 600, 700. Do they really kind of, there should be some stratification. The other part is in the private sector. Because forget about the INH non-availability in the public sector. When we write INH only for IPT in private sector, first thing it is not available. Second thing, he goes to the shop, and the third day he gets a call from somewhere saying that you have been prescribed anti-tubercular treatment and you have to be enrolled in the Nikshay. So whether it is for one drug, whether it is for 4 drugs, whether it is IPT or not, it is not available. And then it is not available in the public sector or private sector. So we cannot send the patient. So point is ki, if in a country like India, when we want to eradicate something or eliminate in 2030 or something, if you have this kind of haphazard kind of policies, it is going to be a more problem than solving a problem. And I think as experts, we should give good suggestions for that to improve that. Because otherwise TRG in the NACO is going to say that this is the study and you have to implement it.
I'll take a slightly contrarian view because we had a study published in 2015 about incidence of tuberculosis in patients who are on ART in our center, around 1,500 patients. And we drew our inspiration from the WHO guidelines. So it's very clear now that if you just give antiretroviral therapy and you suppress all patients, you can reduce the incidence of tuberculosis by only 67%. Irrespective of the CD4 count, whether it is above 500, also there is incidence of tuberculosis. It might be lymph node tuberculosis, it might not be TB mods. That is the only difference. If you add isoniazid prophylaxis on top of suppressive ART, the reduction in incidence goes up to 95%. So it is additive, it's not synergistic, it's additive, but it's helpful. So there are studies now which have been done on thousands of patients which have shown that there is evidence of benefit. Is also evidence of prolonging isoniazid prophylaxis to 36 months. So in Botswana, they are actually giving it for 36 months. So what sir said is right. If you want to stop tuberculosis as a public health threat, ART plus isoniazid preventive therapy is the way forward. And in our study also, there are only 2 categories of patients who developed incident TB on ART. One was those who were virologically failing, and 2 who were not taking isoniazid prophylaxis. So only these 2 things to watch about. The case you have presented is excellent. We will see such fulminant hepatic failure in 1 out of 10,000 patients given INH. Yes. But that doesn't mean that it doesn't help the rest of the 9,999 who will develop some amount of hepatotoxicity, so we checked for hepatotoxicity also for a period of 6 months, and it was around 3% for INH. In that cohort, we also lost a patient to fulminant hepatic failure, but it is a thing which we take. But overall public health benefit, it is definitely there. And for non-HIV population, now WHO has come out with guidelines saying, as sir said, all those who are on infliximab ideally should get INH. All those who are undergoing hematopoietic stem cell transplantation also should, and it's a strong recommendation. It's a recommendation, it's not a guideline, but it's a recommendation. So gradually, I think in rheumatology and in transplant setting, INH will come. We are not having that kind of good quality data to prove it.
So what would be
Sir,
the
excuse me, sir.
start IPT? That's one of the question which has come.
Once you are sure that your patient does not have active tuberculosis, whether he has a CD4 800, 1200, 100, doesn't matter. So
This is while initiating a ART.
no. You
Okay.
initiate ART. You many times, many experts first initiate ART. After 6 months, suppress the patient. They are sure that there is no TB. After 6 months, they give 6 months of IP and then stop it.
I don't doubt that isoniazid prevents tuberculosis. That's not the problem here. The problem is that we are extending it to larger and larger populations of patients and trying to prevent a relatively common disease. We are not going to ever succeed at it just by giving treatment. It's not that countries have not eliminated TB. They have eliminated TB. And they have not eliminated TB because they have been giving isoniazid. They have simply because the standard of living has to increase. So that is the answer to it, right? We can't do it through medicines.
No, it is one of the method. I am not saying that INH will eliminate all TB. I agree that socioeconomic status have to improve, but
that is the only answer,
reduce
right?
the incidence of TB. They have given 5 things. One is ART, second is IPT, Third is early diagnosis, use of TB gene expert or other molecular tests. So all these things will help us reduce it by 95, 97.
No, so but the difference in approach is, I believe in reacting to the situation. We want to improve health via and mass intervention. I am a little scary of.
The crux
Hello,
of the
sir. Can I
discussion
speak something?
is,
Hello.
individual basis treatment basically. First and foremost, that we have to rule out the active causes of the TB, and even if CD4 doesn't matter, or maybe immunosuppression doesn't matter, so then and then we can take a decision to start with the IPT. And of course, we have to take a proper follow-up of this kind of patients as well. Thank you.
Thank you.
Thank
I think in the interest of time, we'll go to the next case.
Thank you.
I call Dr. Sarvesh Bhimavat. He's an ID fellow from Dinanath Mangeshkar Hospital to present the next case.
So good morning, everyone. Thank you for giving me opportunity to present the case here. So my title is Double Trouble for Brain in the case of HIV patient. So 38-year-old male, no known comorbidities, resident of Kolkata. He was brought to Dinanath Mangeshkar Hospital by sister with complaints of headache, vomiting since 15 days, and altered sensorium since 3 to 4 days. There was no history of fever, and on examination he found to be drowsy, prefers to sleep, and there was no focal neurological deficit. On examination, there were meningeal signs were positive, Kernicks as well as Brudzinski signs were positive. So initial labs were done, which turned out CBC was normal. HB was 16 counts for 8,770 and platelets of 3,16,000. LFT shows mild transaminitis, SGPT of 88 and OT of 43, total bilirubin 1.57 and creat was 1.2. And on serostatus HIV turned out to be positive. So he was newly detected HIV. And with this meningeal signs positive, we have done MRI brain, which shows ring enhancement lesion with multiple ring enhancement lesion, as you can see, with conglomeration and perilesional edema. So, and they were in the posterior parietal lobe with significant edema, and there was diffuse leptomeningeal enhancement in the areas of bilateral cerebral convexities, cerebral poli, and along the cistern. So, looking at this, our differential diagnosis was either as a sero positive patient. So, we thought to be it could be tuberculoma with tubercular meningitis because there was multiple ring enhancement lesions and conglomeration was present. As it was seropositive patient, so toxoplasmosis we kept in mind, but absence of eccentric dot sign and surrounding edema and conglomeration goes against the toxoplasmosis. Cryptococcosis, there can be multiple lesions in cryptococcus, but usually they are along the vascular space, and they are usually multiple lesions will give a soap bubble appearance in that. And neurocystic sarcosis, multiple ring enhancement lesion with surrounding edema, but they are usually small and they will give you starry sky appearance like this, and there will be in the parenchymas everywhere there. And neurosyphilis, there could be focal areas of inflammation that present and that cause a mass lesion, which we will call as a syphilitic gummas, but multiple ring enhancement lesion goes against this. So with these differentials, we proceeded with the lumbar puncture. So CSF turned out to be a protein of 380, sugars were 98, total counts of 1020 with lymphocyte of 70% and polymorph of 20% and monocytes of 10%. So with this, and ADA 9.9, CD4 count turned out to 186 and his viral load was 1 lakh, HIV viral load was 1,36,000. Hence, in view of lymphocytic predominant CSF, along with routine cultures, we have sent for gene expert MGT culture, MTV pyrosequencing, and CSF cryptococcal antigen was also sent because CD4 count was below 200. Then, and serum toxo IgG was also sent, and as patient was newly detected HIV positive and he had a exposure history. So, to look for other STIs, we have sent for the syphilis also. So, let us CSF turned out to be gene expert MTB detected, present was not detected, and load was low. AFB culture was awaited. CSF cryptococcal antigen turned out to be negative. Toxo IgG was negative. Serum RPR reactive and titer was 1:128. So it was non-treponemal test. To confirm it, we have done the treponemal test. And TPHA was also positive with a high titer of 1:5,120. So with this, patient was started on as repeat LFTs was normal. So patient was started with wet-based ATT with steroids. And so what we are treating in an RVD patient, TBM with syphilis. But what stage of syphilis are we treating? Because TPH and RPR are positive, so syphilis was there. But whether it is a early syphilis, late syphilis, in early, whether it's early latent, late latent, because there was no primary or secondary syphilis signs were there. So whether it is early latent, late latent, what syphilis are we treating? So for that, and CSF VDRL was done, and it was turned to be positive. 1:8 titer was there. So we were treating patient with tubercular meningitis with neurosyphilis in a HIV patient. And we have done the detailed ophthalmological examination to rule out any ocular syphilis as well as otic syphilis. But there was no sign suggestive of any ocular or otic syphilis. And patient was started on injection ceftriaxone, as there was penicillin G was not available at that time. So we have started patient on ceftriaxone along with the ATT. Patient improved clinically, he started improving signs. Later patient was switched to IV penicillin G when it was available with a dose of 4 million unit every 4 hourly to complete the total 14 days of therapy. So in case of tubercular meningitis, we know that HIV patients are more prone to tubercular meningitis because as there is gradual decrease of CD4 count, there is increased opportunistic infection and including Mycobacterium tuberculosis. And there is a direct and positive correlation between the reduction in the CD4 count and increase of extrapulmonary as well as pulmonary tuberculosis. So in case of drug sensitive TB, we have started on the plan to start ART after 4 to 8 weeks. Later on, as we know, the patient was having only symptoms of meningitic symptoms. So our patient was most likely in a case of early neurological, early neurosyphilis, as there was no parenchymal signs or spinal signs. Because and usually these parenchymal and spinal signs of tertiary syphilis usually comes later, right? Around 25-30 years later. So hence our patient was in an early neurosyphilis because he had meningitic signs. And so we cannot say clearly whether these meningitic signs were because of tubercular meningitis or a neurosyphilis. So we were treating a dual case. And in case of when to do CSF, in case of whenever we are suspecting a neurosyphilis. So whenever patient of neurological or ophthalmological signs in any stage of syphilis, we need to do CSF to rule out neurosyphilis. If there is evidence of any active tertiary syphilis, we have to rule out neurosyphilis because in a neurosyphilis, we have to give therapies like penicillin G, which is of better penetration in the CNS. And if we find treatment failure, including failure of serum, non-treponemal test to fall appropriately in any stage of syphilis, we need to do CSF to rule out neurosyphilis. In case of otic and ocular syphilis, usually CSF is not required, but if possible, if we will not always find CNS, CSF abnormalities. But if CSF abnormalities there, so it will help us to tell the efficacy, to assess the efficacy of the treatment. And some expert also suggest where to do CSF to rule out neurosyphilis whenever serum titers are more than 1:120 and patient is not started on ART, patient's viral loads are high and CD4s are low. So they recommend to do CSF also. We have to keep a high suspicion for a CSF neurosyphilis. And this is the latest trial which shows ceftriaxone is a non-inferior to the earlier known gold standard benzyl penicillin for the treatment of neurosyphilis. And they found clinical response at the end of the 1 month and the serological response at the month of 6 months were good. And as well as there was decrease in the hospital stay.
Any questions from the audience?
Hello.
Toxoplasma infection, instead of IgG, IgM should have been done for ruling out the active infection.
Sir, as we know, when we are talking about the toxoplasma brain lesions, so at that time, it should be chronic, and toxoplasma is in a retroviral disease positive patient. They are mainly a reactivation. They are not an acute infection. That's why IgG is preferred. We are not talking about the active infection. Toxoplasma usually it is a reactivation. So that's why IgG is helped to rule out. When toxoplasma IgG is negative, there is clear evidence that there is no toxoplasmosis. Because we are talking about the ring enhancement lesion. That's why it was in our differentials.
Reason is anti-toxo IgM is an extremely difficult test and should be done in reference labs. Okay, so there isn't much of a market for IgM at all.
See, thing is, this is an interesting case we have been following. He also had herpetic infection, genital infection there in this case. But the point here I want to make is with the kind of syphilis that is coming back, I think in a HIV positive patient, when you are sending CSF for any damn thing, for every case, irrespective of the signs, symptoms, and something, you advise for a VDRL test. It should be a routine thing in a HIV positive person because syphilis is known to be spreading rapidly in HIV infected people, especially in immune compromised states. So one can travel to neurosyphilis also much rapidly, and you can see neurosyphilitic signs in early syphilis, early HIV also. So it's one of the things which can get affected very fast.
Dr. Kulkarni, it is my practice to do VDRL and TPHA as a baseline evaluation in all patients of HIV. Okay, so we are trying to catch it even before the stage of invasion of the CNS.
No, I completely agree because in our baseline investigations, all other STIs, hepatitis B, C, VDRL, and everything should be done. But especially in a neurological patient, when you are sending us CSF, you should ask for a CSF VDRL also.
Yes, and I also noticed that many physicians and dermatologists do not do TPHA. So my plea is please do TPHA as well because sensitivity of VDRL in tertiary goes down to 65%. So you have to do TPHA. Please don't cut corners and only do VDRL.
If I could just add to that, I've actually started repeating the VDRL on a sort of annual basis in high-risk patients. I've actually found re-exposures and recurrent syphilis.
I completely agree because it is not only for HIV patients, but all our patients on PrEP. We are seeing a lot of syphilis coming back, not only syphilis, HIV seroconversions, hepatitis B seroconversions. So high-risk patients, we should be repeating the test quite often.
Yeah, that's more of tuberculosis.
That's why you thought that the meningitis. So you can comment on what you thought was the ring enhancing.
Sorry.
So he's asking whether the ring enhancing lesions were in favor of syphilis more or TB.
No, they were in favor of tuberculosis.
You send the test and it come positive. That's why we take it.
No, serum titers were of TPH and VDRL are high. So with these high titer, we have to keep in to think of neurosyphilis also with this presentation. So
The cord. Have you screened for cord also?
spinal cord.
Spinal cord.
No, we have not screened.
Okay, thank you, Sarvesh. We now move to the next case by Dr. Likhit Gandhi, ID fellow from the hospital. I think we'll try and finish the case and the discussion within 10 minutes so we can start the next presentation in time.
Today I will be presenting a case of acute meningoencephalitis. So 32 years old male. Years-old male patient, known case of RBD is 15 years. Source was unknown. Mother, father, siblings seronegative. He was on ART, TLD from private practitioner. One month ago, he has admitted fever, headache in Nagar, diagnosed to have lymphocytic meningitis. Did not relieve his HIV status over there. So prescribed with prednisolone and suspecting viral meningitis. Took Dama and recovered. Got married to seronegative lady later. So just 3 days after the marriage, he again got admitted elsewhere with the complaints of headache, irritability, yet ataxia. So MRI brain was done, which was suggestive of meningoencephalitis with few ill-defined lesions in salivary features. So evaluated for same, found to have cryptococcal meningitis based on multiplex PCR panel. So then CSF Fox sent for culture and started with liposomal amphotericin B by 10 milligram per kg body weight with flucytosine for 6 days. So on this therapy, patient have developed thrombocytopenia, hematuria. Along with that, leukopenia was there with fevers. So shifted to DMH with last viral load not known, and CD4 count was 229 a year back. So, that time the patient was on TLD, so that is tenofovir, lamivudine, dolutegravir. So on prime. Yes. On day one in DMH, we stopped AMPHO and flucytosine and started with high dose fluconazole. So that is 1200 milligram on day one and 600 milligram after that. Along with that, Mero was started in view of sepsis. So the lab came, which was CBC was 14 of HB, WBC of 4,290, and platelet of 21,000, with serum creatinine of 3.6 and serum procal of 457. Had acidotic bleeding with metabolic acidosis, so was intubated. And that time the blood lab informed us that blood is growing GMV. So we asked to do sepsityper and got to know it's Klebsiella. So empirically escalated to zivseftastenum. Then flow was asked. So flow was detected OXA48 and NDM. So zivseftastenum continued. After 3 days of ICU stay, got extubated, and creat got normalized. So started with a fluconazole high dose, that is 1200 milligrams per day. And once the platelet settled, we did lumbar puncture again. So protein was 207, sugar of 34, with counts of 18, poly of 0, lympho 60, and mono of 40. So in DMS, CD4 was sent, which came 58, and viral load was 1,823. So then he rapidly improved, extubated of inotropic support, shifted to wards, and CSF fungal culture in DMH had no growth. So inquired outside hospital where prior CSF was done. So they had there was fungal growth in their CSF. So asked to send a strain to DMH, and that on that strains within mildly, so which found Cryptococcus neoformans. So DST was asked. So this is the BMD for crypto. So then as the CD4 count was 58, so started with Bactrim prophylaxis with fluconazole of 1200 milligram daily for 12 weeks, later changed to 200 milligrams per day, lamivudine, dolutegravir. And as we asked for past history of ART, so this is a timeline of ART history. So in 2014, he was diagnosed with CD4 count of 21, started with AZT, 3TC and nevirapine. And in 2017, the CD4 count was increased to 135. So continued same reason. 2019, CD4 count dropped to 15. Viral load was not available. And so they changed to tenofovir, lamivudine, atonavir, ritonavir. So in 2020, CD4 counts again little bit improved, 27, and that time he had meningeal signs. So CSF was done, which had Cryptococcus antigen positive, and treated with oral fluconazole for few weeks, and ART was changed to TLD. So then 2021, CD4 not available, and viral load was not available, and continued with same resume. 2023, CD4 counts was increased to 229 and viral load of 49. So that time, by seeing this ART history, we send a resistance marker. So these are the resistance marker. So we can see the major mutation in NRTI with M184 and T215, which might be the due to the AZT. And there are no rather any mutation in protease. And integrase, there was N155H mutation was there. So finally, we discharge him on Bactrim, TTC, DTG, and DRVR and fluconazole. So despite long, like discussion point over here is, despite long term follow-up and due to probably poor adherence, developed triple class failure. And the first episode, which was 2020, which was inadequately treated for cryptococcal meningitis. And third point was high dose amphotericin B, that is 10 milligram per kg body was for several days, caused AKI. flucytosine caused bone marrow suppression, and cryptococcus requiring several weeks of high dose fluconazole and salvage therapy for ART, with no NRTI included, and long term complications like hand.
So two questions from the audience.
No, but he's not on two drugs.
Sorry?
He's not on two drugs.
Yeah, okay.
What?
So 3TC, that is lamivudine, dolutegravir, darunavir, ritonavir.
Any other questions from the audience? Judges? We'll stop here. Thank you so much. Thank you, judges. Thank you, fellows. I think we'll now move on to the next lecture, updates from CROI 2024. I'd like to call Dr. Amit Dravid, consultant ID physician at Pune Hospital and HIV specialist. And for the moderator, I'd like to call upon Dr. Raman Gangakhetkar, sir. Sir needs no introduction, or if I go on to the introduction, I think we'll go on till the end of the lecture. So I think we'll start with the lecture, sir.
Piyush.
He is one of the leading ID specialists as well as HIV medicine specialist. He has a keen interest in blood-brain barrier, working with Spotlight and Ray. I would request him to deliberate on this issue.
Thank you, sir. Thank you, Gangakhetkar, sir. Thank you so much, sir. Thank you, Piyush. Thank you, SIDS. Thank you, MCure, for calling me here. And I was supposed to talk on updates from CROI 2024, but if I stick to only updates from CROI 2024, the people won't understand where I am coming from. So I'll put in some theory in between so that we understand where we are going. So it is now very clear that we are starting antiretroviral therapy for everyone. So anybody who walks into your clinic, even if his CD4 count is 1000, you're sure that he has no OI, goes on antiretroviral therapy today. WHO wants us to get to 90-90-90. Countries. Only then in 2030 will HIV be an illness which will not be of any public health significance or public health importance. Botswana was the first African country, the first low and middle income country which reached there, and they did not reach 90-90-90, they reached 95-95-95. So their ART program is so robust that 95% of women access sexual and even India can look back to a poor country like Botswana where they have reached. And in 2024, 4 more countries reached there. Botswana, Eswatini, Rwanda, Tanzania, Zimbabwe all have reached 95 targets. So Africa is very robust and they are country after country. We should learn. Where is India? These are the 1999 data. Some states are doing very well. As usual, Kerala is at 95-95-95 already. Maharashtra is at 88, 84, 88. But overall, we are only at 77 or 85. And it was supposed to be achieved in 2020. So I think it will take another 2-3 years to reach this. Excellent. Chandigarh, Maharashtra, Kerala, they are doing very well, but there are other lagging states who really need to pull their socks up if we want to reach 95-95. WHO guidelines are clear. Everybody goes on dolutegravir as the first choice, and ultimate regimen is nearly 400. While for the private sector, we follow the DHHS guidelines, where even FTC big single dose is another regimen which is available. Abacavir, lamivudine, dolutegravir is another regimen which is available, and TAF FTC dolutegravir or TDF lamivudine dolutegravir is also available. We also have now DTG 3TC as a two-drug regimen for our patients who are suppressed on first-line ART. So what will first-line ART regimens look like? And this is in 2025. We are getting there. We might have a very different look at antiretroviral therapy in the future. First of all, we might see a lot of two-drug antiretroviral therapy, and dolutegravir will be the backbone of that oral therapy, and it will be for treatment simplification. This was the study, the TANGO study, which showed that once you're suppressed on TLD, TAF-LD, TAF-FTC-BIC, and you're not hepatitis B positive, you can just shift the patient to a two-drug regimen of DTG-3TC, and it maintains suppression. So the whole premise that we need 3 drugs to suppress the virus went out of the window when good drugs, robust drugs like dolutegravir appeared on the scene. And the future belongs especially in patients who are suppressed on first line to two drugs therapy. So maybe we are moving there, and data from CROI show that it is a movement has started where we will soon be talking about oral and injectable two drug regimens for antiretroviral therapy, and it was doing as well as a 3-drug regimen. So those who were on TLD, those who were on TAF-LD, and those who were only on DTG-3TC were actually doing equally well. Then came the NEGM study, which showed a totally different perspective, where long-acting cabotegravir rilpivirine came in once monthly injection. What is cabotegravir? It's the next generation INSTI after dolutegravir. What is rilpivirine? It is a sister drug of nevirapine. So they combined 2 drugs, one integrase inhibitor, one NNRTI, gave it once every month after suppression. Once first line ART you are suppressed, you have no antiretroviral failure in the past, you are not HBsAg positive. They tablets. Everybody is now shifted on to cabotegravir rilpivirine injectable once in a month. So we are talking of only 12 injections in a year. You are tablet free. You're not disease free for life, but you're tablet free for life if you keep on taking your injections regularly. Side effects, everybody complained it might cause injection site reactions, but injection site reactions were there only in less than 2% of patients. Discontinuation rate was only 1%. So it is so robust that it will, once the virus is suppressed, this injection will keep suppressing it, and it will not have any side effects as well. So NEGM put out this poster saying failure rate of only 1.6%, discontinuation rate of only 1%, and suppression for life just with injections. Lancet went one step further. They started giving a higher dose of cabotegravir rilpivirine once in 2 months. So why stick to 12 injections? Let's give only 6 injections. And we found that even 6 injections are doing well. So just by doubling the dose, giving it once in 2 months, cabotegravir rilpivirine, 2-drug regimen, once you are suppressed, I'm not saying give it upfront, but first suppressed on first-line antiretroviral therapy, rule out HBsAg status because both these drugs don't work on hepatitis B, and shift them, you will find that here also almost 93% continued the suppression. So we are now moving into an era where in 2025, and I think 3 Indian companies already have the license to manufacture cabotegravir rilpivirine. They will soon be into the market in 2025, and then we will have an exciting phase where all my patients will be tablet free, whoever are suppressed on first line, and will be shifted to cabotegravir rilpivirine. Again, injection site reactions very, very low. In CROI, they started asking the patients, what is better, oral therapy or injectable therapy? And overwhelmingly, patients started favoring injectable therapy and not oral therapy. They gave various reasons. They said daily HIV medications are inconvenient. They have to hide those HIV medications every day. It reminds them of their status, and they have problems taking HIV medications daily. See, if you start taking tablets daily, you will also get exhausted one day. We are telling our patients to take tablets for 40 years now. It's not possible. So we have to cut them some slack, and there has to be some convenience given to patients. So overwhelmingly in CROI, data after data showed that patients are happy with injectable drugs and they are suppressed on injectable drugs. Then the question arose, can we replicate this model from the West into an Indian or an African model of low and middle income countries? Remember, we have a public program where we don't do viral loads. We do viral loads only once a year. We have very high NNRTI resistance, baseline NNRTI resistance, sometimes touches 10%. And rilpivirine is NNRTI. So, and many times we just shift from TLA to TLD. As the program introduced TLD, many patients were just shifted from TLA to TLD, sometimes not without a viral load as well. So what if he was failing earlier? What if he had archived resistance to NNRTS? What do we do? So this was the CARE study, which was the closest we can get to an Indian setting, which was published in CROI 2024 this year, where they looked at African individuals who were on first-line antiretroviral therapy, TLD majority of them, suppressed, not HBsAg positive, and shifted them to cabotegravir, rilpivirine, and see if whatever is what is happening to these patients, typical free ART sector patients, which are also there in India. And they felt that because there is so much NNRTI resistance, there might be more failure in the future. So it was clear you either continue your TLD or shift to twice a month cabotegravir, rilpivirine, 900, 600. Uganda, Kenya, South Africa. So the countries which are closest to our demographic were selected. See the retention rate, 99% retention. So almost everyone was happy that they were getting shifted to injections and getting only 6 injections a year. Look at the resistance mutations. They had archived blood samples. So they went back and checked the archived blood samples before shifting. And they found that 13% had rilpivirine mutations, though they had NNRTI mutations. 16% had some sort of integrase mutations as well, because they were already on TLD. So some of them might have that. So there was a problem there, 15%, 10%. So we expect that around 20% will fail. See that 99% adherence and almost 99% took it within 7 days of taking it. So there was no problem with adherence. So they looked at how many were suppressed, less than 50 copies, 97% suppressed. So despite having baseline NNRTI mutations, baseline cabotegravir mutations, cabotegravir, rilpivirine still worked. And after 1 year, 97% of patients were still suppressed as compared to oral. So this was the study which actually convinced WHO that time has come where the free ART sector also has to think about, not roll out, but think about giving this option to their patients, because it is working. It is worked in Africa. I don't see any problem why it won't work in India, because we have almost the same demographic and almost the same mutation profile in our patients. High efficacy, 97.4% patients suppressed at 1 year. Only one participant had a blip and he was resuppressed with dolutegravir. So integrase mutations were not big of a problem. Only 1% discontinued because of injection site reactions. And the satisfaction score amongst patients was humongous. So I feel this is now coming. We are now set where the West is already on cabotegravir, rilpivirine. Very soon, pre-ART sectors in India and Africa will soon get this as an option for patients who are suppressed on TLD and who are HBsAg negative. The problem with this study was they did HBsAg and anti-core antibody for all the patients before shifting, and they found that the anti-core antibody came positive at 30% of patients. So we don't know what will happen with anti-core antibody. They followed up those patients who accidentally got this treatment despite anti-core antibody, and there was no blip on half hepatitis B. But that thing has to be kept in the back of our mind, that we have to do HBsAg for every patient before we shift, and anti-core antibody if according. Then there was another study which was published. They went even further, saying that we all have patients who are alcoholics, who are injection drug abusers, who are prisoners, who can't take oral antiretroviral therapy regularly. They always keep stopping, come back with a high viral load. They take it for 6 months, come back with a CD4 of 50, 60, viral load of 60,000. Such patients whom I call nuts in my practice, who just don't take antiretroviral therapy regularly, they say टैबलेट से बोर होता है, कितना लूंगा, 6 महीने बाद बंद कर दूंगा. So there are many of these. So they took this cohort, saying this is a cohort which is not going to take oral antiretroviral therapy regularly. They are not adherent to regimen. They just did their resistance profile and proved that there are no integrase mutations, no cabotegravir mutations, and put all of them on cabotegravir rilpivirine. They were homeless, they had unstable housing, they had no insurance, they have injection drug abuse. So all these patients who are at the periphery of our care, they hardly receive care. We also discriminate them saying, "Ye treatment nahi lene wala." So these patients were included, almost 155. Viral load was almost 4 logs plus, and CD4 was 215. And you see, out of those 57 patients with viremia, after 33 days, 55 were suppressed. So those patients also who are not going to be adherent on oral antiretroviral therapy, we know there are certain prisoners, there are certain injection therapies, alcoholics, even they will be helped, provided they don't have cabotegravir and integrase or NNRTM mutations at baseline. If that is ruled out, even in such category of patients, and this is known as the Ward 86 study of San Francisco, where they will also be suppressed on antiretroviral therapy. What about second line regimens? We all know the Dawning study, which was conducted as a second line treatment in patients who failed ZLN, who failed TLE, were shifted to either dolutegravir plus 2 NRTIs or a protease inhibitor plus 2 NRTIs. Initially, dolutegravir outperformed lopinavir, because of which the WHO guidelines said that now we have to use dolutegravir in second line as well. It was clear, and boosted protease inhibitors became the alternate backbone. It did not become the main backbone. So WHO said, if your patient is on AZT3TC nevirapine or tenofovir, lamivudine, efavirenz, shift him to 2 new NRTIs plus dolutegravir. If your patient is on dolutegravir in first line and failing, shift him to 2 new NRTIs plus protease inhibitor. It could be atazanavir, it could be lopinavir, it could be anything. These were the WHO guidelines. What changed? NEJM published the Nadia study. What did Nadia do? It just said that do we really need to shift from tenofovir to zidovudine or from zidovudine to tenofovir? Because zidovudine is uncomfortable. It has to be taken twice a day. It causes anemia. It causes lipoatrophy. And then patients say that I was on TLE, which was 1 pill. You gave me ZL plus dolutegravir, which are 3 pills. What about the adherence? So all these problems were then sorted out by this Nadia study. It was very clear. If you're failing in an RTI, you shift either to TLD or ZLD or TL plus darunavir or ZL plus darunavir, 4 arms. And they found that in all arms, second line antiretroviral therapy, more than 90% were suppressed. So this whole thing that we need to change the NRTIs, we need to change from tenofovir to zidovudine, just went out of the window. It was found that even if you have K65R, even if you have NRTI mutations, if you have 0 NRTI working in your backbone, dolutegravir will still work. Darunavir will still work. So the whole idea that you have to move from TLE to ZL plus dolutegravir went out of the window. This study conclusively proved that you can shift from TLE to TLD, TLE to TL darunavir. You don't need to shift your NRTIs for that matter. Then came the second line study. They said, okay, we will shift from TLE to TLD. But what about those patients who are already on TL atazanavir, already on TL lopinavir? Can we shift all of them? Majority of them were on lopinavir and atazanavir. And they found that you can shift all of them to TLD. So anybody who is suppressed on second line on TL atazanavir or TL lopinavir or TL darunavir can just shift to TL dolutegravir, and the suppression will continue. Then this study was published in CROI 2024 this year. They said, okay, we don't have access to dolutegravir. We have access to bictegravir only. And you know that bictegravir has not been studied in treatment experienced patients. Dolutegravir has been studied. Bictegravir has been studied only in first line. So TAP FTC BIC is recommended only for first line antiretroviral therapy. This was Haiti. There was a civil war going on in Haiti. And they said, we can't give so many drugs. We don't have that much money. All the patients were suppressed on second line, whether it is atazanavir, lopinavir, darunavir, they shifted to TAF-FTC BIC because it was 1 pill. We don't need to bring 2-3 pills together. The cost came down. The company gave them bulk TAF-FTC BIC. And they said, let's check if these patients fail. They did not fail. 93% were still suppressed. on TAF FTC big second line. So this opens up new frontiers where initially we had only dolutegravir in second line. Now we can say that if your patient is suppressed on TAF FTC atazanavir, TAF FTC lopinavir, TAF FTC darunavir, you can either shift him to TLD or TAF LD or even TAF FTC big. This is another option which has opened up. Although this study is not big, but it is giving us a sneak peek where TAF FTC big also will work in second line. And you can see, because it is TAF, the renal toxicity is very low. Suppression rates are almost more than 90%. It is non-inferior. What is new in HIV TB co-infection? We already know the Radiant TB study was published, which said that we don't need double dose of dolutegravir to suppress patients of HIV TB co-infection. Even if you give single dose, just TLD plus HRZD, you will still be suppressed. You don't need a second dose after 12 hours. So this was, which was published in Lancet. Again, it is a phase 2B study, not into phase 3, not in guidelines, but we know we are going towards that. That we may be, WHO will come with a guideline saying that you just need HRZD plus TLD. You don't need an extra dolutegravir after 12 hours. So what changed? There is a new study now, which was published in CROI, which was the INSIGHT study. They said, can we use bictegravir with rifampicin? If we can use dolutegravir with rifampicin, we can use bictegravir with rifampicin. The only thing is they doubled the entire dose. So one pill one morning, one pill night. So TAF double, FTC double, bictegravir double, plus HRZD for HIV TB co-infected patients. And they found that even bictegravir suppresses it, only in double dose. We don't know about single dose because the study was planned that way. But now if your patient is having problem with dolutegravir or problem with TDF, you have an option where TAF FTC big double dose, so one pill morning, one pill night plus HRZD, can also achieve virologic suppression without any adverse events. So people thought you were giving double dose TAF, double dose FTC, double dose big. What about side effects? Hardly any side effects. Even hepatitis was low. I don't know what patients they see, but even hepatitis was low, which is quite common in our patients, but still hepatitis was very low. And they found that the pharmacokinetics was also maintained. 80% reduction in big levels, but still above the suppression rates. So IQ, it was still above the IQ, which was required for suppression in patients. What is new in HIV and pregnancy? Again, this was the impact study, which was published in Lancet, which showed that any dolutegravir-based regimen does well in pregnancy, suppresses the viral load fastest. But to our surprise, the best regimen for pregnancy was TAF FTC dolutegravir, not TDF FTC dolutegravir. And they found that stillbirths, preterm delivery, and small for gestational age, these obstetric and maternal outcomes and child outcomes were the best in a TAF-based regimen. So if you ask me today, which is the best regimen for HIV and pregnancy, I would say TAF, FTC, and dolutegravir. TLD comes second. TLE should be completely out now. So this was already proven. Now came the bictegravir study in pregnancy, which said that even bictegravir is safe in pregnancy, even bictegravir suppresses the viral load, and there are no adverse maternal and fetal outcomes, and fetuses are all HIV negative. So now we have another option for pregnancy where instead of TLD, TAF LD, you can also use TAF FTC big in pregnancy in patients who need it. Any new update about prevention of cardiovascular disease in HIV? You know, our patients are getting elder. They are living for decades together. And then they are falling prey to what I call as major adverse cardiac events, MACE. So this was a study published in NEJM, which looked at pitavastatin as a single therapy, preventive therapy for all patients who are HIV positive between 40 to 75 years of age, which almost all our patients are now in that category, and having low to moderate risk of cardiovascular disease. They gave pitavastatin 4 milligram daily, and they found that when pitavastatin was given for almost 5 years, there was a 35% decrease in major adverse cardiac events. All your strokes, unstable angina, myocardial infarction, arterial ischemia, all of this reduced by almost 35%. So it is now very clear that because our patients are living longer, if you have a patient with 40 to 75 years of age with low to moderate risk of cardiovascular disease, which a majority of our patients are, then they need a statin along with antiretroviral therapy, along with INH prophylaxis, which is so controversial. So this is another tablet now, which I am going to recommend, and it works everywhere. So across the board, whether it was Black population, Asians, whether CD4 count was more than 500, less than 500, suppressed, not suppressed, everybody got pitavastatin and everybody had benefit. So now in Feb 2024, DHHS has changed guidelines and put out clear recommendation that if your patients are 40 to 75 years of age and with moderate risk, everybody should take either pitavastatin, atorvastatin, or rosuvastatin. They have given three options because there are retrospective studies about atorvastatin and rosuvastatin as well. So if you don't have pitavastatin available, you can give atorvastatin 20 mg daily or rosuvastatin 10 mg daily. Less than 40 years, you don't need an indication. They went even further, saying that 40 to 75 years of age with high risk. That means you have past history of cardiovascular disease, family history of cardiovascular disease, you're a smoker, your cardiovascular risk is above 20%, then initiate high intensity statin therapy for your patients who are HIV positive. If you're diabetic, then initiate at least moderate intensity statin therapy. What is high intensity statin therapy? Atorvastatin 40 to 80 milligram, rosuvastatin 20 to 40 milligram. So all of this is now coming into our domain. We are going to add statins for majority of our patients who are between 40 to 75 years age and have either moderate or high risk of pregnancy, high risk of cardiovascular disease. What's new in obesity management? You must have known that so many of our patients who are on antiretroviral therapy are coming with weight gain and weight gain of abysmal proportions. That means 120 kg, 130 kg, 135 kg. I did not even believe that one scenario will come. Well, I'll do obesity surgery for two of my patients last year. So this is where we are reaching because so many of our patients are on integrase inhibitors. And we can't prescribe obesity surgery left, right, and center to all our patients because it is costly. So we need drug therapy. And we know that for diabetics and obese patients, semaglutide is a drug which is available in India. It has been routinely prescribed for diabetics with obesity. And there was an entire session for obesity in HIV positive patients where semaglutide was looked at whether it helps in HIV positive patients. I had actually asked one of my diabetology colleagues to give semaglutide to one of my patients, and he had said there is no data in HIV positive just 6 months back. And the first session which I attended was this, that it was obesity and diabetes in HIV positive. So what is semaglutide? It is a GLP-1 analog. What it does, it improves insulin and it leads to fat loss and satiety in the brain. So the patient doesn't feel hungry. The caloric intake goes down. The insulin releases fat cells from the brown and white adipose tissue and leads to weight loss. It has multiple other actions which we can discuss later. And it has been proven that by giving semaglutide for almost 40 weeks in HIV positive patients, it does reduce your sugar, it does reduce your weight, almost an average of 7 kg weight loss. So for a 100 kg man, almost 7 kg weight loss is gold dust for him and without undergoing surgery. So only problem is it does cause nausea. So two of my patients who are on semaglutide cause bad nausea, and sometimes it can cause facial lipoatrophy further. So it is called as Ozempic face. So it can have lipoatrophy as well, but the benefits outweigh the risk here. So you look at the data was clear that those who are in the highest BMI category had the most maximum weight loss. So above 40 had a weight loss of almost 10 kg. So 10 kg in a 120 kg man is amazing at 12 months. It might be progressive as well. It's just a 12-month data. Then they looked at whether we can have reverse the fatty liver disease, which is also common in obese diabetics, by giving semaglutide. Initially, they started with 0.25 milligram subcutaneously, went up to 1 milligram. And they found that it led to for 58% of the participants having more than beneficial response for fatty liver disease and 29% of patients completely curing their fatty liver disease. So the liver was completely drained of the fat. So this might be one way where we have our patients who develop liver cirrhosis because of fatty liver disease or non-alcoholic NAFLD. Then there is one option for HIV positive patients where you can use this. So slim liver study was good for glucose, good for lipid profile, was good for obesity weight loss, for sugar management, and also for draining the liver of the fat and preventing NAFLD. So it was clear that it is beneficial, and semaglutide will become soon a part of our guidelines for patients who develop ART associated obesity. How will future PrEP regimens look like? And that is where I'll end my lecture. So cabotegravir was looked at. People said, why should PrEP be only oral, TDF-FTC? Many people don't take PrEP regularly because they say, can't keep taking a tablet regularly. I don't know when my sexual intercourse will happen. I just can't keep taking tablets so that I presume that I prevent some imaginary infection. So they said, fine, we will give injectable cabotegravir to patients who are at high risk, especially MSM and transgender women. So they compared it with TDF-FTC daily PrEP, and they found that it had 78% better efficacy than TDF-FTC. This was published in Lancet, and then very soon WHO picked it up. They put out an advisory saying, now the time has come where for PrEP also we will give injectable drugs. Once a monthly cabotegravir, almost 80% better than oral PrEP, 80% better than TAF-FTC or TDF-FTC, which we prescribe today. So there is another better drug available for PrEP as well. And the better efficacy was only because of better adherence. People could take 12 injections in a year rather than taking 365 tablets in a year, which is any time better. And plus the drug levels remain. So it is always better. The only problem is if you fail PrEP, then cabotegravir resistance develops and dolutegravir might be sacrificed. So that is a problem. We are still working on it, but the PrEP failures are very, very low. So finally about doxypep. So this was another study which was published earlier, and the follow-up study was published in CROI, where they said that all those patients who are on PrEP or who are HIV positive and still engaging in condomless sex, if they come to the sexually transmitted infections clinic, they should take 200 milligram of doxycycline, single dose, after every episode of condomless sex. And they found that the incidence of syphilis went down 80%, incidence of chlamydia went down almost 75%, incidence of gonorrhea went down because doxycycline resistant gonorrhea is common, but still it went down by almost 50%. So now in Africa, they're thinking that they might give, along with PrEP, doxypep as well, so as to prevent sexually transmitted infections. There was a real world study in CROI which confirmed that even in African setting, doxypep works. It prevents sexually transmitted infections. So on a mass scale, we can use it. So finally, in conclusion, the future of first-line ART regimens now belong to maintenance therapy with high efficacy, long-acting integrase-based injectable regimens or oral dolutegravir-based dual therapy. TAF-FTC can now be safely used in PEP, pregnancy, HIV-TB co-infection in double dose, and second-line antiretroviral therapy after suppression on PI-based or DTG-based second-line ART. There are new drugs which I didn't talk about because it is beyond the scope of this discussion, like lenacapavir, ibalizumab, fostemsavir, which there are multiple presentations at CROI on this, but we don't need them as of now and in India as a country. But they will be available if we start developing DTG and darunavir resistant HIV. But as of now, these two drugs are enough. Injectable PrEP scores any day over oral PrEP and will replace it in the future. Just like injectable treatment will replace oral treatment, injectable PrEP will replace oral PrEP. Weight gain and obesity is a reality on integrase-based ART, and cabotegravir is not going to solve it. It might worsen it as well. So we are in for a lot of pitavastatin, atorvastatin, rosuvastatin, semaglutide, and I think all ID consultants now need to brush up their metabolic knowledge so that your patient doesn't need to be sent somewhere. And despite multiple success stories regarding sterilizing or therapeutic cure of HIV, a single pill for cure is still a decade away. And this was the first conference where there was not a single case study of any sterilizing cure of HIV. In the last every conference, there was at least one patient who was cured by a bone marrow transplant, Delta 63 bone marrow transplant. But this was the first study, first conference after a long time where no sterilizing cure or no enthusing news was reported. Thank you. And I'll take question.
That was really a nice exposition on CROI. Now we open for the discussions. If there are any questions.
Yes.
That yeah, taking our patients, what treatment priorities and that is for the right.
Sir, once you age, you will get a bottle of pills along. So our diabetics are doing it, our hypertensives are doing it, our CKD guys are doing it. The day is not far when our HIV positives will also do it.
Any other question? Huh?
Yes, sir.
Are all these new drugs which you mentioned are being covered by insurance?
Insurance in the West, yes. Insurance in the West, yes. But they are not available in India. But if they get available, they will be in the priority sector anyway. So I don't think insurance will be needed for that. But HIV as a per se is still an exclusion criteria for insurance companies in India. So that is not settled. This will only be settled by a government order, or government will have to intervene in that.
पण काय आहे?
Insurance Regulatory Authority. So previously our HIV positive patient did not use, I mean, they were not getting any kind of insurance. Now, if you go to a multi-specialty hospital, they will not cover HIV per se. Previously, they were rejected on the basis of HIV detection. Totally, insurance were rejected. Now they can get the insurance at least 80%. Say, for example, 1 lakh insurance cover is there, they can get at least 80,000. 20,000, like as far as ART is concerned, or maybe investigations are concerned, limited to HIV per se disease. They will not get any kind of insurance. And this is valid for, now IRD has removed the age guidelines as well. So before 45, you don't have to go for any kind of a medical checkup. Now after 45 also, you will not require any kind of a medical checkup. It's just a matter that you have to upfront tell that I'm having diabetes, I'm having CKD, or I'm having HIV positivity, or any chronic condition. Even for that matter, files previously, only the condition is that if you disclose your disease, you have to wait for 3 years. It's a waiting period for 3 years. So that is also incredible in today's era.
Just few questions to ask to Milind. Who's offering that? Because IRDA guidelines, it can only advise insurance companies. It cannot dictate terms. And I don't know whether such a.
So I think there is one insurance company, I think Care Insurance, they are offering the same.
Who? Care?
Care Insurance.
I was told Tata continues to offer a cover for HIV positive.
Previously, sir, Narimade Astanna, there was one company, Star Health.
Star Health.
They were giving 50%. Just 50,000 concession, I mean, cover was there.
No, but that was only after our effort.
No, this is recently published on 1st of April only. So maybe that needs to be discussed.
IRDA guidelines, that is a problem with IRDA. No? Anyway, but I was very curious to know, you said if you provide doxy as post-exposure prophylaxis, incidence of gonorrhea drops down dramatically. To my mind, it should not happen as dramatically.
Sir, now data about syphilis and chlamydia is very clear. Gonorrhea, there is a controversy. This study in NEJM said 50% drop. The study which was published in CROI said 33% drop. Because doxycycline resistant gonorrhea is already entrenched in some countries like France. So if you do a study in France, the incidence drop will be less. If you do it maybe in India, I don't know the incidence of India, it might be higher. So it all depends upon doxycycline resistance, which is circulating in Neisseria gonorrhoeae and Staph aureus. So the other problem was Staph aureus, that you will develop doxy-resistant Staph aureus. But this study said that this incidence doesn't increase. So the nasal carriage of Staph aureus also they checked. They said the resistance doesn't increase. Neisseria gonorrhoeae, yes, it's a problem. If you develop
not only a problem. Perhaps we need to be more careful because there is a surveillance called as GASP, where Neisseria gonorrhoeae is one of the most important organisms, which is looked all over. That was one thing which I felt. Actually, doxy is so weak. No, AMR, it will affect AMR as well. And for syphilis, I have still worse a comment. If you look at the early data from where even penicillins came, they have not been rigorous scientific trials. We do not know in the natural history of syphilis whether it is really cured and whether it comes back and hits you again. The same is true with azithromycin. When azithromycin was prescribed, identified through a trial, they are not long-term trials. We don't know whether they will hit you again as S2 or S3. So we need to take it with pinch of salt. Dr. Vinay Kulkarni will also comment perhaps.
In spite of the data, somehow all STI consultants are quite gaga about doxycycline, doxyprep. When the patient comes, I am not still using it because what I feel is that all the diseases that are caused by doxycycline supposed to be sensitive, these things will have symptoms. So I tell them that these are the things which I would be screening. But if you have any symptoms, come back immediately. We will investigate and treat completely rather than giving 2 tablets of doxycycline just like that. I am worried about increasing toxic resistance and whatever, false sense of security, and then people popping up 2 doxycycline tablets on their own, keeping in the pocket. Instead, they can keep a condom in the pocket rather than 2 doxycycline pills.
Sir, so we now disagree on 2 points, INH and doxycycline.
INH, I don't agree. INH, I don't disagree. I completely agree. Doxycycline, I do.
One has to be careful from another angle. Now that syphilis is re-emerging, now that gonorrhea is being seen in MSM population, it would be premature to say that STIs are not going to emerge. Now, if STIs emerge, if you use doxy right and left, your other diseases which were amenable to doxy perhaps will go out of hand. No, there will be huge resistance that will
Agreed, agreed. Sir, by the way, I am not proposing doxyprep. I'm just putting the data out.
But it's one area to work on because you have to have some definitive solutions to ensure that others who are HIV negative continue to remain negative if you want to have an elimination target for 2030.
Yes, sir.
Anyone else? So we thank you, Dr. Dravid, for an excellent talk.
Thank you, Dr. Ravid. We come to the next case-based discussion on ART treatment challenges and non-OI related complications. I'd like to call upon the speakers, Dr. Piyush Chaudhary, Consultant Infectious Diseases at Jahangir Hospital, and Dr. Ashwini Taide, Consultant Infectious Diseases from Nagpur. Introduce the panelists. Dr. Raman Gangakedkar is continue. Thank
Yeah, so I'll now call upon our 3 panelists who are available. One is Dr. Amit Dravid, sir. Second is Dr. Abhimanyu Makne, who is a HIV consultant from Sambhaji Nagar. And
looking at non-communicable diseases in this HIV population. Yeah. So, because if we see in 2020s, HIV is more become like diabetes, a chronic manageable disease from what it used to be around 20, 30 years back. I do agree that still opportunistic infections is an important consideration when it comes to Indian population. But with long-term survival of these HIV patients increasing, more and more other comorbidities like cardiovascular, metabolic, renal, and liver-related non-communicable diseases are on the rise in our HIV populations. And then in those patients, there is a complex interplay between the virus itself, the combination ART, the drugs which are used for treating the comorbid condition, and their interactions with the ART that the patient is taking. Overall, all these things impact survival of these people living with HIV. And there are no well set protocols, I would say, which are ingrained in our mind the way we have protocols for, say, PCP prophylaxis. Then below a certain CD4, you give MAC prophylaxis, you screen with toxo IgG, you do serum CRAG, etc. Even when most of us here are predominantly practicing HIV, very few of us would be regularly screening for these non-communicable diseases. And above all, with respect to social stigma and approach to these patients, HIV is not like diabetes because there is a lot of social stigma. There is lack of involvement of specialists from other specialties, be it cardiology, nephrology, and so on. There are limited resources when it comes to screening for all these diseases. And this population is further more predisposed to non-communicable diseases because they are also more likely to have various addictions. There are studies from US and most other Western countries where HIV positive person is more likely to have smoking or other addiction compared to general population, which further increases that person's risk of cardiovascular disease and various malignancies. So with this, I'll hand over to Dr. Ashwini to take us through the first case. Minimal scale PPP.
Good morning, everyone. Thank you so much, sir, for letting me present this case. So this was a case I had, this was a challenging case I had managed almost 4-5 years back. And why am I presenting this case? It's mix of normal OIs, what we see, and turned out to be something completely different, which we don't see in routine practice. So this was a young chap presented with tingling sensation in left hand for 1 month duration. He had difficulty in left eye opening, difficulty in swallowing, and slurring of speech for 3 days duration. He was a teacher, married, wife was negative. There were no comorbidities, no addictions, some blood transfusion history. So with this history, he was admitted with us somewhere in 2017. Systemic examination apart from CNS was normal. In CNS examination, there was no neck stiffness. He was conscious, alert, responding to verbal command. He had bilateral 6th nerve, right 7th nerve palsy. He had ptosis, gait imbalance, and the fundus examination was normal. So in background, this patient was admitted outside for this complaint actually, and it was a good neuro setup. So he was worked up thoroughly outside. The MRI brain showed multiple small, moderate size areas, facilitated diffusion in pontomedullary junction, cerebellar, thalamus, gangliocapsular region, and right thalamus. It was hyperintense on T2 and flare image, and there was no contrast enhancement. So it was suggestive of infarcts. They did CSF, which was normal routine. So they did vasculitis workup, ANCA, ANA, DSDNA, which was negative. APLA, cardiolipine, homocysteine, all workup was done. That was negative. He has received Solimedrol 1 gram OD for 5 days, and he has received oral steroid. There was no improvement, and this was the MRI, which showed non-enhancing infarcts. So, and this is the MRI when he got admitted with us. So, if you can see, there are regions in the medulla, pontomedullary junction, left thalamus, both thalamus, and lentiform nucleus. So, on contrast, there is no contrast enhancement and no perilegional edema. So when he came to us, we did CD4, which was 22, and viral load of 1,23,000 copies somewhere. So basically, this is a young chap who presented with neurological symptoms with low CD4 and no other systemic complaints or no other systemic signs. So what are the possibilities which we are thinking of at this point? Any of the panelists can take that, please. Can it be crypto, toxo, PML, what we routinely see? Can it be TB? Because we can have meningoencephalitis picture in all this OR.
So if you had to look at all the differential diagnosis, cryptococcal meningitis, there's no signs of neck stiffness, headache, vomiting, etc. No space occupying lesions, but sometimes there can be axonal spread. So we can't rule it out entirely, especially with such a low CD4 count. Toxoplasma, again, no ring enhancing lesions. PML, if these are white matter lesions that we're looking at, then possibly, but I think that's not how it is, right? It's infarcts in the brainstem.
Yeah.
Let's go back to the differentials. TB, again, less likely, no evidence of meningitis, no basal exudates, no neck stiffness. CMV can present with multiple cranial nerve palsies, although here this isn't so much cranial nerve as much as central causes. Can't rule out any of these with such a low CD4 count.
So can it be something else also, or it's more likely one of this?
It could still be what we call as HIV-associated neurocognitive disease, which can many times on MRI come with infarcts, but actually they are not infarcts, they are just demyelinating lesions, which we call as HIV-E, HIV encephalopathy. That is one. I don't see any other possibility. Maybe VZV encephalitis, but again, doesn't fit.
Okay. So the CSF sugar was 90C, parallel blood sugar was 156, protein was 23. It was just 2 cells and 100% lymphocyte, occasional RBCs. The toxoserology was negative, was done as completion workup because the CD4 was very low. Serum CRAG was negative, VDRL was negative, and CSF CRAG, India Inc. and Gene Expert was negative. So what are the differentials at this point? Do we need any further investigation? How should we work up? So if we go back to his counts, there was bicytopenia also. So what are the further investigations we'll advise? We'll do further CSF workup, or you want some systemic workup? How should we go about this patient, and what are the differentials at this point of time when we have CSF, which is the basic infective workup, which is negative, toxo, serum CRAG, VDRL, Gene Expert, everything is negative. This is a chap who has received solimedrol 1 gram for 3 days. The vasculitis, CSF, 2 cells. Yeah.
JC virus PCR?
Okay. What else would like to have? So the differentials at this point after the investigations will be?
I'll tell you what 9 out of 10 people will do. Start him on antiretroviral therapy.
Okay. Fine, accepted. But then do we need anything else to rule out some unusual infection? Because CD4 is very low, and we'll be skeptical before starting ART for such patients. Am I missing out something?
How was the CBC? You were mentioning the counts were low.
The counts was 3,900. Hemoglobin was 7.7.
Fundus?
Fundus examination was normal.
CMV.
Biopharemi panel. Okay. JC virus PCR. Anything else we need? That should be enough. CSF culture was negative.
CMV disease would explain cytopenias and CNS involvement. No fundus involvement. There is no GI disease. CMV PCR perhaps.
So we like to have bone marrow to rule out systemic disease. There was bicytopenia or pharyngeal biopsy. Yeah, okay. Brain biopsy, that's what was contemplated, but relatives were not willing for brain biopsy at this point of time, actually. No, sir, no. Okay, so it's basically non-infective things which comes to our mind and we like to go ahead with ART. So what we did is we did bone marrow because we were suspecting CMV also. So we did bone marrow aspiration biopsy, which was normal. Serum CMV PCR was negative. CT chest abdomen to rule out if there is something. That was normal. CSF cytology was done twice, which was negative. EBB, Toxo, JC-PCR, all were done and all of them were negative. VDRL, CSF VDRL was done, that was negative, and even the multiplex PCR was negative. So we are dealing with non-infective etiology and we should be started with ART now. Yeah. So
With such low CD4 count, although gene expert is negative, can TB and vasculitis can cause infarcts.
TB vasculitis can cause infarct. So what else should be done? My dear gene expert, twice it was done, which was negative. AB cultures were sent. We could have done pyrosequencing at that point of time, but yeah, it was difficult. We used to send it to Hinduja. We do send. So this was 2017. I had just started using DTG, so I was not sure about DTG and Daru CP score or penetration. So what I did is I started on TDF, 3TC, Darunavir, Ritonavir. Subsequently, there was no improvement and he in fact had worsening of disease. There was left upper limb, lower limb weakness, which was initially not there. At least he was moving, walking, talking. Then he had poor gag, 9-10 involvement, left gaze palsy, and dysarthria. So the lesions were worsening. Here you can see extension of lesions, worsening of lesion in the internal capsule and all. So it was a worsening disease despite of being on ART. And this was a picture when he came to us a month later. He had palatal ulcer, which were bleeding, and the disease was worsening. So what was happening to this patient? Did I miss out something?
You want thinking histoplasma?
Okay. Anything else which is possible? But this time the platelets were normal, though he had a bit of low hemoglobin, but then the counts and platelets were normal. So we did biopsy it, but biopsy didn't give us anything. It was just a necrotic lesion and the fungal cultures, everything was normal. In fact, we asked for whether it is HSV or some other this thing, but that was also negative and there was nothing. So why was he not settling? That was a question coming to my mind. What is it that we are missing out? So was it a slow responder or there was some other OI which was undiagnosed? Was it a paradoxical worsening or the primary diagnosis was incorrect? And so how should we go?
The primary diagnosis is PML and you put them on ART.
ART, yes.
30% will improve, 30% will remain stable, 30% will worsen. So if you're telling me I have put on antiretroviral therapy, patient is worsening, the MRI shows only worsening lesions. It does not show any new granulomas, new meningitis. You have taken the ulcer biopsy, it has not shown anything. I would still feel this is worsening of PML, which is quite likely. It happens on antiretroviral therapy. So when we put patients on PML on treatment, we tell them that 30% chance you will improve, 30% you will stable, 30% you might worsen, go into respiratory failure and die. It can happen. So as far as the case goes, I think looking at all the scenarios, I think this could be PML with worsening. HIV encephalopathy normally doesn't worsen. It will improve to some extent at least. So
Would we need a CSF HIV viral load?
Yes, we did CSF HIV viral load. That was negative actually. So even we thought of CNS escape or something, but that was not there. And there was persistent worsening. We did repeat CD4, which was improving. Viral load, they were not willing at this point. So we didn't repeat HIV viral load, serum HIV viral load. But then he was virologically controlled, at least immunologically improving. But we couldn't do that viral load. CSF, repeat CSF we did, that was normal. Palatal biopsy, as I said, was normal. Since it was necrotic lesion, we did CTPNS also, that was also normal. So CSF viral load, as I said, was normal. So how often do we see CNS escape and how do we manage these patients? Because every now and then, since they are long-term ART and patients are doing good, we do see, like last month I had a patient who was on ART for a decade and then he came with memory loss. So how do we manage these kind of patients?
The CSF viral load was suppressed.
And the CSF viral load was suppressed. And this patient also, the CSF viral load is negative. So what do you label this patient and how do you manage these patients?
So I would still label this patient as worsening of PML because everything else we have taken care of. And the only thing is the brain biopsy, which can prove it. Again, JC virus PSC PCR of CSF does not have that much sensitivity to diagnose PML in HIV positive patients. So just by saying that the CSF JC virus PCR is negative doesn't mean you have ruled out PML. This is a fit case for a brain biopsy to look for what is going on. Secondly, this is again anecdotal. For CSF escape, we shift to better penetrating drugs in the brain. But increasingly over the last 5 years, I have realized that shifting to better penetrating drugs in the brain for PML also works sometimes. So few of my patients, I have tried going back to zidovudine, lamivudine, dolutegravir. Dolutegravir has excellent penetration, zidovudine super penetration. So we take a risk with anemia and give it. Few of them have responded. I don't know how it works. But because it was working in CSF escape, I tried it in PML because more of they have overlapping features. So there is no data about this, but that is what I try because there is no data about this.
Okay, so this was already on Darnavir and he had anemia, so there was no question of putting him on zidovudine. Actually, there was a persistent anemia. 7, and it was in that range, 7, 8 something. In between, he required transfusion also. So what should be? So basically, this patient who had received steroids, there was a label on vasculitis. So whether this is HIV vasculitis, which is a not so common entity. So that was a question coming to my mind, and I was worried whether adding steroid will help this guy or not. The only hitch was this guy had already received steroids, high dose steroid, and there was absolutely no response. So how do we go about it? So in fact, we thought of, this is just a data about the sensitivity of EBV, toxo, JCPCR. So JCPCR sensitivity varies 70 to 93%. So like you said, probably it was PML also. But then the thing was, I was thinking whether I had missed out vasculitis, something which is treatable, manageable. And if we offer steroid or some immunosuppressant, if he improves, because he was a young guy. So we just looked at the literature of HIV-associated vasculitis, and it's basically a diagnosis on biopsy. And biopsy, we were planning to send this patient to NIMHANS, but then we lost this patient. So the incidence is 1 to 5% somewhere. Basically, it is related to immune-mediated akin to primary anxieties of CNS, or it can be because of direct action on of the HIV. And it's a gold standard for diagnosis of CNS vasculitis is histopath, evidence that which shows vessel wall inflammation. The differentials are many, and the reasons like we have CMV, HSV, all these we have worked up. It can be connective tissue, like we are seeing, it's more of a non-OI, which we see a lot of rheumatological issues also in HIV patients, and we have to keep these issues in mind always. So this is a diagnosis of exclusion, and that's why we had worked up thoroughly, because that was there in back of my mind always. So I had worked up thoroughly, but unfortunately we couldn't do brain biopsy to establish this diagnosis. And there is hardly any literature for to support the diagnosis or the management of HIV-associated vasculitis. Ganga Khedkar sir, I'd like to know from you should we really suspect HIV-associated vasculitis, or because we don't see it that common. It just came to my mind in this patient because there were multiple lacular infarct. So,
you can suspect anything, but there is no evidence.
Vinay sir, yeah. So when he came to me, the complete. Okay. We had taken rheumatopenion, and the initial rheumat workup was completely negative. Actually, there was no other systemic vasculitis symptoms, or there was nothing else on the CT also. No other vasculitis signs, no other infarct apart from CNS.
Would some kind of vessel wall imaging have helped establish vasculitis as the pathology?
I didn't mention it. We did MR angio, but there was no blockage, nothing. So the other patient, which I am saying now, we did MR angio. This was 40-year man. So we did CSF viral load, CSF JCPCR, everything which was negative. and these were lacunar infarct. So the neurologist started him on ecosprin and clopidogrel, and his memory loss, all those things improved. So another question is, how often do we see this phenomena, and do this patient really help? Dr. Amit, do you see this in your practice?
Vasculitis?
Vasculitis or the infarct on treatment, like we're seeing they have more of a thrombotic tendency, increased inflammation. We're seeing more of a non-OI complications. So
That is a given. Our patients are getting elderly. They are having, as I always mentioned, major adverse cardiovascular events, a lot of them. And not vasculitis, but thrombotic and embolic tendencies we have seen. So that's why I said now time has come where we put everybody on steroid, on statins.
Statins and probably.
So maybe that will prevent such kind of complications. But treatment, I agree, you are stuck in a difficult place in this case. But I would have treated it as worsening of PML. I would
PML
have
only.
shifted his treatment to some better drugs, dolutegravir and zolpidem, and taken a call because you have done MR angio and it does not show vasculitis. So MR angio at least should pick up something. And you have given steroids, it has not improved. You have given methylprednisolone, it has not improved. You have given oral steroids, it has not improved. So
No, it was in the initial phase. After that, I didn't give steroid because it was not sure what is happening.
yeah, so once steroids, such high dose, 1 gram has been given, I would prefer going towards PML rather than vasculitis in this case, and try changing just his ART.
I think we'll wrap up the
Sure. Yeah, thanks.
Just
Let's
one
move on
last
to
comment.
next. We'll
One
move
last
on.
comment. I think one more point against vasculitis is the distribution of the lesions throughout the brainstem, both sides, thalamus. Tough to explain that through any particular arterial territory. So I think it goes more in favor of PML.
We can have
pertaining to one territory. In fact, that is the hallmark of small vessel vasculitis, where multiple territories can be. It will not follow a particular vascular, means a distribution of, say, MCA or any of the anterior cerebral or anything, because these are small vessels. Yes, so yeah, I'm not defending that this is vasculitis, but I'm just talking about the territory. That's about it.
Yeah, so we'll move on to something perhaps more trivial than the first triptych case. So this is a 48-year gentleman who presented to the emergency department at Jahangir Hospital with fatigue and myalgia, which progressed for over 3 to 4 weeks. Prior to that, he had a history of muscle cramps for several weeks. There was a polyuria and increased thirst, dysuria in form of some burning sensation and some non-specific urinary symptoms. And on presentation, he had rapid breathing and palpitations also. The initial labs done at the ER showed metabolic acidosis. Then there was proteinuria, glycosuria, and ketones were negative. Creatinine had gone up. He was anemic. WBC platelets were normal. Sugars were normal. And there was hypokalemia and borderline sodium levels. So at this point of time, he was admitted under the nephrologist who referred for ID opinion for adjusting dose of ARVs, as the patient gave history of RVD and being on TLD-based therapy for the last 2 years, prior to which he was on TLE. And the patient claimed that he was 100% adherence and said that previously whenever he was tested, he was having a good control of the disease. So the question to the panel is, which of these 4 possibilities is least likely in this patient?
Is virally suppressed, right?
That's what he claimed. At this point, we don't know the current viral load.
Okay,
But history-wise, he does say that my viral load was well controlled.
Of course, HIV associated abdominal nephritis is least likely in this case, if he is virologically suppressed.
I think I also agree with that option D. No no edema. Normally there'll be renal insufficiency, high potassium. This is looking more like probably a non-anion gap metabolic acidosis with renal loss. Option D probably.
I would go with option B, Ivan, because patient is on treatment for almost 2 years. Ivan normally develops in patients who are very low CD4 count and not on treatment. So, and we have practically given up seeing Ivan now in our practice because so many of our patients are on treatment. So my answer would be B. If his viral load is still high, immune-mediated disease could happen.
Yeah, so all throughout he was on a TDF-based therapy. So according to me, the first most likely differential was tenofovir toxicity, followed by diabetic kidney disease or HIV-associated glomerulonephritis would be more or less equal. Heman, as rightly said, is the least likely because he was on he was quite adherent with a quite potent regimen of ARBs. So further investigations is HbA1c was 5.8%. There was proteinuria more than 1 gram, no hematuria. And as we can see, there was low albumin, bicarbonate, phosphate, and uric acid. So which test would you like to do? And what ART would you plan in this patient at this point of time?
I'll order a CD4 viral load, and pending which it looks like TDF toxicity to me, considering the potassium 2.8, create 3.5, most likely is a TDF toxicity. I would maybe stop ART for some time till the creates reduces and then restart after say 7 or 10 days.
Stop ART altogether, or would you like to modify the ART?
Why not? What is stopping ART for 7 days? How is it going to matter? This patient is on dialysis, I presume now. With
No, not yet on
not
dialysis.
not on dialysis, but on conservative management. But stopping ART for 7 days, what's the problem? Directly again, if I have to give him abacavir, I have to do the HLAB 5701. That will take another 3 days to come. I can't put it blindly. So stop TDF, which is most likely the problem. His sugars were I think 106.
Yeah.
I would do an HbA1c to look
Yeah,
for.
Yeah, it was done.
It's 5.
It was done.
So even the phosphate is low, I guess now.
Yeah.
So
phosphate is
so looks more like TDF toxicity. Taking the you don't have the option, but DTG3TC might be an option here if
Yeah,
his
that's
viral
also-
load is suppressed. So I would send a CD4 viral load. And if you are insisting on giving ART, I would give DTG3TC. Wait for 7 days and then check what's going on.
Okay, so anyway, so I'll briefly cover about the renal manifestations with HIV. So as we can see from all the possibilities that were discussed, thrombotic microangiopathy, diarrhea-related prerenal AKI, all these things are fairly common in HIV patients. Drug toxicities usually would be more subacute to chronic compared to acute presentations. Although some drugs like because of co-administration, they can give acute tubular necrosis. CKD again, predominantly it is thrombotic microangiopathy, coexisting diabetic nephropathy, and then of course toxicity of various antiretroviral drugs. Now this patient, according to me, fitted more in what we call as a Fanconi syndrome because he had most of the factors which are there in Fanconi: hypoalbuminemia, hypokalemia, hypouricemia, and hypophosphatemia. Proteinuria is seen in Fanconi syndrome, but usually it is non-nephrotic range, which would be sort of differentiating from HIV-associated nephropathy, which would be more of nephrotic range proteinuria. There can be glycosuria with normal or low blood sugar levels. And of course, there is excretion of all the phosphates, amino acids, and bicarbonates in the urine, which are because of proximal renal tubular acidosis. So, about renal biopsy, I think none of the experts chose for going for kidney biopsy, rightly so. So, kidney biopsy in HIV-infected patients with renal dysfunction is indicated if there is new onset proteinuria, especially if it is in nephrotic range, or if there is accompanying hematuria, so which would point more towards glomerulonephritis rather than a tubular toxicity. Then, if there is rapidly progressive glomerulonephritis, or if there is clinical evidence of thrombotic microangiopathy in form of HUS or other features of TTP HUS, and if there is a CKD of unknown cause or rapid worsening of the renal functions. In the current patient, he was more or less managed conservatively. HLA-B star 5701 mutation came positive. HBsAg was one thing which we did additionally because I wanted to shift him to dual ARV combination with 3TC DTG. CD4 count was good and a viral load was below detection limit. So he was switched to the 3TC DTG combination. And after that, almost now 18 months follow-up, he is doing well. With the final diagnosis being RVD with TDF-induced Fanconi syndrome with CKD. And so far, the patient has not required any dialysis. So, bringing notice to this thing, what do you all follow in terms of screening for renal disease in PL HIVs when they are on a quite efficacious and adherent combination ART. I mean, like I mentioned in the beginning, we all have set protocols for screening for PCP, toxo, CRAG, and all those things along with OI prophylaxis. So going forward, what should be our protocol to screen for renal disease? Because with TLD being the standard first line ART, this is more and more likely. And as I'm sure all of us see every 3 or 6 months, at least 1 or 2 patients who have TDF induced nephrotoxicity, which could have been picked up much earlier and prevented.
In general, once a year we do that KFT, serum electrolytes, urine routine. Usually that is enough to screen for most things over here. You'll pick up urine protein, urine RBCs, urine glucose, serum phosphate, and creatinine.
Any other?
Yes. So urine routine will help. That is the first thing which will come abnormal in this patient. So many times all our patients, so this guy who has presented with a creat of 3.5 and acidosis, if he would have had a urine routine done 1 year back, he would have definitely shown proteinuria, glucosuria, and we also check for creatinine clearance because many of our patients don't have that much amount of muscle mass.
Yeah.
So all these guidelines were actually made for 100 kg Americans. The same TLD we have picked up and we are using for 50 kg Indians, sometimes even less, 40 kg Indians. So we presented a paper 10 years back saying nephrotoxicity was 5 times higher in Indian population, Asian population per se, as compared to the Europeans, because Europeans average weight is 80. Muscle mass, fat is much, much higher than this. We are, if you look at our patients, they hardly, when they come first to us, they hardly cross 50. So giving the same tablet to them is going to have issues. Fanconi syndrome will always start with proteinuria and glucosuria. The creat will slightly increase from say 1.1 to 1.3. And then many times because the cutoff is 1.5, they will say, no problem, continue. But if you go back and check the creatinine clearance, it must have dropped below 50. Once it drops below 50, we have to start making adjustments. Either increase his weight or change your tablet. So that is what we do. Increasing weight is not possible. So we changed. And now we have DTG3TC, we have TAF. So we have multiple other options which we can go to. So if you don't intervene that time, 1 year later, the patient will end up where you might require drastic measures like dialysis. It can happen. And then once you stop the treatment, then the creat clearance will never come back to normal. So many times we have had patients coming with creat of 8, 10, requiring dialysis, stopping TLD. Even after 2 years, the creat is still 2.1. Then what happens is, as they age, diabetes takes over, and then the creat comes back to 2.1 and again starts going up because already the kidney is compromised. On top of that, you are now having hypertension, diabetes. Many of our people pop the combiflam left, right, and center for body pain. Again, this starts happening. So this has happened many times where the creat has come down, patient has not required dialysis, was dialysis free for almost 5 years, creatinine went up again required dialysis. So this is where we need better prevention rather than treatment.
Completely agree with Amit sir about the simple two tests even in government programs. This discussion is going more of favor in government programs because everyone is getting TLD in government programs now, and even government program has incorporated creatinine and urine routine 6 monthly, but sometimes it is not being followed rigorously. If these two simple tests, not even electrolytes and all KFT and everything, but simple creatinine every 6 monthly and urine routine, and not ignoring 1+ proteinuria on DIPST or simple rise in creatinine, marginal rise in creatinine, and calculating creat clearance is a simple thing that can be done easily. But sir, I will contradict with the thing about European data and using same dose tenofovir in India. We published one paper during my ID curriculum. We found UK data and Indian population. They were having same nephrotoxicity risk, even though weight and age and tenofovir exposure was compared.
Yeah, so I think as rightly pointed out by the panelist, given the low muscle mass and body weight in most of our Indian HIV patients, I think barely relying on serum creatinine is not enough, and we should incorporate a routine urine analysis at diagnosis as well as at beginning of ART and at timely intervals, especially if they are on a TDF-based regimen. And things like the way we screen for microalbuminuria and other things in diabetic population, even in HIV patients who are on TLD should be routinely screened for that. We'll move on to the next case. Okay, I'll look on. Okay. So going for one comorbidity to the other. So here we had again middle-aged gentleman coming with typical anginal chest pain. He's a non-diabetic, hypertensive, and RVD patient on ARV for more than 10 years. The current regimen being TLE, and the OHs were metformin and sitagliptin combination, on which he was fairly controlled. He was diagnosed with acute anterior wall MI, underwent PCI requiring the placement of drug-eluting stents, and he was, as a routine protocol, started on Brilinta, Ecosprin, and rosuvastatin by the treating cardiologist. And at this point of time, the CD4 was 337. The viral load was 588 copies. And patient claimed around, he said, more than 90% of times I take my tablets regularly, but I tend to miss 2 or 3 pills in a month. So if we come to cardiovascular diseases and HIV, so which of these statements is or are true when it comes to HIV and CVD risk? So HIV raises the cardiovascular disease risk by more than fourfold. HIV is associated with increased risk of only coronary artery disease. Traditional risk scorings apply to PL-HIVs as they do to a general population. Then in now this gentleman had MI, but if there is a say asymptomatic individual who is found to have coronary artery disease on routine screening, say CT angios or after TMT and all those things, is combination ART more important than coronary revascularization interventions for survival? And with DTG based first line ARTs, do we need to consider drug interactions in such cases at all?
So HIV raises the risk of cardiovascular disease. True. But twofold. Fourfold, I don't know. I have read twofold. HIV associated with increased risk of only CAD. No. All major adverse cardiovascular events, right from cerebrovascular, cardiovascular, peripheral vascular, you name it, it can happen. Traditional risk scorings apply to PL-HIV as well, yes, but not as accurately as it is for non-HIV population. So if you look at the cardiac risk score, it might not be as accurately applied to non-HIV population as it applies to. It might underestimate the risk of cardiovascular risk because we are not taking into consideration two factors, HIV and ART, both of which now are now proven that this can increase the risk. In asymptomatic individuals found to have CAD-CART is, I think revascularization is more important here because he already has an anti-wall MI.
No, not this man. This is
He
is asymptomatic. Yeah.
Asymptomatic. I don't know, frankly. With DTG based first line CART regimens, drug interaction is not an issue anymore. I would not hazard to make a statement like that, but yes, whatever statins we are giving, say atorvastatin, rosuvastatin, pitavastatin, can be reasonably safely given with dolutegravir. The problem is with ritonavir-based atazanavir, ritonavir-based lopinavir, where there can be an issue. And we had a case where the patient was on ritonavir-based atazanavir and was given amlodipine 5 milligram and landed up with a BP of 70-40 and with ARF. And then we were not understanding why the patient landed up. It was because the amlodipine levels went sky high secondary to ritonavir. So once ritonavir or efavirenz come into the question, then the interaction levels go haywire. Dolutegravir that way, even for transplant recipients, is much safer. So even with your transplant medicine, it is safer. I don't know the fourth. I really don't know.
Yeah, so as rightly pointed out, the risk is around 1.5 to 2 times higher with HIV, and it is still far more with conditions like diabetes, smoking, and dyslipidemia. But when more than one factors coexist, which is the case in most of our middle-aged HIV patients, this risk is definitely multifold higher. This I think I'll skip for the lack of time. And as rightly pointed, the traditional risk calculators, they underestimate the CVD risk in PL-HIVs. Now, this was about the drug interaction. So if we see, most of them are with the boosted PIs and very less so with dolutegravir. Now, in coming back to our patient, what about the OHs and ARVs in this man? His viral load was 588 copies on TLE, and he was diabetic on a oral hypoglycemic agent. So I think metformin and sitagliptin. I think with more and more polypharmacy, we need to know at least little bit about cardiac drugs, OHs, renal drugs, and so on. So metformin co-administration with dolutegravir is sort of known to increase metformin concentrations. And if this patient also had some tenofovir-induced tubular toxicity, then this can increase the risk of lactic acidosis even more. And there are, of course, other issues with sulfonylureas, insulin, like weight gain, which is anyway also an issue with DTG, TAF-based regimens. Any takes on ARV in this patient? With that viral load of 588, acute cardiac event, and him being on TLE.
But he's not taking his treatment.
Around 90% adherence is what he claims.
I think he needs to first start taking his treatment regularly. But why not shift him to
the DTG based?
Yeah, DTG based regimen. What is his creat?
Creat was normal.
Normal.
Yeah.
So even TLD will work fine. The problem is now this guy is having a cardiac event. I would not immediately give him TAF because again TAF will increase his weight. It might increase his abdominal fat. It might worsen his lipid profile. So TDF, lamivudine dolutegravir, actually is an anti-weight gain pill and an anti-lipid profile pill as well. So you add your pitavastatin, I have no problem, but TLD actually works fine for weight gain and for lipid profile as well.
Yeah, so going to the dyslipidemia part, as we have started discussing. So again, out of all these statements, which all are true and applicable in a HIV patient with dyslipidemia? So statins reduce inflammation also in PLHIV in addition to reducing the harmful LDL cholesterol. Then every PLHIV, I think this was briefly touched upon in the previous lecture, should be on statins. Then HIV should be considered as an added risk for decision about statin initiation, like we do with smoking, diabetes, hypertension, and other things. Then non-calcified plaques are more common in PLHIV than general population. And DTG has positive impact on lipid profile. And last one, anti-inflammatory medicines beyond statins, not steroids, which may be needed for optimum risk minimization in HIV patients. Or is statins enough?
Sorry. Statins reduce inflammation in PLWH? Yes, they do. Every PLWH should be on statins? No. 40 to 75 with low to moderate risk of cardiovascular illness, everyone should be on a steroid, a statin. Above 75, no brainer, they have to be. If you are diabetic, no brainer, and HIV, no brainer. HIV should be considered a risk enhancer for decision about statin initiation. Yes, the study has proven it. It has to be given. I don't know about these plaques. I don't know, but they might be more common because the cardiovascular risk is more higher. DTG has positive impact on lipid profile. Depends on what you give along with DTG. So if you give TAF, abacavir, it might worsen your lipid profile. If you just give DTG 3TC, it might improve your lipid profile. If you just give TDF 3TC, TDF I have already said, anti-weight gain, anti-lipid profile. So it might improve your lipid profile. And I don't think anti-inflammatory medicines are required, but you might require aspirin. If you are really at high risk of cardiovascular illness, you might require aspirin along with statin. Otherwise, only statin. But only statin will become a norm now, at least in 40 to 75 age group, because almost all our patients will be either low or intermediate risk for cardiovascular illness.
Might sound a bit non-clinical, but as we are discussing more on dyslipidemia and metabolic syndrome at ID conference, if we are going to look at patients aging further and further and getting these metabolic syndromes further, can we all start counseling patients for their diet controls, their exercise and lifestyle modifications? Because more and more patients, what we are seeing nowadays, once they get somehow burden free, and they understand within 6 months or 1 year of time that they are going to survive a normal lifespan, we are looking at their lifestyle, which is getting risk free. And maybe our counseling in our OPD since day one of the HIV therapy might help them to at least prolong these metabolic syndromes.
This question was answered in the pitavastatin study, where they said that in addition to diet, in addition to smoking cessation, in addition to exercise, on top of that, statins were helping. So healthy life, definitely, that starts from day one. But once you start start aging, then statins help over and above the routine advice we are giving to all our patients to get fit.
Yeah, so again, dyslipidemia is again multifactorial, and as much as the other factors, even inflammatory cytokines do play a role in HIV-associated dyslipidemia. There is no doubt that it should be considered as a CVD risk enhancer. Now, like already mentioned, intermediate, like borderline to high risk, everybody should be on statins. And if we see impact of dolutegravir, various drugs on the lipid profile, then individually speaking, dolutegravir does not have much of impact on total cholesterol and LDL, but it does increase HDL, which is supposed to be a beneficial cholesterol, and reduces triglycerides as well. So maybe, of course, depending upon what is the accompanying drug, but DTG by itself perhaps has a positive impact on the lipid profile in these patients. And then vice versa, as far as the statins with various classes of antiretrovirals are concerned, then most of them are fairly safe with instis, although they do have significant interaction with PIs and NNRTs. And this was the last point that there are already studies and trials in Western literature, because perhaps they face much less of OIs than us and they are more into cardiovascular morbidity and mortality. So there is something beyond barely lipid control, which is required to reduce cardiovascular disease burden. And that is to do with the inflammation which is there in these patients. And there are studies on things like PSCK9 inhibitors and low dose methotrexate, colchicine in some of these patients to reduce inflammatory cascade and reduce the cardiovascular disease related risk. Now, this I think Amit sir has already touched upon in his previous talk also. On this one, I would just like to know one thing. In such patients, of course, with nephrotoxicity, we are going from TDF to TAF. Would you want to go from TAF back to TDF if a person has a significant cardiovascular disease which is already clinically manifested?
Switching from TAF back to TDF.
Yeah, TDF to TAF, I think because of nephrotoxicity, everybody is going there, but reverse switching.
If I'm not mistaken, there was a study which looked at this, where they switched from lipid bad ART to lipid friendly ART versus just giving statins.
Yeah.
And I think the statins scored above changing ART. So the giving statins was better. So if I have to switch already because of nephrotoxicity, I have shifted from TDF to TAF. The patient is suppressed. Now he is going into high cardiovascular risk. I would still initiate a statin first or an aspirin, depending upon his cardiovascular risk. If it still does not stop, and if he keeps on gaining weight, the problem is not about cardiovascular. The problem is he keeps on gaining weight. Then I might be forced to go back. And TAF DTG together is a very deadly combo for weight gain. So I would then prefer going back to DTG 3TC. If the patient is HbA1c negative, it will take off the TDF TAF altogether with all those toxicities gone, and DTG alone will be remaining. But I'm not sure there will be weight loss once I do that. So the problem is, once you gain abdominal fat, you gain muscle fat, it doesn't reverse. And that's why the semaglutide trial came into being, because they tried stopping DTG, going to nevirapine, going to rilpivirine, and the weight gain was not as much as was demanded. A patient who is almost touched 100 kg can't suddenly become 90 kg because you stop dolutegravir. It will still remain. So some of it is coming of age, where the weight gain is because of the loss earlier. but some of it is over and above. So people are saying, I have never touched this weight ever in my life. And the problem is with women on TAF and black population, which is, we are all brown, so we might as well classify as black. On TAF plus DTG, highest weight gain. So if you look at women on TAF DTG, first year they will gain almost 7-8 kg, which is humongous. So, and sorry for the comment, but women are more careful about their body shape rather than men. So they say, "Nee, far motive hot challe, you change the treatment." So I have had to change ART because there was too much weight gain. More in women, less in men, but it is happening, and the problem is the same.
Yeah, so just to summarize the whole thing again, we can use the standard risk assessment tools when it comes to PLHIV, provided they are virologically suppressed, and then add additional 1.5 to 2% added risk compared to a general population. So that makes most of the people in high risk or intermediate risk category. So for low to moderate risk, they are quite clear. It should be lifestyle modification and yearly reassessment. For moderate to high risk, lifestyle optimization plus a statin is a must. So that should, I think, be the take home point from this particular case. I don't know if we have time for.
We have only 10 minutes left for in the panel.
So moving on to next practical issue, what we face is bone issues. So cardiometabolic, nephro, all we have covered, and now we have TAF and TDF. Particularly in the government program, we have TDF, and majority of our population is on TDF. So bone problems we are seeing more often. So this was a gentleman who was on treatment for 10 years on TLD, no comorbidities. He was a smoker, was taking gutka also, had some hairline fracture a year back, and presently came with fall, and this was the X-ray actually. So the question is, how often do we see fracture or bony complication in our population? What's the impact of HIV on this population, and what's the impact of ART in this population?
HIV and ART have definitely progressed osteoporosis in patients, particularly tenofovir again, which is hampering bone health in patients. And definitely everyone is seeing bone BMD scans showing osteoporosis of further progressed as compared to their comparator age population.
So before I ask this question, can I ask how often do we really screen bone health in our population? We have grown up to screen cardiometabolic, nephro, but practically speaking, I have never screened patient for bone health in my population. Probably after this, I'll start screening. This is a honest confession. But how often do we screen our patients?
Not something I do routinely at all.
That's what, yeah. So, do we really see these complications often in our patient?
So we were stupid enough to actually do a bone marrow scan, BMD scan for all our patients in 2017. We got a grant and we did it for everybody who was on antiretroviral therapy. And we realized certain factors we did pick up that around, see, our patients anyway have poor bone health when they come to us per se, because they are HIV positive, they have low CD4 counts, they are nutritionally inept, because of which they already have weak bones. What happens is, once you start antiretroviral therapy, this was what the study said, once you start antiretroviral therapy, any antiretroviral therapy you start, whether you start zidovudine, stabudine, tenofovir, abacavir, anything, for the first year, you will lose around 4 to 6% of your bone mass, and then it will come back to normal. And then you will start improving once your weight gain starts. Problem is in certain population, elderly males, post-menopausal females, and remember, our HIV positive patients attain menopause a decade earlier. At 40 only they are menopausal. So their bone health is already going down. Then there are patients who are on steroids for iris or for other conditions. They are diabetic. So they are CKD. So all these things, on top of that, you are adding one drug, which is TDF. So only ART is not the factor which is causing all these issues. It is the cherry on top. So the earlier there is a problem, the cherry on top is the TDF. But now we do keep asking. After that study, we kept on asking about bone pains in all our patients. And you will see it is easy. Whenever there is a fracture, I always ask the patient, "Kashe padle?" Many times they say, "Sir, काय नाही, फक्त खाली उतरले एक प्लेट आणि फ्रॅक्चर झालं." That is actually a fragility fracture. And many times patients won't come to you for your fracture. They'll go to an orthopedician, they'll fix the fracture and come to you after 6 months saying, "मला fracture झालं होतं म्हणून तुम्हाला भेटायला नाही आले." That is actually a fragility fracture. So fragility fracture is very common. And if we get and they start developing this spine pain. सर ते पाठीमध्ये फार दुखतं, चालताना असं दुखतं, किंवा ते इन नॉर्थ महाराष्ट्र they say बोन्सचा कटकट आवाज येतो. That is one thing which tells you that maybe on TLD there is a problem. And TAF is a welcome addition, or DTG3TC is a welcome addition, because there have been patients who have been shifted just on bone pains. I have shifted TDF, and then there is a salutary benefit over 1 year. I always tell them ki he dukhno lage janar nahi. It will take almost a year, but after a year they say ki no, I'm feeling much better. So TAF, abacavir to some extent, but DTG3TC also is actually a godsend for patients, because this is a silent epidemic. CKD, AKI is actually more in your face. But a bigger silent epidemic is osteopenia, osteoporosis. Osteopenia, not much, but osteoporosis definitely. And as I said, elderly male smokers and postmenopausal females, which are a big category, are going to suffer a lot. So if we are having ages now of 40 plus, 50 plus, almost all our females, if we start checking them, will be either osteopenic or osteoporotic. Because on top of menopause, you are giving one more drug, which will worsen it.
So like you said, yeah, it's multifactorial actually. So this was a meta-analysis 2020, which they found that almost 6% of the population had twofold increased prevalence of fracture. And there are multiple studies which have 2 to 3%, 4%, risk of osteoporosis varying from 23 to 34%. So definitely it is there. And if we compare naive versus treatment experience, the risk doubles actually. And there are multiple papers which have shown that. So the question is there any role of calcium or vitamin D screening in this patient, and the role of anti-osteoporotic drugs? What's the place of these drugs in our HIV population? Do we really need to screen them for routine calcium, vitamin D, and supplement them?
Not very sure about the guidelines to screen someone HIV negative or HIV positive. How often should we screen some age group, or is it really beneficial? Maybe not very clear cut about the guideline of screening, because we don't have any concrete treatment for osteoporosis. Even teriparatide, denosumab, whatever drugs that are being guided for osteoporosis treatment, they can just prevent further progression of osteoporosis. They are not having very concrete results of reversing osteoporosis. And that's why screening tends to be, even in ortho clinics of HIV negative persons, symptom based.
So I'll tell you what I do. First, I'll change his ART. If I'm sure that he has developed osteopenia, osteoporosis, I'll change his antiretroviral therapy, because that is going to have the maximum benefit. Because you just remove the one culprit which is causing it. Calcium and vitamin D, calcium along with dolutegravir is another issue. So if you want to give calcium with dolutegravir, you have to space it either 2 hours before or after, or straight away give it 1 in the morning and dolutegravir at night. So you might end up not giving the optimal calcium dose. Vitamin D is fine. Many of our patients are vitamin D deficient. Giving vitamin D supplementation is fine. So you give calcium with a caveat of dolutegravir, give vitamin D, change it to either TAF or DTG3TC, watch for 6 months. If the symptoms still don't improve, then maybe you can give bisphosphonates. We have tried giving bisphosphonates, but again, how long are you going to give it? So after giving it for a year, you will have to stop it, because otherwise they'll cause their side effects. So I don't know the name, risidronate or something like that. Alendronate. We have tried, but again, after these 3 checklists have been fulfilled, that is now vitamin D normal, calcium is normal, changed his ART. These 3 things will work in majority of the patients. But if it doesn't, then we can try your teriparatide, you can try your bisphosphonates, all other things.
Okay. So yeah, please.
So in general, peak bone density is achieved by the age of 20, and after that it's a steady loss. So our aim is to basically prevent further loss. So apart from the change in the ART, I see no reason why we don't treat osteoporosis then the same as we would treat anyone else, right? So annual injection of zoledronic acid or 1 year of teriparatide to increase the bone density, which actually happens, following which we use bisphosphonates to prevent further loss. We can do that.
Yeah. So yes, I have just seen the guidelines, like Australian guidelines says like a daily dietary intake of calcium. Like you said, we have to space it with DTG. Calcium should be obtained through dietary intake, and exercise is really important because progressive resistance training with weight training is what is recommended for a good bone health. Vitamin D should be measured, and supplementary vitamin D should be given to those who have vitamin D insufficiency. So it is 50 or deficiency less than 25. Uh, Target is more than 50 should be maintained. Vitamin D supplement should be undertaken before bisphosphonate therapy is begun. And in those, like you said, who are giving calcium, we have to space it 6 hours before or 2 hours after the dose of DTG. The European AIDS Society guidelines recommend vitamin D levels for those who have positive history of fractures, low BMD, high risk of fracture, or any other associated risk factor like low vitamin D, dietary deficiency, dark skin, obesity, malabsorption, and CKD. So all this population, we have to screen vitamin D. The osteoporotic medications which are recommended are based on the BMD score and age, which includes alendronate, rosintonate, zoledronic acid, and teriparatide. So role of DEXA scan, like you said, in 17 you did all patients DEXA scan. We hardly do DEXA scan, and if we have to do, how often we should do, or is it really mandatory, or we have some other screening apart from DEXA scan, which can help us avoid DEXA scan in these patients?
I don't think it is mandatory. We just did it because we had a research grant and we wanted to look into bone loss in HIV. I would still wait for the symptoms, and the symptoms are there. So if you actually are diligent enough, I always say that like CSF escape, the patient will give you symptoms. If you don't say, then he will land up in some neurological issues. Similarly with bone pain, the patient will give you symptoms. And it is very non-specific. Sometimes the symptoms are non-specific and then we just put it on some psychosomatic complaints, this, that. But it is actually, if you're on TLD, maybe for at least for more than 2 years, then these things will occur, especially in women. It will happen. Smokers and males, it will happen. Either you do a DEXA scan or you tell them to shift because a better option is available. If you can't do a DEXA scan, you just shift his antiretroviral therapy. Unfortunately, in the free ART sector, it's not available to shift from TLD to something. And they don't shift because we write saying that this is osteopenia, osteoporosis. Then the patient has to understand, then comes calcium, vitamin D supplementation and tracking.
Probably after all these supplements, screening, and change of ART, if there are persistent symptoms, we can do DEXA scan and
Absolutely. Absolutely.
But what the guidelines say is DEXA scan is indicated for all postmenopausal women, elderly males, patient with significant clinical risk of fragile fractures, or someone who is going to be benefited with anti-osteoporotic medications actually. And there's something interesting, this FRAX tool, I've never used it, but I found it interesting and it's available online. So probably if we screen it, we can at least, so it's available with DEXA screening and without DEXA screening. So both scores are available, and it gives us idea about the risk of osteoporosis and fracture. So probably if we screen this in our routine practice, we can avoid DEXA scan and further investigations what are required.
I think the FRAC score, I think major osteoporotic fracture risk about 10% and hip fracture risk about 3%. You're supposed to intervene.
Yeah.
Because we did it on our patients, same thing. So if it's major osteoporotic risk about 10, I might be wrong, it might be 10 or 15, and hip fracture above 3 or 5.
I just tried it for the first time. I just entered my data.
Yeah.
Fortunately, I'm not.
So you are not osteoporotic, don't you?
Yeah. So choice of ARV we have already discussed.
But if we look at it, it is recommended in all postmenopausal women.
Yeah.
If you look at your population of women in HIV positive, so many will be eligible for a DEXA
Eligible
scan.
for this actually.
And now even men above 65, so many of your men will be eligible because they are aging so much. So there is a huge population there who should be ideal in an ideal world, in a resource rich setting, they should be.
I guess probably someone who is really virologically controlled and everything else is well managed. We should think about all this and add up to our basket for better benefit of our patients. Choice of ARV, I guess we have already discussed.
Just one, we have been talking about this. I would like to bring in one more risk group, and which is missed all the time, is children. Mother to child transmission, young children who are now 15, 20, 30, 25-year-old complaining of bone pains, you should look at, because we have seen people having fractures. So I think this is one of the risk groups which is definitely there.
The other important point is addition of bisphosphonate to cessation of TDF leads to great increase in BMD than just cessation of TDF and switch to TAP. So probably this is something new for me also. They're not taking our case, no? Yeah. So this is just a chart which will help us in screening. So we can do FRAC screening and replace vitamin D, do DEXA scan whenever required, especially above 50, and immediately after diagnosis of menopause. Once there is established diagnosis of osteoporosis, we can offer them calcium, vitamin D supplement, and bisphosphonate also. I guess we will have to learn all these points because that is what our population is going towards. And this was a good learning for me. Thanks so much, sir, for giving this opportunity.
So Piyush's cases were not trivial. Huh? They were all important cases. You unnecessarily made them trivial at the start.
I mean, compared to the first case, I said. Anyway, we'll just go to take-home points. So it is high time that now that viral suppressions and why better, we should go into and keep our minds open for non-communicable diseases in PL HIVs. There should be systematic screening protocols. As we saw, there are so many sort of ambiguity about what all to be done, what not to be done, how for what we have resources and which may not be applicable in our patients because of the cost. And we should start involving our other specialty colleagues who have sort of shut their minds out from HIV for last 3 decades. I mean, even when the patient goes to any other specialty and HIV is diagnosed, beyond that, nobody is bothered about looking into all these systemic complications in these patients. And so I'll close by the first thing I learned from Soman sir in very first week of my ID fellowship 10 years back, that during one of those typical waits outside lift in that big building of Hinduja. So he was just telling me and Dipti, to be a good infectious disease physician, one first has to be a good physician. And I think with all due respect to people who are practicing exclusively STDs or HIV, I think HIV is one disease where we have to be a good internal medicine physician to be able to manage all these complications well. Thank you.
Thank you, Dr. Piyush. Thank you, Dr. Ashwini. Excellent panel, excellent cases. I think we've come a long way from diagnosing HIV through OIs to now treating non-OI related complications in HIV. Thank you, the panelists. We now come to our next talk, which is on skin manifestations in HIV and STIs. I'd like to call upon Dr. Vinay Kulkarni, sir, who's an HIV specialist and consultant dermatologist at Prayas Amrita Clinic and Dinanath Mangeshkar Hospital. For the moderator, I'd like to call Dr. Raman. So you. Thank you.
थोडं ओळख करून देऊ का? काहीतरी करायला पाहिजे ना. It's my great pleasure to introduce Dr. Vinay Kulkarni, a good friend of mine, and perhaps one of those kinds of people who, despite being in practice, tries to become or has made definitive attempts to become a complete STD specialist in addition to skin as such. And the reason why I say that is you will find most of us tend to become biologic in our approaches. But if you look at his work on sexuality, it's as good as you can imagine on different populations, including normal people with whom or adolescents with whom he tends to work. I'm sure his talk is going to be really informative in a time when most of us believe that STIs are gone. It will help us to diagnose better even the skin diseases because most of us don't pay attention to that. Over, sir.
Thank you. Okay. Good afternoon. And Piyush ended it on a very nice note, telling that you have to be physicians. And for last 30, 40 years, I have been in this dilemma because the ID consultants and HIV physicians say that he's a dermatologist, he doesn't know anything about HIV. And the dermatologist identify me as, oh, he works only on HIV, he's not a dermatologist. So good for me to have this chance to talk about skin manifestations. And basically, because we are now having much less people who are doing exclusive HIV kind of a practice, it's nice that we interact with each other, and whenever you have any skin problems, you always have dermatologists at hand. But I would just like to go through kind of to try to make it a bit interesting because uh, as we know historically, it was because of the skin problems that HIV got kind of identified. So Kaposi sarcomas were the ones which came there and then had people with herpes coming back and then candidiasis, etc. So it was in India also, majority of the first people who started working in HIV field were all dermatologists and kind of things. What happens, I think, because of whatever, we are hungry also, I will rush through some of the things. We know that alterations in the cell-mediated immune response leads to organisms considered to be non-pathogens, can cause pathogenic infections, aggressive behavior of those who are well-known pathogens, and immune dysregulation is leading to abnormal inflammatory responses in HIV. Of course, there are other factors like climate, endemic diseases. So you are going to see diseases which are more common in your kind of milieu or the environment that are likely to be common than in the other parts of the world. So, of course, other socio-economic factors, etc. But what has happened after we started having heart is there is a 40% reduction in dermatological problems. So previously, when we used to work, and some of my students in early 90s are here, and maybe some of them would see the same slides again because they have seen the patients at that time. But we used to see that almost 90% of the people would have some kind of a skin problem and present with that. But now we see that there is a 40% reduction in dermatological problems because we are diagnosing early, because we are putting people on treatment early. And there is a 63% decrease in the number of visits to the dermatologist. So, of course, in pre-heart era, there were more of cutaneous infections, 66%, and 33% inflammatory diseases. But now cutaneous infections have gone down, inflammatory diseases have increased, and surprisingly and interestingly, there are 5 to 10% now visits to dermatologists for cosmetology purposes. So they want lipodystrophies to be taken care of, lipoatrophies to be taken care of. So, for example, previously we used to see ophthalmology as CMV retinitis and kind of things, and now they come more for cataracts and kind of things. So, because of aging, etc., also, but the infections have gone down. Of course, this is a cartoon which says that immunological deficiency leads to cutaneous infections, immunological dysfunctions leads to the inflammatory diseases. So, just a rapid fire. These are the commonest things. What is this? Candidiasis, herpes zoster. Now this is a bilateral one. There is scars on the other side, and there is a very common misconception about herpes zoster in our community that when it encircles completely, the person dies. And I used to say that that's a myth. But in case of HIV, I always find that that must not have been a myth, but must have been a good observation that anybody who has bilateral kind of a thing would have so much of immunodeficiency that the person is going to die. So I think this is a bilateral scarring. What is this? molluscum contagiosum, molluscum like, we'll have the differentials for that. Most probably herpes simplex infection, multiple ulcers, serpiginous lesions, warts, HPV infections. A bit interesting. Molluscum-like lesion. This turned out to be cryptococcosis. So from the archives, like not only the international history, but this is one of my patients seen in 2005, came with scar with herpes zoster scar. This is another patient in 1991, probably one of my longest surviving patients who is still around, seen in 1991. He had penile lesions. Then there is another one from 96, oral candidiasis, and treated with scaboma, that's gamma basil hexachloride. So scabies, no? So these are the kind of things which we are seeing that time. So we have typical as well as atypical manifestations of common diseases. We have skin presentations of systemic diseases. We have infections which could be reactivations or relapses of latent or subclinical infections. We can have allergic disorders, and we have cutaneous malignancies or malignancies is coming up in the skin. And all these are the important questions whenever we see any skin problem with HIV, we have to answer this. Could it be HIV associated? Can it inform us about the immune status? Would the management be different as in a non-immune compromised patient? And could this be related with the treatment itself? So these are the questions we should ask. So what we all do we expect? Common diseases with common presentations, and we should think of them right in the beginning. Then we have common diseases with uncommon presentations. We have uncommon diseases with common presentations of those diseases, and then we have uncommon diseases with uncommon presentations, and we should differentially diagnose in those kind of sequence only. So just a few cases. 53-year-old man who presents in a dermatology clinic with rash on chest, elbows, knees. Family history: mother with psoriasis, no tobacco, alcohol, daily IV drug use for 5 years. Multiple well circumscribed erythematous plaque. This is a classical kind of psoriasis, plaque type psoriasis everywhere. And now I keep on telling when I talk about psoriasis and HIV is that if you have seen psoriasis, the HIV and psoriasis looks a bit different. What the difference is, I don't know. But it could be having not a classical silvery scaling, but slightly violaceous tinge or something like that. And with this risk factor of intravenous drug use, we should be suspecting HIV in this person. Now, should every patient with psoriasis be screened for HIV? I don't think so. But at the same time, you should be having a high index of suspicion in patients and try to take the history of sexual history, etc., to look at the risk factors in patients with psoriasis. And psoriasis is a papillosquamous disease. So especially a patient with papillosquamous disease with lesions on palms and soles, send for VDRL TPHA, as Dr. Soman said, and then also look for psoriasis. It's a common disease in general population. When patients have pre-existing psoriasis, it may get worsened. Psoriatic arthritis is more common and severe in HIV positive individuals. Of course, the treatment, that all types of psoriasis is seen in HIV patients. The treatment remains similar. Now, the questions that are being asked to me in majority of the dermatology conferences, whenever they are talking about, because previously we used to talk only about methotrexate. That was the most kind of immune suppressant drug which we used to have in psoriasis. Now we have biologics, and then we have TNF alpha inhibitors, and then all other biologics, and when to use, how to use, should we use, etc. are the questions that need to be answered. But majority of the times, ART does help control of psoriasis. A 30-year-old man who presents with bumps behind his ear as well as white spots on his tongue and mouth. No history of diagnosis of HIV for 5 years. now has odynophagia also. So multiple discrete dome-shaped solid skin-colored papules with central umbilication. That central umbilication is an indication. We have to think of 4 differentials at least in umbilicated lesions. One is molluscum contagiosum, cryptococcosis, histoplasmosis, penicillosis. And these are the things which you should keep in mind whenever you see any umbilicated lesions. The simplest thing to rule out molluscum contagiosum you can do is take a needle, sterile needle, try to pick it. If that kind of the molluscum body comes out, it's molluscum. If it doesn't come out that easily, it is something else. Of course, this is oral candidiasis, and we know that molluscum contagiosum is very common. What I tell people is that perigenital molluscum contagiosum is to be looked at as a sexually transmitted infection, irrespective of the sexual history. So you have to look for the partner, you have to screen for other STIs, and you have to send for screening for HIV also. Candidiasis, of course, we all know, you are all infectious disease consultants, and apart from HIV, you are treating oral candidiasis. There are several types of oral candidiasis in HIV, and we have pseudomembranous erythematous, hyperplastic, and angular cheilitis like candidial infection. And of course, oropharyngeal candidiasis may coexist with candidial esophagitis. So odynophagia and dysphagia, many times previously we used to say that these are the symptoms and we should empirically treat with fluconazole because these are the commonest things that cause these symptoms. Patients may also exhibit chronic and refractory vaginal candidiasis, paronychias, onychodystrophies, and candidial intertrigo. So you have to look at the other sites where there could be candidiasis, and we have to treat it. Now, this is another case with a 55-year-old man who was admitted to the hospital for altered mental status and rash with numerous crusted lesions all over the body with minimal pruritus. Blood cultures were positive for Staphylococcus aureus. Diagnosed with HIV 9 years ago. Last CD4 count was 36, checked 2 months ago, and had dementia for 2 years. He had stopped heart last year with plans to restart them now that he had settled with his brother. The family history was non-contributory except that the brother had some itching on the body. Now what this could be? Large hyperplastic keratotic plaques with deep fissures, most severe in buttock and feet. Scale is poorly adherent and falls off on large spaces. It's a very interesting case. What this could be? Norwegian scabies, and this is another one with extensive scabies. And what is the problem with Norwegian scabies? We say that in an immune competent person, whenever even if there is severe itch, there are not more than 4 or 5 mites all over the body. But in Norwegian scabies, especially mentally retarded people, there could be millions of sarcoptic scabi. So you can just take a scraping and you can diagnose that. Immune suppressed and neurologically impaired individuals are increased risk. Present with thick scaling, immunocompetent contacts of person need to be treated. And fissures provide an entry for bacteria leading to increased risk of sepsis and death. So this person actually died because of sepsis in Norwegian scabies. Now just maybe as in the musical concerts nowadays, people have, because to keep the interest, you have some full songs and then you have a collage or whatever this is. Like we can go through the pictures of many of this. Uncommon dermatosis are cryptococcosis, histoplasmosis, bacillary angiomatosis, Penicillium marnefi, Kaposi sarcoma, malignant syphilis, etc. There are infectious diseases, mycobacterial, bacterial, fungal, viral, non-infectious, seborrheic dermatitis, psoriasis, just dry skin, papillopruritic eruptions. And sometimes we have diagnosed patients with HIV by just looking at the papillopruritic lesions all over the body. They have a very typical, peculiar kind of a thing that there is a central depigmentation with a hyperpigmented halo, very tiny lesions and extremely pruritic. If you see these kind of lesions in children or adults, do screen for HIV because it's very interesting and it's very specific also. So there are several mycobacterial diseases. I have put not tuberculosis on the top because we have discussed tuberculosis a lot, but leprosy can manifest as iris as well as independent disease in HIV. Actually, we had published this paper. I think this is the only paper, HIV and leprosy, which is there in the literature. It's probably there is a higher incidence among HIV infected people. Long back, 20, 30 years ago, people felt that we can have a resurgence of leprosy, which has not happened because of HIV. But we do see an increased incidence in HIV infected people, and it can manifest as immune reactivation syndrome. TB is a we know this, it's a common and deadly combination, maximum mortality in HIV because of tuberculosis, and it is 10 times increased when HIV infected people. Though pulmonary tuberculosis and extrapulmonary things are commoner, then still we do keep on seeing cutaneous tuberculosis. It's rare as compared to other tuberculosis, but we do see daily regimen preferred over intermittent regimen, category extrapulmonary sputum negative. We have to have 3 months of HRZD and continuous phase, not HR, but now we have HRE for a longer period. And Dr. Ganga Khedkar has mentioned this previously. This was one of the papers which he quoted from our data, which led to the guidelines moving from 3 days a week to daily anti-tubercular regimen. But these are some of the children, especially with HIV, who had cutaneous tuberculosis. And we see all kinds of cutaneous tuberculosis varicose acutis, lupus vulgaris, scrofulodema, as well as orificial tuberculosis. Atypical mycobacteria are common in immune compromised persons, especially if the CD4 counts are less than 100 or 75 or something like that. And so, especially in advanced immunodeficiency, we see atypical mycobacteria. And of course, we know that they should be given MAC prophylaxis. This is an example of atypical mycobacterial infection proven with biopsy and culture. There are several bacterial infections which are more common, and if you have recalcitrant bacterial infections or severe bacterial infections, then I think we should again be screening people, especially children. If any child has recurrent bacterial infection, we should look at the immunodeficiency. So these are some of the children, like recurrent bacterial infections resistant to routine line of management. Sarcinet impetigo in a HIV infected child. This is severe pyoderma recurrent resistant to routine line of management in a child. This is an interesting case. One of our friends, ID friends, many of you know, Pallavi was here when we had presented this. A milkman on 3-TC D40 and nevirapine regimen was transferred from outside hospital. No response to routine antibiotics to the skin lesions, which I'm going to show. Painful vesicular pustules and ulcers in various stages of ovulation all over the body. This was a small one. This is a large one. Another one on the body, multiple lesions, and this was the large lesion on the hand. He was a milker, had noted some infection around the nipples of a buffalo and continued to milk the animal, and buffalo had kicked the milker. So unusual viral infections, possibility, mycetomas. This was one of the differentials, and bacterial, Botryomycosis. Now that mycosis is turned red because it's not a fungal infection, it's a bacterial infection. So at that time, we sent the samples to many people. On the gram stain, we had GPC in clusters, culture group Staphylococcus aureus. Asked surgeon to excise and send for histopathology. Loads of bacteria and microabscess and inflammatory infiltrate in the dermis, culture group Staph aureus, MRSA, and case was labeled as Botryomycosis. Treatment with vancomycin was started, and he started healing and healed gradually, and over a period of a few months, the lesions were completely cured. So think about common things. Appropriate microbiological tests are needed whenever you are looking at any infections in HIV infected patient, and you should have a microbiology support. Fungal infections, dermatophytic infections are common. Lesions may be unusually widespread. Nail involvement is common, and all nails are rapidly involved. Proximal onychomycosis with whitish discoloration is a characteristic of HIV disease. So of all the nail infections, look at the proximal onychomycosis. Children, of course, with extensive fungal infection, intertrigos with candidiasis, tinea capitis in children, extensive fungal infection in adult. Two things you have to ask, whether the person is immune compromised or the patient is applying the commonest combos that are available in the market. This is called tinea incognito, and I called it as Fordham dermatitis, like all those combinations with multiple antifungals and steroids. There can be extensive fungal infections on the face, on the trunk. Of course, there can be candidiasis, severe candidiasis. This was the case which I showed, multiple cutaneous skin colored umbilicated lesions, papules, nodules, plaques, and ulcers, maybe other features. This is another patient with umbilicated lesions all over the body. And this person had disseminated cryptococcosis. This was the fundus picture of that. And they had fungal cryptococcal abscesses in the retina. So there could be other lesions, other deep fungal infections like histoplasmosis, skin lesions in 11% of the people with disseminated histoplasmosis. These are the lesions seen in a patient of histoplasma. There could be a smaller lesion or there could be an extensive lesion. This lesion on the finger turned out to be histoplasmosis. There could be fever and weight loss, respiratory complaints, and 5 to 10% have an acute sepsis soft-like syndrome. Skin lesions are uncommon molluscum contagiosum-like lesions. Treatment, of course, all of the ID physicians know here. It's amphotericin B and other lesions, other things. This was an interesting case again because this turned out to be aspergillus. And we had the differential was deep fungal infections, atypical mycobacteria, etc. But turned out to be aspergillosis and cured after treatment. Of course, viral infections are there. Herpes zoster is the commonest thing. Screen all HIV all patients with herpes zoster. And my students here know that I must have told this 30 years ago. Irrespective of age, gender, religion, whatever, all herpes zoster should be screened. That could be just one of the take-home messages after the lecture. That screen for that. Don't wait for multiple lesions, multidermatomal disease, severe disease, etc., etc. Screen everyone. As we have seen this bilateral one, severe lesions on the face, extensive lesions on the thigh. We also should be thinking about HPV infection in HIV infected people. There could be extensive small flat wart lesions, not only genital HPV infections, and all women with HIV above 25 should be screened for HPV. Cervical lesions, and those who are HPV positive should be followed up probably. And we have also published that HIV infected children less than 20 or less than 15 should be vaccinated. They would require 3 doses of HPV vaccine, not 2 as the other adolescents, but they should be vaccinated. So these are extensive HPV lesions. Of course, anogenital warts can lead to CIN, AIN, and there could be extensive lesions. There could be this kind of lesions, lymph nodes or growths, and this turned out to be lymphoma. There was another lesion in the oral cavity came to us, and it was diagnosed as lymphoma. This is another lesion, hyperpigmented lesions on the toes. What this could be? Looking at the color, Kaposi sarcoma. Now we come to STIs. We have both ways impact HIV, STDs and HIV, HIV and STDs. The risk factors are same, so there are more likely to be HIV positive on patient with risk of STIs, and STIs manifest differently in patients with immunodeficiency. There is a changing phase of sexually transmitted diseases. When we were in college, you won't imagine, but in Sassoon Hospital in 1981 to 83, when I was doing my PG, the STD OPD used to be of 150 to 200 patients every day. There used to be long queues of patients waiting for treatment on syphilis, chancroid, gonorrhea, etc., etc. 2001 to 2015, it was a complete lull. We had no STI patients almost. In those 15 years, I must have seen not more than 7 or 8 cases of syphilis. And 2015 onwards again, we are seeing a lot of syphilis, and all other STIs are coming back gradually. So this is primary chancre, multiple painful ulcers, chancroid, papillosquamous, bilaterally symmetric coppery red non-pleuritic rash with lymph nodes, that's secondary syphilis. This is secondary syphilis with unusual lesions, sarcinate kind of lesions of syphilis with a primary lesion. This is granuloma inguinale, beefy red kind of lesions. Chancroidal lesions, chancroid with purulent discharge, extremely painful lesions. We used to have a joke in Sassoon OPD that a person who walks in teda has chancroid. The person who walks out of the OPD teda has gonorrhea, because he has got those 4.8 lakh units of penicillin in both of the buttocks. So you can diagnose it from outside who is suffering from what. Multiple ulcers of HPV, HSV. We don't know if there's phimosis. There could be other lesions inside, whether it could be chancroid or any other ulcerative lesion. Bubo of LGV, lymphogranuloma venereum. Acute gonococcal urethritis, we have started seeing this again. Again, this gonorrhea, it's vaginal discharge. There could be urethral discharge also. Herpes simplex. This is most probably HSV infection. These kind of lesions you see in immune compromised patient. Any non-healing ulcer in an immune compromised patient by default should be treated first as herpes simplex and then look at other things. This is GI, granuloma inguinale lesion. Osteomine, lymphedema, secondary lymphedema after STIs. Molluscum contagiosum. Again, a lot of molluscum contagiosum with probably scabies. Meatal warts, HPV infection in the meatus. Children, do think of child sexual abuse, and whenever you see HPV, BV, bacterial vaginosis. STIDs in HIV key features, drastic fall was there, but now it is coming back. Some representative cases, 30-year unmarried man, rash all over, erythematous papillosquamous lesions, body ache, headache, abdominal pain, sore throat. Took some medicine without relief, most probably doxy as prophylaxis. Hemogram, LFTs, urine, dengue serology, all within normal limit. Papillosquamous rash. What led to suspicion was these lesions on palms. VDRL 1 and 2, TPHA 320, STD screen was negative 3 months ago. Was advised azithromycin, no symptoms, so stop treatment on the a few days afterwards. Repeat VDRL was with a higher titer. Past history, 1 year back had gonococcal proctitis and pharyngitis, MSM. So there was anal gonorrhea, there was oropharyngeal gonorrhea, now had syphilis, secondary syphilis, had multiple partners, insertive as well as receptive sex. 35-year-old presented with rash on the body, perianal lesions. Again, lesions on palms and soles raised the suspicion of secondary syphilis, VDRL positive, HIV infected, unmarried, MSM, multiple partners. Is this scaremongering? No, this was an old slide, but that time I had, actually we published a paper in IDWL some 7-8 years back. let's not let the guards down. Syphilis is coming back, and I think it came true. Secondary syphilis, not only men, not only MSM. We have started seeing it in women. We have started seeing in pregnant women. We have started seeing it as congenital syphilis. So many times gynecologists did say that we haven't seen VDRL positivity for 5 years, 6 years, 7 years. Why we should screen every pregnant woman? I think it makes sense to still screen every pregnant woman. Syphilis is here. Gonorrhea is starting to appear. Others will follow. What could be the impact on HIV epidemic? I don't know. Because may not have, because majority of our HIV patients, U is equal to U, would be on ART, may not transmit HIV as such, but maybe there is an there could be an increase or tremendous increase in other STIs. So summary of commonly seen skin diseases: oral candidiasis, zoster, herpes simplex, mollusci, warts, bacterial infections, tinea, drug infections. There could be other lesions, non-specific lesions, hyperpigmentation, oral hairy leukoplakias, etc. We have to keep an eye on sexually transmitted diseases. These are the uncommon dermatoses which we have seen. Thank you.
Thank you for an exhaustive. Any questions for him? Any questions? जाते का पहिलेच आवाज नाही आहे.
तुमचा पण आवाज कमी झालाय भूक लागल्यामुळे आणि सगळ्यांना भूक लागली आहे.
उलटून बोलायला लागायचं. But just one or two things. Perhaps next time, one suggestion to Dr. Soman is we should have one presentation where how to examine patients of MSM by Hijra community, that has to be taught. One of the reasons is now increasingly transsexual surgeries are increasing. Now you are finding that the presentations are also changing among the Hijra population, especially among those who are cis women. No? Now, that is one thing. Because you need to have certain sensitivities, and these people are going to keep on coming because they have higher incidence of HIV even at this juncture, and with the काय 370च ना का 370 फक्त काश्मीर आहे नाही हे जे
377
हा
377
मला कन्फ्युज झालंय म्हातारा झालो
377
whatever it is, but with that removal and now it being legal, you will find increasing number of people who are MSM, who accept that they are MSM, will come to the clinics. It's not so easy as it appears. When he said that oral gonorrhea can occur, oral gonorrhea, but it's very difficult to clinically pick up oral gonorrhea. No, because most often they tend to swallow the whole thing and it becomes really difficult. Even recognizing proctitis is not so easy a task, or syphilis, just the other way in MSM. I recall that in Sri Lanka, WHO had developed a global guideline on STI management. I think it must be somewhere around 2002. And they were disseminating because they wanted opinions. I had to struggle as hard, perhaps as badly as I did for TB, moving the program from DOTS to daily regimen for HIV infected people. There was no chapter on MSM, how to manage MSM. And I had to struggle a lot because all of these people were by and large from South Asian countries. But I can claim that it was successful. The whole thing changed. They had to go back to Geneva and they introduced the chapters on MSM. I think it is time we have to become sensitive to MSM and Hijra population. It would also be good if we can bring in somebody who can talk about how to deal with those patients. It's not so easy as it appears, that I can definitely say.
Yeah, see, I can say that because, see, for example, saying that every woman we would ask for a HPV screening, but for a trans man who has walked into your clinic as a man, wants to be addressed as a man, but has vagina and cervix, and then telling that person that you undergo HPV screening is a task in itself, and we have to understand and learn that. Similarly, TG women, like he must be having that experience that when someone TG woman is sleeping in the clinic, and you would many times never know that this is a biological man who is a TG woman, and someone walks in and wants to examine, and then finds something different, vague, and kind of.
Yeah, I remember one of my
so,
gynecologists who was working with me in 1994. One of your friends, wife, a woman walked in. So generally, never used to see women, avoid as far as possible. And she walked in. I told her, "You go, you see your patient." She started shouting, from the room, and I was scared. Something has gone wrong. Those were very early HIV days. She said, "काही करताय sir तुम्ही?" ते माणूस आहे तो, मेल आहे तो, ती बाई थोडी आहे. But if I recall that incident, the woman was so good looking. Nobody could have had recognized that she was actually a male, who had not undergone transsexual surgery as such. What is important to understand, that woman had that daring to say, ती मला म्हणली, "डॉक्टर, कधी तुम्ही रेड लाईट एरियामध्ये नुसतं माधुरी दीक्षित म्हणून म्हणा, लोक मला घेऊन येतील म्हणून." मला काही काम करायचं असेल तर. It was that kind of.
There are these issues like where we admit that patient. So there is a TG woman where we admit in a female ward, in a male ward. Do we have washrooms for these kind of people available, kind of thing? So because I think we were blind to this and these people were not coming to us, we had not seen these problems. But these are the problems which we would have to now also learn apart from this clinic. Clinical things are easy, and I think
Very. I will give you a small.
As you use the word, these are trivial, but the other issues are not trivial. They are very important.
No, it's very easy to speak, but we come from traditional background. So what happens is when you see somebody who's a Hijra, let's assume it's a she gender that she would like to assume. For us to call her as she and discuss with her as if she is a woman is as challenging. That I can tell you. No, the conversations never remain simple. So it is good if we teach everybody what to do.
Okay, anyway, any questions? Otherwise,
there are trainings. I used to conduct many. No, now these are conducted through Alliance. I can speak with them. They perhaps will be able to manage.
Because you said that you have to identify such a person who can speak authoritatively on this particular topic.
मी बोलायला पाहिजे होतं पण मी फिट असलो तर.
there was a program in IMA some 2-3 months back on, and whatever points he's making, I had made a presentation. There were some other people who had made a presentation. The simplest thing we can start in our clinics is first question to be asked to everyone: what is the way you would like me to address you? He, she, they, whatever, and then stick to that, because these are the simple things which are now coming in. And so,
it has become so complicated. Now there are terms like cis or trans, because there is a conflict, physical and mental makeups. And even among them, they have many sub district categories.
Okay. Lunchtime. Thank you.
I think the last panel which Dr. Aisha ma'am and me will be like sort of addressing will, I think, bring up a lot of these conversations. So everyone please stay tuned to that. Thank you, Dr. Kulkarni, and thank you, sir. I think we'll break for lunch and we would start at 2 o'clock sharp. So please have a quick lunch. It's supposed to start at 2, sir. So have a quick lunch and join us back. Thank you. Yes.
Thank you. एक कॉन्टॅक्ट हा इथे माउस फर्स्ट बंद हाँ बंद और ऐसी आवाज है कैसे कैसे हेलो 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 चेक 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 सीमा सचान सीमा सचान हाँ चलो हेलो 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 चेक 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 ओके अब आवाज तो नहीं आ रही खिड़की वो आती रहेगी हमारे इवेंट में ऐसा ही होता होगा
श्री सिद्धिविनायक नमो नमः अष्टविनायक नमो नमः गणपति बाप्पा मोरया
Sorry about the delay. So we now move on to our next talk is by Dr. Sanjay Pujari sir, the science and evidence for U equal U, updates in PMTCT and controversies in breastfeeding. Dr. Sanjay Pujari sir is the director of Institute of Infectious Diseases and consultant infectious diseases at Pune Hospital. And the moderator for this session, for this talk will be Dr. Ashwini Taide ma'am.
So let's start with the post-lunch session. So like we have discussed, non-OI complication PMTCT and other practices related to U equal to U. And to talk about it, I'll invite Dr. Sanjay Pujari.
Thank you for the invitation. So let me start my presentation. This is my outline. We'll talk about sexual transmission of HIV and how U is equal to U impacts sexual transmission. We'll briefly discuss pregnancy-related issues. It's okay. And finally, issues relating to breastfeeding. So it's quite well known that the risk of HIV transmission sexually is associated with plasma viral load. And this is a study which shows that for every log increase in the plasma viral load, there is a 2.9-fold increase in per act sexual act transmission risk, irrespective of whether it is male to female or female to male transmission risk. This was prior to the ART era, and as you can see here, with 2 log viral load, with or without control, the risk of HIV transmission is 0. So even prior to the ART, widespread use of ART, there was a clear association between viral load plasma and the risk of sexual transmission. So I'll try to summarize the U is equal to U evidence building timeline by enumerating some important studies. The first study came in 1998 from Rakai, prior to, of course, the antiretroviral widespread use, in which discordant couples in a cluster randomized trial, where it was studied whether treating STIs reduced the incidence of HIV amongst the 0 different couples. There was a dose-response relationship between plasma viral load and the transmission rate per 100%. This was irrespective of whether it's again male to female transmission or female to male transmission. But what is important also to see that when the viral load is less than 400 copies, the risk of HIV transmission is 0. Subsequently, there was in 2008 a Swiss statement, and the Swiss statement was the first in the world to recommend not using condoms if somebody is effectively suppressed on antiretroviral therapy. Now remember, this was prior to any randomized control trial evidence. So at that point of time, it was widely criticized, and including people from the NIH who suggest that this is not possible. But the Swiss were very, very confident that by recommending this, particularly in Switzerland, because many of the couples there were already practicing unprotected sex on antiretroviral treatment. So they did their own analysis, which was not published, but on the basis of which they recommended that you don't need to use condoms during potent ART. After that, of course, the landmark HPTN 052 study, where 0 different couples were randomized to early versus late ART, and the primary transmission outcome was incidence of HIV-linked transmissions, and the primary clinical outcome was AIDS and non-AIDS defining events. The interim analysis was published in 2011, which shows a 96% reduction of heterosexual transmission of HIV in linked in the linked situation, and this was something which was subsequently followed up to the completion of the trial with extended follow-up. In 2016, there were two trials published: the HPTN 052 final results and the partner 1 study. In the HPTN 052, serodiscordant couples were randomized to early ART versus delayed ART. And as I said, the primary transmission endpoint was virally linked transmission rates. And as you can see here at the end of the final results, there was a 93% reduction in linked HIV transmission, which happened in the early ART arm as compared to the delayed ART arm. If you look at what kind of transmission events happened during this study, there was a total 78 transmission events which happened, out of which 46 were linked transmissions. Linked means the virus is basically phylogenetically similar in both the partners. In the early arm, there were 3 transmissions, and in the delayed arm, there was 43 transmission, leading us to a 93% transmission reduction. So there was no linked infections observed, except in 3 patients, in 3 individuals, in which 2 individuals actually got infected when the index partner was initiated on antiretroviral treatment very early, within 6 months. And 1 partner had a virologic failure on antiretroviral treatment. So it was very clear that if your viral load is less than 400, I think in this study, I'm not sure, the risk of transmission was 0. Also, there was partner 1 study, which was published later during the year, in which different couples, this is the prospective observational study, with antiretroviral therapy and virologically suppressed defined as less than 200 copies, and having condomless sex 1 month pre-enrollment. So the eligibility criteria for the trial was having condomless sex and eligible and interested in participating in a transmission study. And they were expected to have sex together in the coming months without condoms. So these individuals were observed, in which the index patient on ART was virologically suppressed. And this is what you see here, the linked transmission event rates. And this is a point estimate you can see here, which is 0 across all kinds of analysis. So whether it is overall, whether it is anal vaginal sex, whether it's inceptive or receptive, whether it's heterosexual women, heterosexual men, or men who have sex with men. The only issue is, of course, the upper bound of confidence interval, which basically in this study for any kind of sex was about 0.30. In this study, there were about 22,000 condomless sexual acts in MSM and 36,000 heterosexual condomless sex acts which happened, and the absolute risk was 0. Subsequently, from Australia, Brazil, and Thailand, there was a study published in 2018 called the Opposites Attract. In Opposites Attract, it was only MSM population were serodifferent with ART in the index partner and viral load less than 200, and having anal sex in the months pre-enrollment, expected to have sex together. And in this, PrEP was also allowed for the negative party. And this is what you see in 232 couple years of follow-up with 16,800 condomless anal intercourse acts. Link transmission was 0. Now, they also did subgroup analysis where they looked at trying to stratify based on PrEP use of the negative partner. And as you can see here, even in these 2 groups with significant amount of sexual acts, condomless sexual act link transmission is 0. They also looked at whether STIs make a difference if you are on antiretroviral treatment and undetectable, and whether it is index partner or the negative partner, and any kind of STI, including discharge, etc. And these are the condomless sexual acts, the number across various STIs. Again, the linked transmissions 0. And finally, because the 95% upper limit of confidence interval was higher in the Australian study, to be more sure of it, partner 1 extended to partner 2. And in partner 2, again, it was only MSM population, serodifferent, again, the same entry criteria. But here, PrEP and PEP was excluded. And what you see here is condomless anal sex associated with zero link transmissions with the upper limit of 95% confidence interval of 0.23. And again, across various sexual activities, the risk of link transmission was zero. So pulling both the partner studies, partner 1, partner 2, and in gay and heterosexual, you can see here with gay couples, it's zero risk, and the upper limit of confidence interval is around 0.2, which essentially translates into one transmission which can happen in 435 years of condomless sex. For heterosexual couples, because the number was only there in partner 1 study, the numbers are small. The upper limit of 95% CI is 0.45. That translates into one transmission in 217 years of condomless sex. And this is the cumulative evidence of whatever is published and observational as well as one clinical trial of the HPTN-052. Prior to the partners and opposite attract, the upper limit of confidence interval of the pooled estimate was 0.14. And with inclusion of the partner and opposite attract, you see the upper limit of confidence interval is 0.27. So it's a very, very rare event, which is unlikely to happen. It's a statistical issue rather than a biological issue. So for all practical purposes, the risk of transmission is zero. There is, on the other side, if you try to analyze literature, there are no cases of linked HIV transmission to sexual partners when the person with HIV was virally suppressed. So there's an additional evidence to suggest that U is equal to U. So based on this, the U is equal to U movement was launched in 2016 by the Prevention Access Campaign. And this basically tries to disseminate this information, which can translate the lives of people living with HIV as well as impact public health. So then there was this idea about what about blips? So blips basically do not transmit HIV because it's very difficult to prove. Because a blip is usually defined only after you confirm that the viral load has gone undetectable after. So that is difficult to prove. But what about viral load less than 1,000 copies, which is defined as low-level viremia according to the WHO? So in the Lancet last year, they did a systematic review and they looked at 8 studies with 7,700 couples, where they saw 323 transmission events. Obviously, there was no transmission with viral suppression on ART. And most transmissions happened when the viral load was between 30,000 to 750,000. When they looked at 2 cases of less than 1,000 copies, there were two transmission events with viral load less than 1,000 copies. In both the cases, the viral load was tested 50 days prior to the event. So we really don't know what was it closer to the event, whether it was worse. Based on that, WHO has recategorized sexual risk of transmission of HIV as 3 categories: unsuppressed, suppressed but detectable, and undetectable. Of course, undetectable is easy, so zero risk of transmission. Suppressed but detectable means viral load less than 1,000 copies. WHO says it's almost zero or negligible risk of transmission to sexual partners. And in the Lancet study, they mentioned no transmission which has been documented when the viral load is less than 600 copies per ml. And unsuppressed viremia, of course, is a risk factor for sexual transmission of HIV. Now, when you start giving these messages, what is the public health impact? There are some trials which have looked at the impact of U is equal to U messaging in the community. And in a peer-led randomized trial in gay men in Africa, they demonstrated that people coming for testing was increased when you provided them a U is equal to U message, as compared to standard of care where U is equal to U message was not provided. And obviously more people were detected with HIV infection so that they can subsequently be linked with care. In terms of individual health outcomes, and this is a questionnaire-based study again from Africa, which shows that when you give a U is equal to U message to your patients, they are more comfortable in sharing their HIV status with their friends and family. They have optimal sexual health. Their self-reported viral suppression was higher. And finally, their adherence was better when they had this U is equal to U messaging. So it's very important for us as physicians to incorporate this messaging proactively during the treatment of people living with HIV. What is the impact on post-exposure prophylaxis of U is equal to U? If you look at whether it is sexual exposure or occupational and other exposure, if the index HIV viral load is undetectable, post-exposure prophylaxis is not recommended. So this is VIVA and DASH guidelines, which suggests that you don't need PEP if your index patient, whether it's occupational or non-occupational, is virologically suppressed or viral load is undetected. So now shift gears to pregnancy. And why pregnancy is different? Because I'm trying to look at whether we can apply U is equal to U in the pregnancy setting. So in pregnancy setting, there are different issues. First of all, the duration and intensity of the exposure to viremia is much higher than sexual contacts. So you have a 9-month exposure of the virus during pregnancy and subsequently through breastfeeding. So obviously that is maybe one of the factors. The second is the transmission dynamics is a little different also. There are micro transfusion and exposure to blood, which happens as compared to, which may not be a context in the sexual issue. And finally, immune cellular content is more in breast milk versus genital fluids. And particularly in colostrum, where cell-associated virus may be more common than in genital fluids. So for this, apart from maternal ART, people have looked at mode of delivery, neonatal prophylaxis, and breast milk prevention strategies to reduce the risk of transmission of HIV from a mother to her child. But we have to remember that most of these studies, particularly breast milk studies, have come from low and middle income settings, where the breast milk is a very important aspect of child and maternal health. But I would not go into the entire history of PMTCT because it starts from 1992 with PACTG 072. But I will try to summarize you some of the studies which have used contemporary antiretroviral drugs, which we use in our clinical practice. So there are two studies, the PROMISE and the VESTED. The PROMISE used lopinavir, ritonavir, and VESTED uses dolutegravir in the IMPACT group. And then we have the DOLPHIN 2 study. This study, both these studies initiated ART from the second trimester onwards, and DOLPHIN 2 study, they initiated it from the third trimester onwards. So the study design of VESTED is randomizing 600 mothers to the TAF-FTC DTG, TDF-FTC DTG, and TDF-FTC evidence, and then following up for about 50 weeks postpartum. So first is virologic efficacy, very clearly shown that the dolutegravir-based regimens was superior to the efavirenz-based regimen in achieving a viral load of less than 200 copies at delivery. So very clearly DTG surpasses efavirenz. Also, there is a rapid decline in the viral load, a property of integrase inhibitors. Within 4 weeks, a significant proportion of women were undetectable as compared to efavirenz. So around delivery time, a significantly increasing proportion of women went to a viral load less than 200 copies. What was interesting is adverse pregnancy outcomes, which was a composite outcome defined as stillbirth, preterm delivery, small for a gestational age, very small for gestational age, and very preterm delivery. So as you see here, in the 3 arms for the entire composite outcome, the event rates was lowest in the TAF-FTC PTG arm as compared to the TDF TTG and the TDF efavirenz. So that was a signal to suggest that adverse pregnancy outcomes may be lower in the TAF-FTC TTG as compared to the other. Also surprisingly, they found that the neonatal mortality at the end of 1 month was 5% in the efavirenz group as compared to 1% in the dolutegravir groups. So there was a increased risk of neonatal mortality when the mother was exposed to efavirenz. The reasons and mechanisms of this are unclear. And this is final 50 weeks data. I would not go into the details of it, but what it essentially tells you is when you compare TAF-FTC DTG with efavirenz-based regimen, you can see maternal virologic failure, ART resistance, grade 3 events, infant deaths are all better with the TAF-FTC DTG as compared to
their organism. Now, of course, we are all worried about weight changes with that. So what weight changes happens in pregnancy when mothers are exposed to FFPCBH? So this is data again from the Western trial. It's clearly showing that average weekly weight gain is higher in the TAF-FTC-DTGF as compared to the DTG-PGF or the KDF organism. And looking at the proportion of women with low weight gain, normal weight gain, high weight gain, obviously it is lower low weight gain in the TAF arm and better normal weight gain and high weight gain in the TAF arm. So TAF is obviously associated with weight gain in pregnancy. And postpartum, it continues. And this is at the 50 weeks postpartum. You can see almost 50% of women in the TAF FPC-DTG arm have a BMI of more than 25 in these women in South Africa. Now, the interesting thing to look at is whether this weight gain is associated with adverse pregnancy outcomes that we talked about, which is lower in the TAF FPC-DTG arm. What they clearly showed that when you compare normal to low or normal to high weight gain, the risk of adverse pregnancy outcomes is better with weight gain. So if you gain weight in pregnancy, the risk of adverse pregnancy outcomes goes down across all the, including the composite, and of course they don't have the power for it. And at CROI this year, they tested investigators presented blood pressure changes, and there was a signal towards elevated blood pressure, but this was not translated into very great event rates. As you can see, the percentages are very low of gestational hypertension preeclampsia. What about bictegravir used during pregnancy? This is the largest cohort of 137 women who used TAF-FTC bictegravir during pregnancy. And it has decent suppression rates, as well as for perinatal HIV transmission in this single arm observational cohort of around 0.7, which is less than 1%. So based on this, the key messages are for pregnant women living with HIV, the preferred regimen is an integrase-based regimen paired with TAF-FTC bictegravir or TDF-FTC. And an alternative is TAF-FTC bictegravir. This is also in tune with the current DHHS guidance. Also, there are interesting messages from these trials. Of course, maternal viremia is the greatest risk of transmission. However, rare transmissions occur less than 1% when the maternal viral load is less than 50 or target not detected. The mechanisms are unclear. The mode of delivery, elective C-section, is not needed if the viral load is less than 1,000 copies per ml. So you basically need to do a vaginal delivery. And most important, there are no RCTs on the risk with mothers initiating ART pre-conception or first trimester, because these studies have shown that the duration of ART exposure is associated with lower risk of transmission of HIV to the baby when both are having a viral load less than 50 at day. So the duration of ART for some reason is associated with this. For this, there is a French perinatal cohort. Of course, this is not an RCT, which looked at perinatal transmission rates across 3-5-year intervals with ART timing initiation and viral load 50, less than 50 pre-delivery. And as you can see here, before conception, if a woman starts ART, gets pregnant, is suppressed, gets pregnant, and then continues ART and is not breastfed, you have zero risk of transmission of HIV. So this is one cohort study, of course. And then, of course, the later on you start ART, the higher is the risk, even if you have a viral load less than 50 copies pre-delivery. So perhaps the U is equal to U concept can be applied to this small group of women who start ART prior to conception or conceive when viral load is
undetected. Finally, let me end by giving you some ideas about breastfeeding. Well, the risk-benefit ratio of breastfeeding was always a dilemma between high-income settings and low-income settings throughout the pandemic. So in high-income settings, the transmission risk of HIV was appreciated enough, but they had safety of formula feeding. From 1996, the developed world has never recommended breastfeeding for women living with HIV. Now, for that reason, when you actually look at low and middle income settings, where it's a very delicate balance, where maternal child benefits of breastfeeding are something which are important, particularly in the absence of safe formula feeding and the transmission risk of HIV. In this context, advising breast milk, not breastfeeding the kid is something which is not feasible. So people looked at interventions and trying to do that. They tried to use maternal ART with or without neonatal ARV prophylaxis, advised exclusive feeding, and early weaning. For this, again, there are trials, and again, I'll focus only on two studies with modern contemporary ART. And this is a PROMISE study. Again, PROMISE was a little old because it was lopinavir, ritonavir. But this was study which was done prior to the era where ART was indicated for everybody. So prior to that, you used a CD4 cutoff, if you remember, more than 350 and better. So during that era, postpartum women were randomized to maternal ART versus infant nevirapine prophylaxis for 18 months post-delivery or breastfeeding cessation and monitor for HIV, infant HIV infection or toxicity. And as you see here, there was no difference in the incidence of HIV infection, whether a mother received antiretroviral treatment or the baby received nevirapine prophylaxis. And the risk of transmission was very, very low, was less than 1% in this study. Then we talked about Impact Vested and Dolphin 2. They also had breastfeeding subsequent follow-up. In Impact, 78% of women breastfed with 6 weeks of nevirapine postnatal prophylaxis and continual maternal ART. There were only 2 transmissions documented at 6 weeks and 50 weeks. At the 6 weeks, the mother's viral load was less than 50 when transmission was documented. In Dolphin 2, breastfed mothers, breastfeeding was allowed. 4 to 12 weeks of nevirapine postnatal prophylaxis was provided. Maternal ART was continued. And 1 transmission was documented in the efavirenz arm. The mother's viral load was undetectable. So very low risk of transmissions, as you can see here, happening in the context of PNP or maternal ART. What is more important to also understand that there are no studies on breast milk transmission where maternal ART is initiated pre-conception, first trimester, and continued throughout breastfeeding. So again, the same duration of ART logic, which we talked about in pregnancy, we don't really have evidence to suggest that that may be safer. We agree that there is a less than 1% risk that breast milk to maternal plasma ratio of multiple ARVs. And as you can see here with integrase inhibitors, with dolutegravir and bictegravir, the levels are a little low, but with NNRTIs, NRTIs, and PIs, of course, the levels are reasonably okay. But then what is safe for the baby in terms of ARV exposure through the breast milk? Generally, the relative infant dose of less than 10% is considered safe. With instis, you can see it is less than 6. And in fact, for all of the ARVs, you can see it is less than 10. So assume that this may be reasonably safe exposure of ARVs in the breast milk for the baby. Though now you have the extension of the Dolphin 2 study, which is going to look at baby outcomes exposed to ARVs through breast milk over a period of 2 to 3 years. So based on this, I would just like to summarize published this Monday in pediatrics. And this basically is from the American Academy of Pediatrics, which has always since 1996 have said that avoid breastfeeding. So the only method for infant feeding that eliminates risk is obviously complete avoidance of breastfeeding. But now AAP supports breastfeeding in women who desire to breastfeed. ART initiated early in or before pregnancy. Evidence of sustained viral suppression, which is defined as less than 50 copies and not less than 200, as is determined in the sexual transmission scenario. Adherence commitment, including for infant prophylaxis and continuous ART access. So these are the predefining from the US perspective. And I think it's very clear they have recalibrated the risk-benefit ratio for the developed world also. First, for breastfeeding strategies to reduce risk, exclusive breastfeeding through the first 6 months, continuous maternal ART throughout the duration of breastfeeding. And why is this important? This looks like a no-brainer, but what happens basically is when a mother is breastfeeding the child, she's on a stable ART. Changing ART may be risky, even for side effects or minor side effects or cost and all those kinds. If you're not really sure that the viral load suppression is a threat there. Regular assessment and closer follow-up of viral load in the mother every 1 to 2 months is what they recommend, but perhaps we should look at something in between. And infant ARV prophylaxis usually for 4 to 6 weeks when there is a risk for colostrum, either with AZT or nevirapine. And finally, gradual weaning over 2 to 4 weeks rather than that. So in summary, U is equal to U very clearly for sexual transmission, heterosexuals, transgenders, gays, LGBTQ communities, irrespective of sexual orientation, works. So that has to be a message which needs to be given. For mother-to-child transmission of HIV, U is equal to U applies for a mother who is suppressed with ART at conception and continues ART until delivery and subsequently also, but doesn't breastfeed. So in that situation also U is equal to U applies. U is equal to U may apply, or if it is a less than 1% risk, if a mother conceives on ART when virologically suppressed, continues ART and during pregnancy and continues ART during the duration of breastfeeding. So this is a summary of the understanding of the science and evidence of U is equal to U. But let me end by quoting Pochi again, who thinks that this is this quote that I think when the history of great public health accomplishments are going to be written, I guarantee you it may not be universally accepted now, but ART and U is equal to U would be right up there. So I would like to acknowledge, I don't know, disappeared. I want to acknowledge ChatGPT 4.0. Thank you.
Thank you, sir. Thank you, sir.
No, I used it for graphics.
Nice graphics, actually. The last one is really interesting. Yeah. So U equal to U is an important concept and which has changed our mindset and which has made us bold in our practices related to PMTCT, breastfeeding. And the last guideline uptake is really good, heartening for Indian practitioners because we have a lot of patients from low strata who cannot afford formula feed and all. So any questions from the audience? Can we still offer breast milk to all our patients with that less than 1% risk?
No, I think it is a shared decision making. You have to discuss this even prior to pregnancy. In our context, what happens is when women plan pregnancies, they are on ART, they are suppressed. We discuss the issue of breastfeeding with them. Normally, what is my experience is when you tell them less than 1% risk with breastfeeding, they would not breastfeed in the category of patients who come to me. So I think as a public health, it may be different, but in individualized practice, even 1% for a baby, a mother will never accept. Yeah, so you should look at it from a statistical point of view also. So, for example, you have the sexual studies, and they show an upper limit of confidence interval of say 0.07, right? How many sexual contacts they have seen? Not more than 3 lakh, 4 lakh, maybe max condomless sexual acts. Look at it in terms of baby's exposure in breast. If a baby is being exposed to breast milk 4 or 5 times a day in the initial first months, subsequently over a period of 1 to 2 years, we are looking at millions of exposures. And when you have millions of exposures, you can see that event with that kind of a high 95% CI. So there was a very beautiful letter which was written, which was published after the PROMISE study, and I'm quoting that to you, is where U is equal to U should also apply to breast milk, is what the author argues. Basically, because it's just a statistical issue. You see the amount of exposures which happen in that context. For example, in sexual transmission, 1 in 435 years versus that kind of exposure in the breast milk usually happens. So it's a statistical thing, but still we would say because transmissions were seen, and this is something which we need to tell our patients. But there are people who believe that if you conceive when you are suppressed and continue your ART until the end of breastfeeding, U is equal to U may apply.
Sir, is there any ongoing study on such patients who are virologically suppressed, and if they prospectively follow?
Yeah, so there will be only prospective observational studies now.
In this,
Yeah. So
is there anything?
no,
in the
I
pipeline?
have not come across any publication regarding that. Maybe we should do it. DHHS is already updated last year with this. Yes, support breastfeeding. December 2023.
Shall I share my experience?
Yeah.
See, somehow all this is data and science and trials, etc. But we managed something like 3,500 pregnant women over 18 years out of some 15, 16 lakh screened. And we have gone through all kinds of regimens, initial regimens, option A, option B, start immediately on ART, etc. And out of these 3,500 odd pregnancies, only 50 were infected, transmission was there. And in all 50 of them, there was definitely virological non-suppression in the woman. Diagnosed late, non-adherent, or left the treatment. Anyone else who was even started treatment during pregnancy, say first trimester, second trimester, but at the time of delivery was suppressed, there has not been a single transmission. So for me, I always tell women that if you are virologically suppressed at conception or say around 8th month or so, you can go for normal delivery. You can breastfeed the child, standard regimens. And all these children have been tracked, followed up till 18 months. So for me, I feel practical experiences U is equal to U even in mother-to-child transmission also.
Earlier strategies which were used, whether it was single dose nevirapine, whether it was boosted lopinavir, some of the strategies to boosted lopinavir was also given only to ensure that if a couple, if the mother has less than 1,000 copies of viral load, then instead you use boosted lopinavir. Now, what did that indicate? Just a single dose, as long as the dose has been given on that particular time point, presence of the drugs, antiretroviral drugs, reduce the likelihood of transmission immensely, to my mind. Now, the earlier you will start, intuitively, you are unlikely to encounter such a situation because you are already receiving these particular drugs for a long period of time. And it's not only covering the blood component, even on reservoirs, the effect is going to be there. And therefore, what you are seeing is true. So to my mind, I would still continue to believe, whether it is for public health purposes or whether it is for individualized medicine, as long as I convince that mother well, please don't interrupt your treatment, perhaps I would be far safer. Second thing which I would tell is, if you think of nevirapine, no? Because earlier there were studies, what is the concentration of nevirapine that you see in the breast milk? And when it came to children, it was almost a dose for nevirapine, which was being provided for the children by weight. So breast milk essentially is like, what would I say?
Prep.
PrEP is simple thing. It was that a cumulative dose was being given in small amounts as the mother was feeding, no? And eventually you get that blood level that you would see. That's about the second issue. And one of the worries that we will have, whether it is this or that, I think counseling of mothers continues to remain a problem. Their adherence continues to be a problem. And that is still reflected in the data that you get nationally. You still find mother-to-child transmission occurring, and the issues continue to be faced as such, though the numbers have gone down dramatically as of now. The second thing which I just wanted to comment, the association of weight gain and what was it?
Adverse pregnancy outcome.
Adverse pregnancy outcome. Perhaps it could also be a reflection of the disease status. No, we do not know whether it is cause or effect. That if my weight is reduced, I tend to transmit more, my outcomes are worse. If my weight improves, but is it that the mother is getting affected because of her disease status not being controlled, should also be looked at.
लीगल प्रोफेशन में केसेस झाले वगैरे.
As TTS issue that you see in Covishield, you cannot explain everything to everyone, and that is understood. No? We go by frequencies of occurrence. If the occurrence is likely to be very low, by mentioning that outcome with so small frequency, you are perhaps going to influence the decision from an informed decision making into a territory which may be irrational decision making. If TTS was explained, no, at that time when Covishield was being administered, perhaps you would have far more number of people not taking it altogether. No, so that law also considers that way. Law doesn't look at everything.
I'm not sure whether this analogy is right or not, because on one hand, you're looking at a disease which is of pandemic proportion, which has a high mortality and so on. Versus that, there is a risk of a complication. On the other hand, here is a couple who would say that I don't want to take even whatever risk that you say, you're not putting zero, you're going to say it's a finite risk. And then they say, okay, we don't want to take the risk. You will
No. I mean, it's very clear it is zero risk. The The issue here is these are statistical issues. Let me put it because I saw a presentation. You see, kissing doesn't transmit HIV. There are no studies, but we tell. So yeah, so that is one. Secondly, even household contacts, HIV is not transmitted in household contact. There is no very strong evidence for that.
Yeah, the point is like this, that for household contacts, there is no alternative. You are not going to throw that man out or something like that. But here there is an alternative. Are you saying that you don't take that alternative? Because I am telling you, and the guideline is telling you that there is not going to be a risk. Now, just imagine a situation like, God forbid, but that happens, suppose. Then what do we say? Because this is the guideline, this is the figure, and that's why I am okay in my right to give you this advice. Now, is this advice going to be supported by whatever the case and legal profession, judgment, and everything else? I want to ask that too.
Yes, Santosh, that's what he was quoting. There is only one case report of a MSM where HIV was transmitted through kissing. Have we ever used that information to tell people not to kiss? No, we don't know. But if people acquire it that way, where are the safeguards? Safeguards are, you cannot talk about events, all the events that could occur. You have to use your own, what would I say, ते काय म्हणतात, good ह्याच्यामध्ये, good faith. But nothing happens, sir. You will see even in this Covishield issue. They have gone to the court. The court will take a decision in favor of the company as well as the doctors who have advocated. Because tomorrow somebody could have had said that my doctor did not tell me. No, the company has mentioned it in their brochure. That is going to come in court of law to Supreme Court where they have filed. But it will not be a valid argument.
Also, on the other side is the interest amongst researchers to prove this wrong is very high here. And they have not been able to prove that if your viral load is undetectable, not even a single case where risk of transmission is there. So there is no evidence for that. And I read a very interesting statement saying that absence of evidence is also evidence in this context.
Sense of evidence is never a lack of understanding. It also has a accumulated negative findings, which you have not seen. So you cannot say absence of evidence is. But I think there are issues where we have to take decisions by ourselves in good faith. One thing which we have to learn is wrong decisions can come from any court. But if you fight them, things happen. नाही, पण सर एक ऐका ना, मी तुम्हाला स्टोरी सांगायची तर तो जो होता ना आपला साऊथ इंडियाला, राईट टू मॅरी वॉज स्टॉप. इट वॉज अ oral decision which the court had, Supreme Court judge had said that HIV positive individuals don't have a right to marry. That lasted for about 1 to 1.5 years, mainly because we had to go to the bench, where the review is done. Because if one Supreme Court judge says something like this, if you have to overcome, you need to have more than 3 and something like that. But it happened. And these kinds of shocks will always come. But one has to also be realistic, and courts also have to be realistic. The practice of medicine would end up into a complete disaster if I was to go for or be challenged for every decision that I make. that way people can say on what basis you thought, like madam ne कहला होता ना कि it was vasculitis. No? It was her judgment. Anybody could challenge. But I think as long as you have been rational through, there is nothing. You have to prove that that was done with malified intention or as a malpractice. No? If you have guidelines like this, you can always quote that this is as per these guidelines and this is not mentioned in that.
So we are medico-legally safe if we ask or if we give consent to our patients to conceive naturally?
100% we have been doing it for. One thing is, who are we to give consent? First thing, we are no one to give a consent for anything. Secondly, we did not need U is equal to U for having naturally conceived babies. We never always, it was always.
You ask our opinion and we have to give them options.
No, but
So
one thing is,
if they supposedly if someone turns positive and they said you have asked us to conceive naturally, so where do we stand in court of law?
no, we will be, of course, when they have asked us, we will be telling them that you have to be virologically suppressed. Previously, just because someone was virologically not suppressed, we were not going to tell them that you have unprotected contact to have baby without taking the risk of the partner getting infected. So at that point of time, also the advice would have been that if you are virologically suppressed, then you can try, you can use other technologies, etc. Whatever, PrEP and everything.
So, as far as I understand, this applies to everything in medicine, that every individual doctor does not have the means to perform studies on lakhs of people and all. So, whatever medical legal experts have spoken to us at any time and we've asked questions with regards to anything in medicine, they've always said, if you have national and international guidelines, textbook references to back you up, no court of law can hold it against you. Patients and lawyers may say anything, they may drag you to court. But so long as you have the backing of a standard guideline, textbook, whatever, nothing can happen.
See, Sanjay, I completely we have listened to this and we have read all this literature. U is equal to U is fantastic. The point is, for an individual patient, even in clinic, we are telling this, it increases adherence, etc. But somehow the message that is going along with that using condoms reduces the quality of life of people, which we took 30, 40 years for people to tell that if you are at a risk, condoms actually increase the quality of life because your risk perceptions, etc. go down. Now moving that needed to that extent, that promoting condomless sex, because then there would be people who would actually would not be the message for them, but would take it as a message, is going to be a problem because
then in that situation, we have to weigh that perceiving this, that because people will perceive that condomless sex is, you will increase, how right it is to withhold this information from people who are eligible. So both ways, I mean,
I already said that for eligible people, this is a good advice which we are giving everybody. The point is taking it out as a message, as a public health message. U is equal to U for people who are infected, etc. is good. But telling simultaneously that condoms reduce the quality of life.
No, I'm not sure whether I should say condoms reduce the quality of life. That is something which I know you are talking about our movie. So that's a different issue. The communities across the world have progressed beyond what we think. So recently I read an article in the Lancet where gay men are using what is called as biomedical zero sorting in dating. What they do is that they find people who are viral load, who are on ART and undetectable, or partners who are on PrEP, so that they don't have to take anything. So that kind of, progression is happening in this context. So I think we should not necessarily think that giving a broader public message through a movie like what we made
is detrimental or something. It is something which is important. It has to be known by everybody because there is a large negative community there who's stigmatizing and discriminating people with HIV. And for that purpose also, we need to basically give the message that, these are non-infectious people. You don't need to worry about the sexual transmission. It's not just about sex. It's beyond sex. It's about discrimination, stigmatization, internalized stigma, external stigma. All those kinds of things have to be addressed in a public health context.
So I think on that note, we should move to our case-based discussion on overcoming the bias.
But the one small statement, I think perceptions are always going to be different in different individuals unless they become a social norm. No. So essentially, even if you want to show the film, there would be different people who will sit, they draw their own inferences out of it. And that's a law of human beings. No? Everybody is free. Unless it becomes social norm, we should not worry. We should keep on providing information. Whatever they might think, they will pick it up.
Thank you. Thank you. I think so on the topic of social stigmas and biases, which are there in HIV, we move to a case-based discussion by Dr. Aisha Sunamala, consultant infectious diseases at Hinduja Hospital, Beach Candy, and Just Look Hospital. And myself, Dr. Sujata Rege, infectious disease consultant at Jupiter Hospital and Symbiosis Hospital. For the panelists, I'd like to call Dr. Ganga Khetkar sir, Dr. Pujari sir, Dr. Jyotsna Angam, gynecologist consultant at Jupiter Hospital and Jahangir Hospital. Ma'am, if you can just. Dr. Tanu Singhal, ma'am, consultant infectious diseases, Kokila Ben. Yes, ma'am. Dr. Komal Singh, okay, she's left. Okay. Dr. Smita D'Souza, consultant pediatrician at Jupiter Hospital. Have I missed anyone? No.
Okay, so we've had a real power-packed day with all the science and
So this is a physician colleague's brother, okay, who's a businessman, non-diabetic, who's got recurrent genital herpes episodes on treatment and has been diagnosed with pulmonary TB. And your colleague, who is also a physician, who has been treating this the genital herpes episodes, has asked you for your opinion for only the ATT part. And you talk to them about, have we tested your brother for HIV? And the colleague absolutely laughs it off. Are you kidding? he's happily married. He's my brother. He just, he travels a lot and otherwise he's very healthy, but he's got that genital herpes because he travels a lot, hygiene acha nahi hai, things like that, all sorts of explanations. So at this point, you have your colleague and you have that colleague's brother sitting in front of you. So do you initiate a conversation about HIV? Do you mention it just in passing as one of the things that you would want to test? Or more often than not, do we sort of camouflage it like this? So you have, sorry. So this is a real, this is sort of like what our prescriptions look like, where we have a CBC, CRP, ASR, something, 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 and we have it under the big umbrella of something called triple H, HIV, HBCG, HCV. And then you send all three together. You don't really talk about HIV as something that you are thinking. So it's kind of like the owl, which is camouflaged. So you're just sort of camouflaging HIV somewhere into your prescription so that you don't have a messy conversation with your colleague, with their brother. What should you do in this situation? And Dr. Aisha will be talking.
Okay. So, as Dr. Sujata just put it out there, that's one situation where you try to sneak things in without really having that messy conversation. Now, this is another extreme. And these are actual cases that, we thought we need to put out there because they were such massive tragedies. So this young man, 25-year-old from Chiprun, he was admitted under a physician at our hospital. He was admitted to the ICU with severe respiratory distress and severe oral ulceration, as you can see over here. And of course, he was worked up for all sorts of infections and everything. But at some point, we started suspecting that this really isn't an infection and it looks like something toxic. So, we went deeper, we probed deeper. Initially, the patient denied everything. And eventually, he agreed that, this all began when he consumed paraquat. Paraquat, as we know, is a chemical pesticide, which is used across the country, and it's associated with an extremely life-threatening ARDS, which doesn't settle, and most patients succumb to this, like this gentleman unfortunately did in a few days. And then, of course, we probed deeper into what had happened over here. And the story goes that he had presented in his town with an acute febrile illness, and he had admitted to the general practitioner there that he had had multiple sexual exposures. The local practitioner, in a sense, probably put it out bluntly, frightened him a little bit that this could be HIV and asked for an HIV test. And the fear and the stigma of that was enough to cause this kind of catastrophic consequence of poor pre-test counseling in this individual. And we lost him. So this is open for discussion.
So when it comes to pre-test counseling, if you have a patient in front of you, it's a different thing. But otherwise, a lot of references that we get for HIV positive patients are those who are already admitted in the ward for something else, maybe pre-surgical. So how is this pre-test counseling actually done? How should it be best performed? Who should be doing it? Should it be a prescriber that is when you're suspecting HIV probably, but otherwise it's probably a junior medical staff? Is it a counselor? Is it a nurse who's just withdrawing the blood? Just sign here. What about routine screening on admission for pre-op or pre-employment for that matter, or post-NSI to medical staff? That usually comes either to the hospital infection control department or the ID team. And how does one deal with patients who refuse testing? So I'd like the panelists or anyone in the audience for that matter to just enlighten us on how do you go about it in your practice? How would you recommend that this should be done? The ideal way, rather than, sort of just try and sneaking it in. How do we do it correctly so that we can avoid such tragic events which can occur in certain, because we see a lot of times people are just traumatized by the very thought that it could be HIV, despite of all their sexual exposures, whatever they may be, or their lifestyle. So anyone from the panel or the audience, please.
This was way back in 2001. Okay, before that I was in Delhi. And just like you said, we insert this Triple H for all the antenatal profile that we do. We don't have anybody who's supposed to do the pre-test counseling or the post-test counseling. But still we get a result and we could identify, although the prevalence was very low in Delhi. But when I went to Imphal in 2001, on one hand, we are talking about avoiding, vertical transmission or preventing it. And here I'm sitting in the antenatal OPD with no HIV testing. So every time there is a forum where I attend, and I'm the one who's screaming that we have to have antenatal, counseling and testing, because how do we prevent it? And the answer that they say is we don't have people or staff to do the pre-test and the post-test counseling, and so it is not done. But then eventually the head of the NACO, the president, was a Manipuri at that time, and we finally had this one person who was appointed to do the pre and the post-test counseling. And the prevalence rate, like if we have about 100 in the OPD, every day we are detecting about 3 people positive. That was the rate. So then there are so many people who come unbooked, being a medical college referral center. So we are popping in Nevirapine, during labor. That's the only contact point where we could give. Many a times, they put up a list of those positive that comes from a micro lab, and we're doing night duties, and I could kind of see some name familiar among the people who are laboring. And that is how we used to identify. But coming to present day, even in a corporate hospital, these are not done. In the name of consent, we do take a signature, but we don't, as a clinician, I don't have the time to give a proper pre-test counseling. But of course, for people where we are suspecting, we do take the effort to do so. But for a routine antenatal low-risk patient, we are not doing it. We're just inserting it in between, like you said. We have a comment.
Like the case which you said was TB, it's really easier because, there you can say that there is a rule that, everybody who is TB has to be tested for HIV. So it becomes a little simpler there that, this is a rule where, and then I generally also tend to say that, we don't have to be worried, if you're suspecting HIV. HIV has now become a very simple disease to treat. It is as simple as diabetes or blood pressure. I mean, I do try to tell those things that, even if it comes positive, it's nothing to be worried about. So I do try and tell those things so that, they are prepared that even if it comes positive, it is nothing to worry about. But at least this is for those patients where we are suspecting in children also, because if they have TB, then we have to tell them to test. We also ask that the mother tested in pregnancy and she says, yeah, I was negative, but we still say that you have to test. But generally speaking, I don't know. I have never found any kind of reluctance or something whenever I mention to patients that we have to do your HIV test, and they say, yes, you can go ahead and do it. I mean,
sometimes, ma'am, if you have not told, so this is when you're talking about a patient that you are treating. A lot of times, patients get to know as an accident. I mean, it's an incidental report. So in those patients, they've not really had pre-test counseling.
Yeah.
And then they say, wait.
No, so I'm coming to that. So this is the time when, like, I'm just sharing my experience that when you, most of the time when I've said that we may have to test you for HIV, most of the times I've never had any kind of saying that, no, how can you test me, or I've not done anything that I should get HIV. Most of the time they say ki haan, aap kar lijiye test. I mean, I've never had that. The issue I have really had was that a patient has been referred to me after they have tested positive when no pre-test counseling was done. And there, the issue which I have faced is that the family members don't want the patient to know.
We're coming
Ajay, you will come to that. And that is a difficult thing to handle. or the patient doesn't want the family members to know, which is little easier, but the other thing is difficult.
So is there any way in which we can sort of easen out pre-test counseling for our patients? I mean, the ones who are even undergoing pre-test testing as a routine. Is there any way to educate them better?
So what happens is that when patients are getting a blood drawn for an HIV test in the hospital, they have to sign that separate consent because it
Yes.
is not part of the usual consent. And there they are told that your HIV test is going to be done. That's all that is done. So no, so then if they have a question that why do I have to get a HIV, then we have a counselor there who can then come in and tell them. But I think 9 times or 99 times out of 100, they don't ask that, why am I getting a test?
That's what it's not an opt-in, it's an opt-out.
I believe it's the law. You are absolutely sort of obliged to do pre-test counseling and take a signature. There's no question about it. No? From whom medical staff, we don't have a blanket policy that everyone who's admitted or undergoes surgery has to do testing. But when we have a needle stick injury, we've had our counselor actually go and talk to patients and tell them that someone's had a needle stick injury. We would like to draw your blood, and patients have refused. And we've had no option but to just give that medical staff. Yeah, but where is the right to refuse if you don't take consent? You're saying that why should you take consent?
Madam,
Pre-test counseling.
No, is there a need to do pre-test counseling, but there is a need to take consent before drawing HIV. Yeah.
Excuse me. Yeah.
Sure.
Pre-test counseling part of the HIV pre-test when we need to consider that the patient doesn't know anything, and we as a physician or a counselor should give the idea of what can happen when the test come positive or negative. If the test is negative, he's free bird. But if the test come positive, we have treatment and which is also free. So there is no actual financial burden or any technical burden. People can live 100 years. U equal to U we are talking about. So not a big issue right now. It is, I think I tell myself that diabetes is more dangerous than HIV. And when the idea or concept goes to the person, definitely he will take the test because nobody wants to suffer in the next future.
So that was the idea of this discussion, that there has to be somebody, and perhaps the most vested stakeholder here is the prescriber, the person asking for the test. So I know that we feel like we don't have the time to do it with each patient and do it individually and everything. But clearly, our hospitals, all our hospitals, and some of the most biggest eminent hospitals out there still don't have counselors. So ultimately, the onus is upon us, and we're just trying to drive home how important it is to just put this across the patient and alleviate them of the misery of going through the test.
What if patient denies consent?
Sure.
2, 3 observations. First of all, this situation doesn't happen very commonly in my practice because people are diagnosed and come to me most of the times. Nowadays, we get a lot of people who practice high risk behavior want to get tested and having phobia, etc. So there are two distinct things. One is in a clinic, when you want to offer an HIV test, it's always better to offer yourself, discuss briefly, because there is going to be a long-term trust involved. Because this is a disease which basically the patient is going to be with you for the rest of the life, most likely considering treatment, etc. For ANC clinics or where you have, everybody needs to be tested, which is physically impossible as a physician. So there are strategies there which are called as opt-out strategies. In opt-out strategies, you basically make sure that the counselor talks to everybody, maybe in a sitting room, and tells that, we are doing this test, and not just focus on HIV. So as part of your antenatal care, we are doing this. If for any of these tests you don't want to do, if you want to opt out, then you can opt out and we can talk it in more detail. So that is something which basically efficiently manages the group
Not
and the time and the manpower. So I think, I mean, there are no right answers because every context may be different, people may be different, but this is how you should perhaps approach.
absolutely.
Just on a lighter note, your first case, I remembered one of my cases 30 years back. One of the senior physicians referred a case to me she had tested, was found to be positive, was not ready to disclose. And when we confirmed that, she exclaimed, "अरे पण त्याचं surname तर जोशी आहे." You were talking about brother of a physician. Now, I said the HIV does not know Kulkarni, Deshpande, Joshi kind of a thing. It just gets transmitted if it is the risk. So I remembered that. Even if he's a physician, what's the problem? Like, you tell that this is what I am suspecting and I want it to be screened, that's all.
Okay, so moving on.
No, no, no. I think what will have-
Last one.
no, no, not my final answer. No person can ever give a final answer. If you want, only the first question to be answered, you may require 2 to 3 hours, to find out how those approaches could be. Now, let's look at few strategies. One thing which you must remember, that AIDS bill demands that you have to provide informed consent. You cannot do HIV test minus a consent. Now, when we use the term informed, there perhaps you can play around that word itself. I agree with what Dr. Pujari said. It is related to trust building. But at the same time, even those who are in private practice are going to feel that's a cumbersome task. It's a burden. Can I shorten it? Yes, you can. No, honestly speaking, I don't, though I was a key player in PMTCT, I don't like that opt-in, opt-out consent. The reason is we continue to suffer. If you look at mothers and infants who actually are lost to follow-up, I think one of the reasons is drop-in, drop-out. I think every effort has to be made as individualized counseling. Now, how do I do that? If I have to do it, I have a constrained time. So you have to look at certain principles. Why am I doing it? I don't want any case to occur like it occurred in the beginning, where a lawyer in Bombay hospital, without being told, was tested and he jumped out of the window and committed suicide. Now, if I want to do the testing, the testing component can be abbreviated to a larger extent in pre-test, because you have a post-test to follow up, where you may try to balance the time that you have to spend. One thing which is important for you to understand, you have to talk about HIV, give information in small pieces, which happens. The moment you open up on that, the patient or the person will ask you few questions which he does not know. Now, what am I supposed to do in order to ensure that a negative event doesn't occur after that? I have to ensure that the subject understands the risk of being found as HIV infected. So I would put questions. I used to put questions. Acha, do you know how it is transmitted? He would tell you quickly. Yes, I know. Then I would say, do you really think you can acquire it? They would open up furthermore, because they will tell you in the first question they will not give you the correct answers. Second time they will be. It is that the perception of risk has to be brought into a particular level, and they need to understand uncertainty that is around the eventual outcome that will come with the testing. Now, on the issue, like you are asking two specific questions, the bigger problem is each one of them will require in-depth discussion. No, it doesn't, because you may have to adopt different strategies to ensure that the person his inquiry is satisfied to a larger extent. But I don't believe that if you have a counselor to do that, good enough. But if I don't have a counselor, I'm working in a private setup and I am expected to do it, and I don't do it because there is no counselor, it's not possible. So you have to adopt simpler strategies, give simpler messages. You can write down on those pages. No, if they appear concerned, this is a treatable illness, though not curable. That's a good news. No, you will not see any kind of a symptom. No, if we find today that you are HIV infected, can you get married? You can quote Dr. Pujari that it is you is equal to me. It can happen. So certain facts have to be told. It's very easy to do, but it is situation specific. That's why I said if you discuss even a single question, you will require 2 to 3 hours because every thing will have to be discussed from different angles.
And there are no real answers. So this is just to generate, a thought process. So with that, we'll move on. And what Sir was talking about, we're just going to cover. We move on to this final diagnosis, when you finally made that diagnosis. And again, another case very similar to what Dr. Ganga Kedkar sir just told us. So this is a 51-year-old male, married, very eminent advocate, partner in a well-renowned law firm with compatible symptoms for the past 7 months. He was seen by equally eminent physicians both in Mumbai and Delhi, but an exposure history was never taken, and so he was never tested. Yes, it was. I was referred for the first time. I remember that evening when I saw him, I went through his case, his papers, and stuff, and I realized he hadn't been tested. His wife, who is also a lawyer, was with him, and without dwelling on it too much, I did mention that, I would, among all the other things that I'm going to check for the opportunity, he certainly had a lot of things going on. But I said, I'm going to do an HIV test as well because some of your symptoms are compatible. And there were no questions at that time. There was no real discussion. Both of them were highly educated, or so it seems, and they didn't really, counter me or question me or whatever. The next day, I had the primary doctor call me and tell me that the referring physician called and said, this gentleman has tested positive. You asked for an HIV test. So what are we supposed to do now? So I said, and this was a very large tertiary care hospital in Mumbai, one of the most well-known. I said, can you call in the counselor? I'm at another hospital right now. I'll be coming there by the evening. He said, we don't have any such thing. So I said, all right. So I said, okay, then one of us has to counsel. So he said, you sent the test, madam, please, you counsel. So I said, all right, I'll come in and counsel. So I went in there, and like we have counseled other patients in the past over so many years, I started and initiated a conversation with this very well, educated gentleman, clearly at, the highest echelons of society and stuff. And he heard me out. Exactly these words: chronic disease, completely treatable, not a problem. Just get you sorted with these infections and then, take you on the path to recovery. Nothing to really worry about. And he heard me out. And at the end of it, he said, I'm really grateful to you. I've been suffering for the past 8 months. You came in here and made this diagnosis. But I'm afraid I can't live with it. You don't know what kind of social stigma I will suffer. So you can leave the room and I'm going to leap out of that window. And these were his words to me, after the entire counseling session, which took about 15 or 20 minutes. The long and short of it is, of course, I sat there trying to convince him. His wife was outside the room wondering what was happening because I had to initially talk to him and let him tell his wife about it. But at the end of it, I had to inform the hospital CEO. I had to get security because even if this was an impulsive response and all, it was not something that I could, walk out on. And when I sort of spoke to him in greater detail and everything, and, I said, where's this reaction coming from? I'm telling you, it's like you have diabetes, you are hypertensive, you have all these other chronic diseases. This is going to be as simple as that in the long run. I understand the burden of dealing with it, the diagnosis right now, but that is where it's going to be. And he said, have you seen the movie Philadelphia? That is my life. I'm Tom Hanks in that movie now. I said, do you realize that that was 1980s? You know, for those of you who haven't seen Philadelphia, Tom Hanks was a lawyer who acquired HIV in the 1980s. He was a gay man, and he was actually asked to leave his law firm once the diagnosis was made. And the movie was about the early stigma associated with HIV. And I was surprised that this gentleman, you know, coming from where he did in society, said, 1981, 2024, nothing has changed. Maybe it has for you on the medical side, on the scientific side, but when it comes to society, when it comes to acceptance, even in, you know, the largest law firms or the largest multinationals, the perception of HIV certainly hasn't changed. So this man, on further probing, accepted to being bisexual, but has kept his diagnosis. He's been so insanely secretive about his diagnosis. And I wouldn't say that all our patients are like that, but we certainly do come across those who, you know, are almost paranoid about their diagnosis. Every time they come to you, they ask all your residents to leave the room and they want to sit with you alone and things like that. So clearly it's a much larger social stigma than we, you know, care to admit still.
Second issue was bisexuality. No? Now, what is the patient trying to imagine within his mind? People are going to ask, I am HIV infected. They will say, why you have got this infection? Then I will have to tell them I am bisexual. No, so there are linked things that are happening. Very easy to segregate, to handle appropriately with the right kind of messaging. The third thing, which perhaps we need to convince him, because the fear he is clearly pointing out. No, it was one unexpected diagnosis for him. Second thing, which perhaps is known at this juncture, that he is linking because he feels people will come to know I am HIV infected even if I hide my information. Whether through blood test, whether through symptoms and signs that perhaps people will be able to note. So to me, this was a very simple situation. It was very focused. It would not take more than 15 to 20 minutes to, what would I say, reduce the toxicity, mental toxicity in his mind. Because he is the only thing which I would advise in these cases. The skill lies in one thing, to assess whether the messages that you are giving are comprehended by the patient. You should not be.
Mike. You're absolutely right. Okay.
No, so one
Now, so that's what I'm coming to those questions, right? Uh, Someone gives her a mark.
One simple thing that I used to do was I used to tell the person that I will not, what we will do is today we will do testing of both of you. No, that you are being tested, both of you are being tested, because there is a fear. People, no, they have a smart way of throwing the guilt, especially among males. No, the woman would be found positive because she is pregnant. This fellow, the moment he knows that she was tested earlier, he starts accusing, you acquired it and then you gave it to me because you were tested 7 days before, and then things happening like this. What is most important is you have to convince, it is better to do testing of the couple at one time. And then when you disclose first to the person who was not known to be positive, no? And then bring in this gentleman and talk to them together. Otherwise, it's easy. I don't know, but I would have loved to speak more, but it is not very difficult, but it needs skills, communication
So
skills.
it's not difficult. We're not, contesting that. But the point is, as ID physicians particularly, most of our references are already patients who, have been diagnosed, dealt with in a way that was inappropriate. So many of our patients who have been diagnosed by the primary consultant will go and tell their children, go and tell their family before telling the patient, and then you are left there with a family, as Dr. Tanu says, saying, please don't tell my elderly parent what their diagnosis is, you know.
So
And
just a question is that if he doesn't want to tell his wife, does the law mandate that the wife should be told?
eventually, yes, but you have to try. Ultimately, you're obliged to tell. I'll come to that a little later also. So there are relatives who want to keep the diagnosis from the elderly. I've also had, orphans or, children who are brought up HIV positive. In their teenage years, they default on treatment, and that's because their parents, aunts, uncles don't want to tell them about their diagnosis. And it takes a lot of counseling and a lot of convincing that, you can't expect this individual to go through their life on treatment without disclosing to them what their disease is. So I accept that it's doable and it has to be done, but yes, we still face the situations and we face.
Yeah, so this issue about
Sir wants to say something.
No, no, he was asking me. See, there are certain situations. One thing before that, there are these situations for us where, as Sanjay said, we are the secondary reference. The patient is diagnosed, and as we say in the meetings, आभार प्रदर्शनाचं काम असतं ना, त्याला जाऊन सांगा. That is left to us as ID consultants or HIV physicians. The situations like this, that there is a report, either no one knows, or the person doesn't know, everyone else knows, or the person doesn't know, or kind of things. And you have to understand that situation, what it is. The situations in case of a child would be different. The situation in case of a pregnant woman would be different. Case in someone who is, say, called multiple sexual partners and knows about the risks is a different kind of a thing. One of the quotes, one of my first counselor trainer told me was, you mentioned so often that they were well educated, well educated. The first sentence he told me that educated is not wise and uneducated is not idiot. It's all up to our essential skills, how to tell the people in their situations to do that. Having said that, coming to the adolescents, there are situations like this, like so many children by the age of even 17, 18, they have not been told by their parents. We have talked to so many, and we have also published a small book, Kalda Teva, that we came to know. And unanimously, all children who had come to know about their status accidentally have said that it would have been better if you were told by the age of 10, 12, whatever. The way we would have understood, if we were explained, we would have been better off. Because we are facing the stigma, we are facing discrimination, we were having problems at home because one child is being treated differently than the other, etc. But if we had known, we would have dealt with the things quite nicely. There were some other children who have said that parents felt that if we came to know, we would be under stress. We knew about it because we were going to the ART center. We knew about the things. We were taking care and feigning that we don't know because our parents may feel bad. So the children also react to these kind of situations very differently. But what we have said and we should follow is child has a right to know. Same is true with everyone, whether the law mandates or not. If a test has come positive, as regards your disclosure in post-test counseling, the first right to know about the diagnosis is of the person. So we should discuss that in that kind of a situation with that person, then talk about that. Even if you are legally mandated, it doesn't mean that you have to go immediately out and tell the spouse. You can always say that, see, you have got it. I am not interested in that much knowing how you got it. But if it is sexually transmitted, one of your partners has given you, or you have transmitted it to one of your partners. If there is only one partner, you may have acquired it differently. So I would like to test your partner or partners because someone of them has given it to you. You may have transmitted to someone else. So that is the way I think we should share the responsibility of disclosure with the person. Take time. Again, as a in lighter vein, I was insisting about one person that he should tell his spouse. And as Sama Dama Danda Bheda, last I told him that next time you come, I'm not going to give you any medicines or prescription unless you tell your wife. You have to get her. The next time he came with a woman, we disclosed and we tested her and kind of a thing. And after a few months, his wife came with a positive report. And I asked him, who was that lady? So he said, मैंने एक को 50 रुपए दे दिया, बोला चलो सर के सामने बैठो, वो बताएगा, वो बोल दो, सुनो और जाओ. So I think things like this happen. So this counseling kind of a thing, as Ganga Kedkar sir is saying, is a huge topic. We have to do situation wise because it is not something that there are multiple choice questions and answers to this. How best is the person? Select A, B, C, D. It's not like that. The person on the field, person in the situation. Now, for a sex worker, the counseling would be different. For a transgender, the counseling would be different. For a pregnant woman, the counseling could be different. And we had designed a thing called as the disclosure graph. And we had found that in case of women, the number of people knowing about her status is always 3 or 4 times more than in case of men. Because they have more control over their disclosure because they decide whom to tell. But in case of a woman, everyone else knows about her status except her.
So just recently, sir, I had a reference from the ICU in a patient who was diagnosed community acquired pneumonia and HIV turned out to be positive. When I reached the ICU, the patient and his wife were fighting. Closure was done to the patient and his wife, and they were just fighting. When I went there, I realized that they had 2 kids. He has had zoster around 7 or 8 years ago, and they have 2 children, both under the age of 5. And I was trying to do some sort of post-test counseling, and it was just not working out. And then I did not I mean, I had to talk about testing the children, and they said, absolutely not. The children are fine. They're not, there's no question of testing them. And his wife said that I'll see if I want to get tested. If I don't feel okay, then I'll see. I'm going to my MICA. And she just walked off. The man said, I don't believe your report. This is all fake. And then he discharged.
एकच सांगतो आता common themes which you can use, common things that common approaches that one can use. One of the best things if you want to buy time, is to say, "Acha, this test was done outside. Let us do it ourselves," and then go towards saying, "Do you think that the test could have been correct or not correct?" No, so he speaks his mind. Because you have to bring that risk perception to the right level. You also know this is one test that you have done. We will repeat it. My hospital is the best. No, that's something which we can always boast of. No. Now, second thing which we have to remember, handling children is far more difficult disclosure related stuff. The sole reason is it has to be age adjusted, the comprehension adjusted counseling that you have to do with children, because their reactions can be extremely difficult to handle. They may not do it in front of you, but their scholastic performances, their interaction with the family, everything is going to change. And one of the reasons why there is delayed disclosure is because the parents are scared. They are worried about a question, how did you get it? No? So you have as much time to actually spend with the parents. When such question comes, how will you deal with it? And then move on.
Okay. So moving on to the other U equals U in our country. And I think all of us deal with this. Yeah. So unwed equals unacceptable. I think all of us have dealt with this. Sort of young adolescents, young adults with TB meningitis who are on treatment on steroids, Cushingoid. The first thing, as soon as they're slightly stable, the parents will start asking you, can I get her married? Can I get him married? That is a constant sort of thing that goes on. So let's take this one case to stimulate that discussion. So this is a 23-year-old orphan brought up by her grandparents, HIV positive since birth, virologically suppressed on antiretroviral. At some point, the grandfather, after several years of sort of following up with me in the OPD and all, says that, we're growing old. We don't know how long we'll be around. She's 23 years now. She's educated. We want to get her married. So again, it's that discussion that you always have with them that, yes, of course, she can get married. She can have a normal life. But please disclose this to the family, to the boy's family. And of course, as much as you're doing what you're supposed to do, you understand how difficult this is, how practically impossible this is in an arranged marriage system. And immediately they'll tell you that this is not feasible. They will refuse, but they'll go out and talk in the market, and that will be the end of, our entire reputation and my daughter's marriage prospects and whatever. So this was another unsuccessful attempt to counsel them to divulge status. And she stopped taking her ART peri-marriage because she was worried about somebody finding out at her in-laws' place. 11 months post her marriage, she was admitted elsewhere. They diagnosed PCP. And even when she was in the hospital on oxygen, requiring oxygen in a critical state, nobody informed them that she's HIV positive. Eventually, a doctor in that hospital suspecting PCP, diagnosing PCP, tested HIV, and the in-laws were informed. That's when the grandparents told the in-laws that she was under my treatment for so many years. And I had this irate set of in-laws in my OPD, really upset and angry that how did you know and let her get married? She has ruined my son's life. She has, brought this into our house. And of course, we all understand that we have done what we can as, to try to counsel the the parents, the relatives, whatever it is. And ultimately, you can't stop them. But the truth of the matter is, as an HIV physician, you have to double up as a matchmaker sometimes, as a marriage counselor sometimes, and as moral police sometimes. And it's really overwhelming when you have to sort of deal with such situations. And again, I mean, I know sir will say it's very simple, but when you're faced with it, you can. No, of course you can tell them, but sir, it's not about, it's not just about your son is not at risk. Now, of course, he is at risk because she's failed on treatment and whatever. But it's not just about that. It's about how did you let this happen, in terms of a social.
Yeah. No, why say that? That's not our problem.
Can I?
That's not our concern.
Yeah, can I? Yeah. So
We always tell them that please bring your spouse to us. Whoever you want to get married,
Yeah,
bring them
so-
here, we'll talk to them.
That's
yeah, so few quick comments I want to make.
Sure.
First of all, when we do case presentations in conferences, usually those are rare cases we present. This is what feeling I have with this. This is not very common. I mean, it is common, but the situations that you said, I mean, I've particularly the relatives coming to me and saying that, don't tell the patient. I just tell them that, I will only talk to the patient. Patient is sitting in the waiting room and you have to sit out, and then I disclose it to the patient. I've had instances in my clinic where the relatives have taken the patient back to some other doctor.
Similar.
Yeah.
Similar, sir. They
So
stopped
then I have
coming to
no
me
problems
because I
with that.
insisted on
But
telling
this
them.
is the way I work. And that is in this situation. Yeah. In this situation. Yeah. In this situation, I agree that the HIV physician over a period of years is evolving into a matchmaker and a marriage counselor also. But what happens is if you had a if you have a boy who is positive, and usually the pressure on the boy is so huge, suppose, and they want to get him arranged marriage, I usually ask the parents that suppose you want to hide the status and marry, but suppose what happens if it was the other way around? Would you have agreed to hide the status? How would you have felt if somebody would have hid the status and got married to you? And somehow this appeals to many people. Then I've had many instances where people feel that no, it's not right to hide the status, and this is something I would say 90% of my, because once you just explain to them the reversal, the same thing I use for husband and wife. The husband doesn't want to tell the wife. I said, suppose you reverse it. If the wife would have, you know, hid it from you, how would you have felt? Most of the times this works. I'm not saying always it works. I've had patients still in my clinic, 18 years, wife doesn't know patient is HIV positive. We can't do anything about it actually. We are not going to go to the patient's house and in spite of counseling and everything to inform the wife that your husband is HIV positive. You can take reasonable efforts to do so, ask the patient to bring the wife, etc. So I think now then the second step is, okay, if you agree that we don't want to hide the status, and then what are the options? So the option is, one option is, of course, you can have positive marriage things. I think Dr. Chaugule, matrimonial, there's HIVSathi.com, positivesathi.com. Yeah.
This is a
So
BMC
matrimonial
holding
Mela.
matrimonial Mela for HIV positive individuals. Now, I want your opinion on that. But on one hand, we're telling them you are no different.
Correct. So
Yeah.
then I was going to complete it.
Sorry.
So one of the options is this. The other option, I very jestful, with long-term patients of mine, young patients, I'm telling you, fall in love. You see, find a girl, fall in love, tell her about your HIV status. And most of the times I have seen, in love, in love marriage, it doesn't matter. HIV doesn't matter. Now, arranged marriage is a problem.
But the problem is you can't fall in love. प्यार हुआ होता नहीं है, something like. Now, yeah. So now I have a database, and I have basically also given options. But our society cultural context is very, very peculiar. So when I gave one option, I gave the number, consent, and everything is there. And then they say, "वो हमारी जात की नहीं है." So I said, "Come on, we can't really match everything." This is where we have given you, and we are working on it, and we are giving you. And then there are instances where they say, "अरे ती मुलगी शिकलेली नाही आहे." Come on, man. I mean, we are trying. So this happens. We do work on it. Right now I'm working on one matchmake. Over the last one.
We have a large database at Prayas. Large database. We have had enough marriages, arranged love marriages, everything. We have conducted workshops for adolescents over a period of last 10, 11 years, more than 1,000 children. Everyone now knows that they are not going to get married unless they disclose. So first thing is disclosure, but then there are positive marriages, positive negative marriages, negative children, and all kinds of things. The best thing happens is love marriages, but the first thing they do is disclose. As soon as they feel that they are in some kind of intimate relationship, not just friendship, but intimate relationship, they disclose. If they want to get married, we tell them that come to us, we will explain. First thing, even if there are positive marriages, if we are suggesting something, we ensure that their health is good. They are not defaulting, they are not failing regimens. Because there was one marriage where the marriage was arranged, and on the day of marriage, the person was admitted with cryptococcal meningitis treatment failure in Pune hospital. So I said, like, what's the hurry here? You get better and then get married. Na? So these kind of things happen, but unwed is not unwanted, because many of them know that in Indian society, getting married actually to a person whom you would have really liked to get married to is very difficult otherwise also. So basically thing is what's wrong, because there is so much of kind of our society, रंग कसा आहे, शिक्षण किती आहे, उंची किती आहे, मंगळ आहे का नाही, जात आहे का नाही. Just like Sanjay said, I had a lady who came to me who said that we want a Brahmin positive child from Raipur area of Madhya Pradesh for my daughter. I said, now I am not going to go around with a Cinderella boot finding out a pair for you. You have got already one problem, HIV, and you still want to have this kind of super selection for your spouse. It's not possible. If you don't want to get married, don't get married. It's your problem. But stay unmarried. That's okay. It doesn't matter. But
Excuse me. I will talk a little bit. आम्ही मराठीतच बोलतो. इचलकरंजी मध्ये माई आधार केंद्र एक संस्था आहे आमची डॉक्टरांची. जवळजवळ गेली 30 वर्षे काम करतोय. आमचा अनुभव आहे की तिथं काउन्सिलिंग सेंटर ॲज वेल ॲज आता मॅरेज ब्युरो सुद्धा आहे आमच्याकडे. गेल्या 25 वर्षामध्ये जवळजवळ 100 लोकांची लग्न आम्ही केली. दरवर्षी जवळजवळ 50 ते 80 ते 100 लोक तिथं मॅरेज ब्युरोसाठी येतात ऑल ओव्हर महाराष्ट्रातले. आमचा असा अनुभव आहे की आता हा जो विषय चालू आहे की काउन्सिलिंग सांगायचं कसं, प्री पोस्ट, त्याच्या बाबतीत आम्ही भरपूर काम केलंय. माझं तर असं मत आहे की याला स्किल पाहिजे. तुम्हाला फेस रिडिंग जमलं पाहिजे की पुढच्या व्यक्तीला काय पाहिजे आणि काय नाही. हे जर तुम्हाला कळत असेल आणि जवळ कळलं तर ते लवकर तुम्ही त्यांना समजावून सांगू शकता. आणि आम्हाला तर असे काही अडचण फारशी आली नाही, कुणी परत गेलं नाही किंवा परत आला नाही असं झालं नाही. प्रत्येकाला आम्ही 1-2 दिवसात किंवा 3 दिवसामध्ये टेस्ट कशी करायची, का करायची. आता नानाखेडकर सरांनी सांगितलं, संजय पुजारी सरांनी पण सांगितलं की तुमच्याकडे स्किल पाहिजे, तुमच्याकडं तुमचा विश्वास तुमच्यावरती पाहिजे. आणि येणाऱ्या व्यक्तीला असं वाटतो येतोय तुमच्याकडे कशासाठी की बाबा इथं काहीतरी आम्हाला माहिती मिळेल चांगली. आणि ती माहिती मिळाली तर त्या प्रमाणात टेस्ट करायला तयार होतात ते लोक. होत नाहीत असं होत नाहीये. बऱ्याच वेळा आता त्या स्लाइड्समध्ये तुमच्या याच्यामध्ये मी बघितलं की बरेच प्रश्न आहेत तुमची. हे हे कसं करायचं, याच्यात वेळ किती जाणार, ही पूर्वी प्रॉब्लेम होता 2010 पर्यंत. आता 2010 नंतर एवढा मोठा प्रॉब्लेम नाही, तर आता इतके इझी झाले की कुणी आता नाही म्हणत नाहीये. मग वेगवेगळ्या क्षेत्रातले लोक आहेत, पुजारी आहेत, डॉक्टर्स आहेत, मग उद्योगधंदेवाले लोक आहेत, खालच्या वर्गातले लोक आहेत, ते सगळ्या लोकांना जर तुम्ही रेग्युलर तुमचं काउन्सिलिंग सेंटर जर असेल तर त्या ठिकाणी तुमच्याकडे जवळजवळ 6-7 काउन्सिलर आहेत आमच्याकडं आणि त्या काउन्सिलर तेही डॉक्टर्स आहेत. परंतु त्यामुळं कसं होतं की ते ज्याच्या त्याच्या ओळखीने किंवा ज्याच्या त्याच्या माहितीप्रमाणे थोडा स्वतःचे प्रश्न तर घेऊन येतातच, परंतु ते व्यवस्थित त्यांना जर समजावून आपण सांगितलं की तर ते तयार होतात, टेस्टिंगलाही तयार होतात. शेवटी प्री टेस्ट केलं तरी पोस्ट टेस्टिंगला त्याला यायलाच पाहिजे.
हो सर.
नुसतं प्री टेस्टिंग करून काहीच होणार नाही. त्याला प्री टेस्टिंग करताना सुरुवातीला समजावून सांगून विश्वासात घेऊन त्याला बाबा आपण कशासाठी आपण टेस्ट करतोय, फक्त HIV साठीच करत नाहीये, तुला दुसरे आजार आहेत काय, दुसरं आणि काय त्यातून निघतंय का, हे बघण्यासाठी करायला पाहिजे. हे आम्ही त्यांना समजावून सांगतो. तयार होतात. आल्यानंतर मग ते मग मिसेसची तपासणी, मुलांची तपासणी, जर पॉझिटिव्ह आला तर. नाही आला तर प्रश्नच मिटतोय. परंतु त्याला शंका का आली हे विचारायला लागतंय. जसं आता पॉझिटिव्ह साठी नुसते येतात तसे नाही. आता बऱ्याच लोकांना नसतंय आजार, परंतु ते लोक येतात की बाबा मला पॉझिटिव्ह सारखी टेस्ट करा, वर्षाला टेस्ट करा, 10 वेळा टेस्ट करणारे लोक पण येतात. असे पण आहेत. त्या लोकांना पण काउन्सिलिंग करावं लागतं. तरी सुद्धा आमच्याकडे असे ह्या पद्धतीचे लोक येतात. त्यांना आम्हाला जवळजवळ 1-1 वर्ष लागलं त्यांना थांबवायला.
थँक्यू
दर
सर.
2 महिन्याला येणार तो मला बाबा टेस्ट पॉझिटिव्ह मला वाटते, कारण कुठेतरी त्याचा संबंध आलेला असतो, गेलेला असतो, असं त्यांना शंका येते. आपणाला सायन्सला माहिती आहे की कुणालाही बाबा हे प्रत्येक पेशंटला बाहेरच्या व्यक्तीकडून होईलच असं काय नाही आहे. हे पण आपण त्यांना समजावून सांगावं लागतंय. या बऱ्याचशा गोष्टी आहेत आणि या पद्धतीनं जर काउन्सिलिंगचा आता मोठा इश्यू आता तर नाही आहे, हा पूर्वी होता. आता अलीकडे इझिली तयार होतात लोक आणि टेस्टिंगलाही तयार होतात. फक्त आपल्याकडे स्किल पाहिजे की त्या माणसाला आपण विश्वासात कसं घ्यायचं आणि ते कसं करायचं हे करून
Very
घेतलं
true.
पाहिजे.
Thank you for
थँक्यू.
explaining. I think in the interest of time, I'll go through the next case very quickly. So this is basically a patient in 2000. I think we'll take questions, I mean, informally during tea or something. This is a 19-year-old girl who had presented to us with TB pleural effusion in 2016, and she tested HIV-1 positive at the time. She completed ATT and she was on TDF 3TC efavirenz at the time. Since then, she's fully adherent, she's virologically suppressed, and she's married her partner who she was with even at the time. And he has been seronegative since then till now. And they got married in 2019. And it's 2024, and she's come to me now with having had 6 failed IUI attempts and 1 failed ICSI attempt over the past 2 years. They've been trying to get pregnant. She's financially depleted and emotionally disturbed. And she sort of reads about this U equals U. And she asks me that, why can't she conceive naturally? She's had a steady partner. She's married him. He undergoes 6 monthly or every year HIV tests, even though they have been having protected sex, just out of maybe some sort of fear. So why can't she conceive naturally? So can she conceive naturally? Can I say, yes, you can go ahead for it? We had a long conversation about this after Pujari sir's lecture. What is the risk to her husband if they have unprotected sex, and does he need PrEP? If she is virologically suppressed, I said, no, he doesn't. Then she asked that if all the data now is to do with the newer drugs, does she need to change her regimen? So that was a question that I wanted to ask, that if she's on efavirenz based treatment, she has been on that since 2016, she's virologically suppressed, no issues at all. Do we need to change her to dolutegravir before she conceives, since she's not conceived yet? So we have that time. So should we change her, sir?
So I think from the data of the studies that I showed you, it's quite clear that the benefit in terms of adverse pregnancy outcomes, etc., as well as neonatal mortality favors DTG and TAP. So if there is a possibility that since they have been trying for past 2 years, they can wait
Yes.
for another 3 months
Yes.
to just switch them. or maybe even after switching to TAF, FTC, DTG, at 4 weeks, you can repeat the viral load. And if it is undetectable, they can have natural conceptions.
And sorry, and
One thing which you must remember, which must be discussed in marriages that you arrange or through your support, you have to discuss the risk that if any one of them had perhaps tuberculosis or during adolescence when even primary that infection late LTBI can occur, then your risk increases like this. Because you have TB endometrium, you will never find that even if you put in even XC that you are saying has failed, if you ask the infertility expert, let's say he or she will say, I need to do it 4 times. No, my risk is, my success rate is around 25 to 40% at each XC attempt. What is essentially going to happen is the eggs are formed, but they cannot anchor the endometrium, and that is because of TB. So you have to ensure that you have dealt with this issue. When you look at it, changing ART is not going to make any difference. I'm sorry, to my mind.
Why in the first place she was on this
so that
IUI attempts and
so that is
exceeds
the question which I wanted to actually ask Dr. Angam.
Yeah, considering the history, she had pulmonary tuberculosis, as Sir has rightly pointed out. With so many attempts, she has failed. So we need to see the health of the endometrium.
So she was advised
Yeah, she
IUI
was
out
advised
that
IUI
you
because-
cannot conceive naturally, you
yeah.
have to do IUI.
Yeah. So that is now with the with patients on combined retroviral therapy, we can go ahead and try naturally if her viral load is suppressed. So we don't have to go and in for any of these artificial reproductive technologies in this case. As far as what Sir has pointed out, probably because of the pulmonary tuberculosis, she could be having some pathology because of which her attempts to conceive with all these have failed. So evaluation of the endometrium is important. And now we have PRP and all these growth factors to improve the endometrium, provided she's not having any active disease there. And as far as the dolutegravir is concerned, there is a little thing about neural tube defect. So before pregnancy, say about 3 months before, if we start on folic acid, I think that is also an overcome.
No, sir, this is an exceptional sort of.
She may not be maybe endometrium or any other issue. The question is that now she's financially depleted. She said, if I'm not going to get pregnant or if there's something else, treatment that I require, that's a different thing. But since the past 2 years, she has spent a lot of money on IUI out of the pride that she might transmit the virus to her husband if they try and conceive next. So my point is that
So, sir,
no, so the case is not about getting a child or something. Don't tell her that you are virologically suppressed. Have normal sex. If you get pregnant, okay. Otherwise, no problem.
I think that what we're straying from what the issue is. We want to drive home the point that regardless of what we tell them, most gynecologists out there convince them against having a natural conception. And that has happened to us over and over. So we're discussing all these issues in a small forum here among HIV physicians. But we need to take this beyond ourselves to other clinicians in other specialties, because no matter what we tell the patients, they ultimately undergo all these procedures because most gynecologists out there, unlike Dr. here, will convince them otherwise.
So my experience was
One positive thing for all HIV physicians is the trust that they build with you while they disclose their HIV status, or they know you know their HIV status. Even for any health reason, they will ask you, can you manage yourself? No, no decision, health decision is generally decided by themselves unless it is vetted by you. So that's a positive side of this thing, wherein sometimes you become uncomfortable because you are not competent in that area. You tend to be worried.
This is
But
an area
this
we also
particular
look, yeah.
this particular case is clearly infertility. No, 6 IUI attempts, 1 ICSI, they have already passed 6 months. No? So where is the issue? They have to go for IVF.
The other thing could be that she's so stressed out following up with IVFs and IUI, every alternate day monitoring. There's a lot of stress happening inside and the financial depletion. So the moment you close the file and say, okay, this is the end and I'm not going to try anymore after this, many a times they end up conceiving themselves naturally.
Absolutely.
So probably, this could be the stress that is built up from cycle after cycle of failure. That also can cause you of confidence about, you equals you, or how
Allowing natural conception, natural
the
labor.
topic of HIV is not really covered.
Absolutely. That's what we're trying to
There are
drive
so
it
many
over
other
here.
topics which are covered, but this is not. And today it's a masterclass for me, to attend this.
One of the things that happens is you identify your own IVF person. No, and then you try to work through that person. Otherwise, people don't do it. That is one factor. Refusals are common. Second thing that happens is the moment they know that this person is HIV positive, they will charge more. So you have to work out with your referral doctor what could be the cost per IVF. No, it can't come below 40,000 per. It's for ICSI. Less than 40,000 is not feasible. So for every cycle, at least you fix around 40 to 50. Because I know, no, but there are, well, because some of you, like I had 2 referral points. Now, I had started doing it in 95 for discordant couples, sperm wash, and those days were of sperm wash and then try doing IVF. I had certain points. I won't need to take their names. It's not very fair because they charge more for others. But for HIV positive, once you say they charge this much, that information is damaging for them professionally.
Okay, so I think we've run out of time, but I'm just going to leave you all with these thoughts because this entire talk was actually for us to think about moving out of our comfort zones and doing things a little differently as physicians. So you have had the MSM sort of population coming. So I've a lot of people under the effect of hallucinogens, multiple sexual partners at one time, chemsex and we're not so far from that also, sir, but and there's at least in Mumbai, I mean, I'm sure there is enough even in metro cities like Pune and stuff, but there are a lot of people who want to tell you a lot of very explicit details. And yes, it's culturally, it's difficult for all of us, but I definitely say that, among my residents, it creates a lot of discomfort in an OPD. I see people getting up, walking around, putting their mask on, turning around. And I think this is something that we all have to, sort of, get over.
Yeah, I completely agree. Let's not use the words like this, but I think I would ask her also, the ones who are running helplines and online sexual counseling, sexual health counseling, we are discussing for last 2 months or 3 months. Sometimes the person who is listening, one's own perceptions, backgrounds, social backgrounds, etc., But we have to be trained to do that, because so often the calls that are coming on sexual health helplines, the other person is asking or talking just because the person wants to do something. It's not about psychological health or something. The counselor understands that that person is, say, masturbating or something like that. The thing makes you uncomfortable, and this kind of listening to these histories, deciding your boundaries, telling very frankly that this is not on, it is making me uncomfortable, etc., etc. This is now becoming a part of taking sexual history, whether online or offline. And I think a lot of it will have to go into training of counseling, along with all the sexual preferences, sexual orientation, sexuality, and everything. And I think these are the new things that are coming up, especially because a lot of things are happening online, including counselings. And
Can I?
Knowing about these issues. Now, what does unusual you? That you listen to some information which you did not want to listen, right? What is more important is you should have a icon, sir. You should have that communication skill to ensure that the topic is diverted in towards the right direction and bring him back to the line. The people would like to talk, people would not like to talk. You will get all kinds of people all across. No, so you should be able to handle that conversation in a manner that they don't describe who they had. To be honest, no, when in 1992, 93, I was in Bombay, Institute of Immunohematology. I had the first cohort of HIV infected people. Most of the people who used to come were those who were partners of film stars. Now, does this mean I ever asked who and how and what? They wanted to tell what happened. Do you have to put a boundary? No. So basically, it is what you want to hear, and you should not judge them. That's another thing.
Here, I would like to mention since 2003, 2004, under guidance of Dr. Ganga Khedkar, Dr. Sanjay Pujari, and Dr. Vinay Kulkarni, myself and Dr. Madhu, we have been working on HIV management along with HIV-related counseling, which starts from pre-test counseling that you had mentioned in the right first slide. And then pre-test counseling, if the counselor is available, definitely yes, the counselor should do. Otherwise, it is role of prescriber to do that pre-test counseling role. If once the test comes positive or negative, accordingly, it will go as supportive counseling or preventive counseling. Then once the person has decided about marriage, so to talk about the HIV status and implying the legal aspect of that test used to be the next step. Once married, then sexual partner related counseling, exposure to unknown married partner has been another thing. Then during pregnancy and disclosure to child with the right to know about HIV status, all these things we have been like through Mukta Charitable Foundation, we have been very skillfully and scientifically being able to manage with their guidance. Yes, and I would request sir to arrange for one session for this next time.
Definitely. We now come to the last session. Apologies, sir. What? Please,